Check, check. Is that the music? Check 1 2. Check, check. Okay. I just want to make sure it wasn't reverb from the mic.
They won't be way back here. In general, I want people talking from here.
Now it's on. I had
Right, so if you're virtual,
all
you're
that
gonna see
muted
the
for the-
TFT right there, you're gonna
Oh,
kinda
I'm
stand
sorry.
right there,
Okay,
and one of us will switch from back.
so he should hear it now.
Yeah, you can
so I'm
use the
gonna be
clicker for that.
standing there?
You can, yeah, so we'll have a mic for you for that. Right.
Yeah, you can hear everything. Perfect.
And here's mic 1. That's the last mic.
Perfect, cool, awesome. So
Can you hear that, Isla?
just make sure
I
that-
hear it and I
done.
see him typing, so I'm sure he hears it too.
Absolutely, you'll
Yep, he said
it's
good.
gonna work after.
Perfect.
The first, that presentation is gonna go the Netflix intro. Todd's gonna
Are we
introduce
getting a
you.
video feed on the stream, or are we good with Zoom? We'll wrap Zoom?
Yeah, Zoom is working. You can see everything, Isla. On Zoom, just Zoom.
Oh, just Zoom, yes. Zoom looks good. Zoom works. I
Okay.
see the screen. I see James. I see everyone. Spencer.
Perfect.
That's on
Not
the Zoom,
Spencer.
is that correct?
Yes, correct. On the Zoom. Zoom's all working.
You have a dual feed with
Yep.
that, right, Spence? That's the HDMI going in.
Push it.
That's the HDMI, yeah.
All right, we're good.
So now just the stream.
All right, streamer, okay, can we get off Zoom then?
Yes, yeah. I'll just Isla, do you have the ability to mute me and everything? Do you have total control over?
I do. I can mute you completely.
Okay, I'll just leave Zoom as it is right now.
Awesome. Our first, sorry, hold on. Let me just look at the agenda. Our first virtual speaker is at 9 o'clock.
Oh. So it's the first one?
Hold on. Let me just open the agenda one second, confirm. Yeah.
Okay, so do we have a co-speaker for that one?
So, pardon, I misspoke. I misspoke, pardon. The first 9 a.m. session is going to be Todd, Rodrigo, and Jose Campos, followed by a 9:22 session. This gentleman is going to be in the waiting room at 9 for the 9:22. So it's the second presentation he's going to be, Dr. Simon Eaton from UK.
Okay.
Yep, so at 9:22, he'll go live, but he'll be with me starting at 9.
Copy, we got that. So he'll be on standby. And he has a co-presenter, is that correct or no? Yes, he does.
Correct, Dr. Zani and a moderator, Dr. Osley.
Okay, so they should be up here.
Correct.
So he knows. Okay, good. All right, for Zoom, let's wrap Zoom, make sure our stream is working, because that's the most important thing right now.
Exactly, and then just stream and YouTube.
So we're live.
Well, YouTube, you got. I have nothing to do with YouTube anymore, because you have your own channel.
Okay. So I need to get the link from Matt then. Hold on.
But priority right now is the stream. YouTube is our fallback, so I'd rather get the stream like solid.
Okay, deal.
Stream solid.
Okay, deal. Oh, hold on, I'm gonna do the reverb thing. Hold on, stop.
So what we need to do, maybe let's move this screen slightly left so we get the entire screen in, if you don't mind.
2398, correct?
2398.
Copy, all right.
Do you want to time code these cams? Do you have time?
That's what I'm doing, that's exactly what I'm doing. I just wanna make sure we're on the right track here, perfect.
Hey, Myron. Yeah. Are you in the middle of something, or do I? You tell me if you need more time. I don't want to. If you're in a task, I don't want to.
I'm just trying to get my mind around switching. It's a little different than what we've done before. It's cool though, but I'm just walking through it.
Okay.
What
No,
does it need?
I just want to stream test it. Is that
Stream is on.
okay?
That's how she was able to see it.
Oh, she can see
She
everything.
was able to see it. Now, we didn't do audio yet, but we were talking through the two mics.
I got it.
Yeah.
Is Isla still on?
So
Isla, you still there?
Yep, I'm still here.
Does everything look good on the stream?
Yes,
We could-
stream looks great. I see everything. I just muted it.
Okay, perfect.
how is your bandwidth?
Okay.
Yep, I just unmuted it. So, yep,
Okay, cool.
it's perfect.
I mean, it is 6:2. It says it's okay though. Everything's good. As long as
And just out of curiosity, are you guys using the Starlink thing, the bonded?
Yes, yes, we are.
Awesome,
So
good
we
to
have
know. That's great.
backups on backups.
Love it.
We just got to make sure.
And did you set up the clock that M asked for?
You should be fine. There should be that cord is fast.
Just a running clock?
Let me ask.
What happened?
Isla is asking if we set up the clock that M was asking for.
Is it a running clock just to show that it's not idle?
Do you have your mic?
Yes, yes.
That's what they mean? Okay.
Yes, give me a second.
All right.
A clock on.
I have a clock. I just need help setting it up. That's all.
We got it right now, Isla.
Thank you.
What was the clock?
The
Is that on?
iPad, it's
or is
nothing
that-
to do with the feed, it's just a countdown clock.
Okay.
Yeah, like we did before. Yes. So what I'd like to do is make sure this is charged. And then we just put a countdown clock on here.
Time goes connected to everything.
Thank you.
Awesome. Podium mic. Is podium mic working? Isla, do you hear the podium mic?
I do. Sounds good.
Awesome.
We can try our duet.
I don't think anyone wants to hear that. I don't think they're ready for that.
They were talking about music in between.
Yeah.
We're up, Chris.
There we go. Retro, right? We gotta go retro. Retro.
So we can put this on charge.
Myron, have you had a chance to look at the run of show and that PowerPoint breakdown?
Yes.
Awesome. And then we tested the videos within the PowerPoints. Do you guys want to test that again, just in case?
Yeah, we can test them.
Okay.
Yeah, I'm down to test. Yeah, that's cool.
Christian,
Yes.
can you bring up PowerPoint 1? In fact, what I'm going to do before PowerPoint 1 is let me bring
Yeah,
up
cut C, please.
PowerPoint 1? This.
the first PowerPoint. We just want to run through and let Isla hear the video.
Oh, yeah. We're gonna run through. Yeah, this is the first one here. So we'll go. Okay, here's the first video.
After years of debate, we finally have the largest randomized trial in children.
Okay, was that
Can
good?
you do that one more time with me muting Zoom and unmuting? One more time, please, Christian.
Yeah.
Okay, yep, no problem.
Go for it.
All right, here we go. Second time around.
After years of debate, we finally have the largest randomized trial in children addressing non-operative.
Oh, was that?
Perfect. Thank
Awesome.
you.
Okay, cool. And then we'll test out this one.
When facing a severely injured child, the question often arises, should we start chemical
Perfect.
Cool.
Here comes 3.
Would you still take a child with an appendiceal neuroendocrine tumor to a right and
Good. I just wanted to make sure that the sound was coming through and it was hooked up.
Yep.
But there's a million of those little clips in there, so that's perfect.
Gotcha. Perfect. All right.
And then the other thing, can you make sure that you can see the poll-only page with the results of the poll without the borders?
Yes. Let me go find M. She has the.
Okay.
I don't even care if it is.
You guys are at 8:31. If you need food, get it right now.
Copy. I'm going to start running the video in 10 minutes. We have the pre-run video, which is 18 minutes long.
Copy.
Oh, good point, Myron. Do you have you have all the commercials in that run of show and all the intros, the lower thirds, everything, right?
So let me make sure I have an 18-minute. Unless there was something added overnight, what I have is I have all the Netflix intros. I have 4 videos.
Perfect. That's it.
Okay, I have a pre-roll.
Yeah, what Carolyn did for you, Myron, is she stitched all the commercials together, so you just have to press play once.
Okay, copy.
Yep.
pulls up right now.
Awesome, thank you.
Hey, Isla, can you ask her a
Hey.
question? Isla, I have a question.
Mm-hmm.
How long do these presentations last? I have the clock up, so are they average 20, or how many minutes do you want me to put on those?
Let me just check, hold on. Looks like they range from, they range from 15 to 30 depending on, and everywhere in between. So they're, yeah, 15 to 30.
So will they let
On
us know, or
average.
is that on the run or show how long that is?
Yeah, it's column B.
All right, so it's as simple as putting the time we need and pushing play on our clock here. So,
Okay.
Christian, will you be aware of the time of the
Okay.
speakers?
So
Will you know
what
that?
we can do is, can you close out the other windows?
All right, you should get a run or show printed if you could.
So she wanted us to make sure that we could see the results without the tabs.
Oh, you know what you could do? You could. Two different windows. You could, yeah. Just make it a different window. Yeah.
There we go.
Oh, what does that look like on the conference, Myron?
Now, can we maximize it? We have to maximize it.
Oh, yeah.
There we go.
Oh. Very good.
Okay. Everybody good?
Perfect.
How's that look? That looks good?
Em, do you mind just pressing an answer just so we could see what the pie chart looks like? Pie graph?
Yeah. Hey,
Sorry.
Hey, could you press the submit real fast just to see the... Oh, so... Cool. How's that look, Isla?
Love it. Perfect. Love that.
Cool.
Cool.
Okay, all right.
Looks like we're tested. I will mute myself. We're ready to go. If you guys want to start playing the commercials or put the, yep, there you go. Love it. Thank you guys.
Okay.
Cool.
Do we have media and cams, guys?
are no strangers to firsts. Our pioneers traversed brave new worlds, and Cincinnati Children's freed the world of polio. Our engineering inspired others, and Cincinnati Children's created new treatments that changed the outcome for kids. Our state was the first to electrify cities. Now, Cincinnati Children's is lighting the way for advances in organ transplantation. Ohio gave birth to aviation, allowing kids like me from around the world to fly to Cincinnati Children's for care they can't receive anywhere else. Cincinnati is home to the first professional baseball team. Now, Cincinnati Children's is using game-changing proton therapy to cure cancer. Today is another first for Cincinnati Children's, for the Queen City, and for Ohio. Cincinnati Children's is proud to be the #1 children's hospital in the nation.
Welcome to Ann and Robert H. Lurie Children's Hospital of Chicago. Every aspect of our 23-story, state-of-the-art hospital was designed with kids in mind. An extraordinary place for healing and family-centered care, its flexible design and advanced technology enables our caregivers to provide superior care to the most critically ill children in Chicago and around the world. The second floor is also home to our Emergency Care Center, a state-of-the-art emergency room that sees more than 60,000 patients each year. Floors 3 through 8 are reserved for outpatient clinics, diagnostic testing, and procedural care. This includes our Chicago Institute for Fetal Health, one of only a few comprehensive fetal centers in the country, dedicated to the care of pregnant women with fetal complications. And our modern surgical suites, where we perform more pediatric operations than any other pediatric hospital in the state, using the most advanced techniques and minimally invasive approaches. As a tertiary and quaternary care hospital, Lurie Children's intensive care units care for the most critically ill and injured children and serve as a referral center for the community's hospitals whose patients require specialized, life-saving care. Our Center for Cancer and Blood Disorders offers the most comprehensive cancer care in the region. The space was designed to evolve to accommodate new technology and include special features to ensure the safety of our immunocompromised patients. On the top floor, you'll find our Cardiac Care Unit, one of the only pediatric units of its kind in the country. The enhanced model of care combines the technology and expertise of intensive care with pediatric cardiology to provide patients highly specialized care in the same unit for the duration of their hospital stay. This incredible building is one small reason Lurie Children's is the top pediatric hospital in Illinois, but it's the people inside that make it a truly special place for kids.
You're in clinic or rounding. You need a protocol, a technique refresher, or a contact number, but it's buried in your inbox, a desktop file, or that giant binder no one opens. Stay Current MD is your team's knowledge organized in one app. Protocols, guidelines, how-to videos, technique refreshers, even links, contact lists, and department updates, all searchable, all mobile. Join one of the fastest growing medical networks, trusted by over 18,000 medical professionals in the world's top hospitals, with nearly 1 million views and a 20% annual increase in hospital spaces. Evidence clearly shows that guideline adherence leads to better outcomes. And you're not just accessing your own team's content, You're joining a network of hospitals sharing best practices, each curating their own space, all in one place. This isn't another app you'll forget to open. It's built for what you actually need. Quick answer, smart teaching, and better team alignment. If you've ever said, why isn't this easier to find? This is the fix. Stay sharp, stay connected, stay current.
At Akron Children's, we know that childhood is precious. Every moment matters, every smile, every milestone. We strive to create a positive experience for every child, every parent, every step of the journey. Pediatric surgery is different. Children aren't just small adults. Their bodies are still growing. They have unique needs. Our pediatric surgeons are experts in delicate anatomy. They know how to use tools built for small spaces and techniques designed for growing kids. We plan care not just for today, but for the lifetime ahead. Surgical care at Akron Children's goes far beyond the operating room. We know that surgery can be scary, for kids and for parents. From the waiting room to the OR, our spaces are designed with kids in mind. Everyone on our surgical team is passionate about caring for kids and their families. Because surgery can feel overwhelming, we guide the process with comfort, communication, and trust. We talk with parents, we sit with kids, we explain things simply, we listen and reassure. Because when families feel seen and supported, healing begins. Our goal at Akron Children's is to get kids back to being kids, to give families peace of mind, and answer every request for more childhood please with everything we have. Every decision we make supports a child's growth, development, and future quality of life. Because we know every child has something special to share with the world, and we're honored to be part of their story. At Akron Children's, we're a pediatric surgery team that puts families first, and we're proud to help bring a little more childhood to every child we serve.
Some said Tiago had 1 week to live, but this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds, it's about changing them for all kidkind. Hope, care, cure. Seattle Children's.
Welcome to John R. Oshai Children's Hospital, a place of hope, healing, and miracles. Oshai Children's Hospital is one of only 43 standalone children's hospitals in the nation, and the only one of its kind in New York State. The only one. Why is that so important? Because our whole staff is specifically trained in and devoted to the care and treatment of children from conception to 21 years of age. Because the entire building has been designed with patient and family comfort as a top priority. And most importantly, because the best of the best practice here at Oshai Children's Hospital. As a teaching hospital for the Jacobs School of Medicine and Biomedical Sciences and the University at Buffalo, Our physicians are practice and thought leaders, training the next generation of physicians to provide the highest quality of care to our community's children. There are many things that make Children's different from other hospitals, even beginning before arrival. By downloading the My Kaleida app, families can use its GPS navigation to get to the hospital. And upon arriving, it automatically changes to walking directions so that families and visitors have no problem reaching their destination within the building. Parking is plentiful, safe, and close. Whether you choose to self-park in the parking ramp located on the corner of Ellicott and Goodrich, or use our convenient valet service. Walking into the hospital is like Dorothy opening the door to Oz. Bright colors, artwork, playful interiors, and comfortable seating are just a few of the distinctive sights you experience upon entering. The lobby features a gift shop that's any child's dream. A Tim Hortons, which is many a parent's dream, and an entertainment space to host holiday parties, performances, and special meet and greets with local and national celebrities. Each inpatient floor has a playroom where children can put aside their illness or injury and simply experience the joy of just being a kid. There's an outside terrace that allows visitors to get a breath of fresh air, soak in the sun during our beautiful western New York summers, and enjoy a view of the cityscape that's simply spectacular. But at the core of Oshai Children's Hospital is our team of expert clinicians. Their goal is complex, yet singular, to treat and cure sick and injured children. They've devoted their whole lives to that goal, and every single day they give their all to provide healing and make miracles happen. And at the end of the day, that's what John R. Oshai Children's Hospital is all about.
You asked. We delivered. The all-new Stay Current MD app was built with your feedback and your workflow in mind. We've shifted from browsing to search first, so you get the answers you need faster. Search understands typos, synonyms, even clinical shorthand, because at the bedside, there's no time to waste. Whether it's protocols, podcasts, quick videos, or more, everything is at your fingertips. A fully redesigned experience with smarter search, customizable spaces, advanced discussions, direct messaging, cross-institution collaboration, and more control over your profile, notifications, and content sharing, all built to keep you one step ahead. The new Stay Current MD, smarter, faster, built for how you work.
If you're worrying, know there's someone working relentlessly. If you're struggling, know there's a team on your side, pioneering breakthroughs. If you're questioning, know we are finding better answers. Because in the pursuit of healthiness, we're changing the outcome together. Cincinnati Children's.
introduce it first, and then. All right. Is this mic working? Yeah. Yeah. Okay.
That's a reminder to everybody, if you're a speaker, if it's not here, we're not hearing it. It's got to be here.
What? And then I give him this mic, or what? Oh, here. Here's your mic.
Set the time one second.
Yeah, yeah. I'll do it. I'll hit play. Is that my job? Okay. All right. Tell me when you're ready. All right. Good morning, good afternoon, good evening. Welcome to the 12th, I think, annual Pediatric Surgery Update course. 13th annual Pediatric Surgery Update course. We are so excited that everyone from all over the world is joining us. This is really the one time a year where we get to see things that we should be paying attention to that are kind of changing. It's a rapidly changing field. And we don't go in depth for those who have never seen this before. It's more just quick updates on what's new, and we're going to fly through all the things that we think you should know about. We have an incredible faculty here from all over the world, and it's a very good agenda. So I think I'm going to learn a ton, and hopefully we all will. Just some ground rules. First of all, everything's recorded, so if you have to go to the OR, whatever, you'll be able to watch it later. Please participate in the chat, the polls, because we want to hear comments about how you do things where you live, things you disagree with. Be vocal, tell us. And there almost certainly will be technical issues, either with the internet or whatever. Just restart your website. Contact us if there's an issue. I can even give you my email or cell phone, and then you can let us know if there's an issue. But that is it. We're going to go ahead and get started. And first, I'd like to introduce Dr. Jose Campos, who has been with us now. How many years have you been doing it with us? 6 years. Jose came up to me at a conference and said, Todd, it's nice to meet you. Thank you for this uptakes course, but it's not very good because you only talk about stuff that's in the pediatric journals, and you're missing all the publications that are in the non-pediatric surgery journals. And him and his team with this Chilean Society of Pediatric Surgery, they have a method where they identify the best articles that we don't really see because they're not necessarily in our core journals. So every year, and actually all year long through Stay Current, you're giving us updates on what we need to pay attention to. So, Jose, it's all yours now. Thank you.
Thank you, Todd. Thank you for inviting us. It's a pleasure to be here. Oh, cool. Netflix type introduction. Okay, so this is really fast paced and we only have 20 minutes, but I need to take 1 minute just to acknowledge that I'm standing here all the way. Okay, sorry, apologize. So I need to acknowledge that I'm standing here thanks to the Chilean Society of Pediatric Surgery and also to this group of volunteers called Journal Hive. We screen through 1,200 articles each month. We have a method of selecting what's good and what's not. And then we try to spread it out through our newsletter, our podcast, and through infographics, and also within this course. So I wish all the 25 volunteers that are working with us would be here. I'm hoping that some of them are watching us from Chile, but here's just a glance of what the team looks like. Okay, let's keep going. So today we're going to talk about 4 things. It was kind of difficult to choose the articles this year. We're going to talk about non-operative management of appendicitis. We're going to talk about trauma, DVT prophylaxis, neuroendocrine tumors and the extent of surgery, and necrotitis and enterocolitis. Should we do a stoma? Should we do an anastomosis? So let's start with a clinical scenario. It's a very clear uncomplicated appendicitis. Let's imagine for a minute that we're treating a 12-year-old boy with 24-hour right iliac fossa pain. He has rebound sign. His vitals are normal, and the ultrasound confirms a non-complicated appendicitis. So can we please get the poll up? So the question is very simple. Have you treated patients with appendicitis non-operatively in the last 12 months? Why don't we do a quick hands up voting here in the audience. Who has treated more than one patient non-operatively this year? Hands up. Great. Who has treated more than 5 patients non-operatively? Cool.
Wait,
Little
make
less.
sure you ask no.
Huh?
Make sure everybody voted. Who has not treated someone non-operatively?
Okay, one. Let's say, okay, sorry. 0, we got 1, we got Thomas Inge. Do we have results? Okay, so yes is about 2/3 and no is about 1/3. Cool. So I might disappoint you myself because I'm in the no group. Look, maybe this audience is not representative of the worldwide audience, neither am I, but at least in Chile, it's heavily rooted in everyone's minds, patients, parents, physicians, pediatricians, that this should be treated surgically. So I've been following this intellectual debate for the last 15 years, trying to push it and trying to introduce it in Chile without any success. People just freak out when you tell them that you're not going to do a surgery on them. So that's why we brought this the other way around. So that's why we brought this article. This has been published in Lancet. I think if we would give an award of the best article in pediatric surgery each year, it should go into this article.
Why do we have to do this every year? So are we either people don't like this concept or we're slow to pick it up, but I feel like we keep having to do this topic.
The non-operative?
Yeah.
So we're going to talk about it more after the lunch. We brought a full presentation on it, but there are some reasons why previous trials did not address this question properly. They were either pilot studies or they were non-randomized studies. So I think this is kind of a breakthrough. It's very difficult to make such a study, and we are fortunate enough to have Dr. Sean St. Peter present with us here, who's the main author, and also Dr. Simon Eaton will be joining us. So why don't we play the video and see what it says.
After years of debate, we finally have the largest randomized trial in children addressing non-operative management of appendicitis. This article, published in The Lancet this year, might interest you. It reports the APPY trial, an international multicenter study comparing appendicectomy versus antibiotics for acute uncomplicated appendicitis in children. 936 patients aged between 5 to 16 years were randomized across 11 hospitals in different countries. Importantly, treatment failure was defined differently in each arm. In the antibiotic group, failure meant an appendicectomy needed within 1 year, while in the surgical group, failure meant a negative appendicectomy or any procedure under general anesthesia related to appendicitis within the next year. At 1 year, 34% of children in the antibiotic group failed treatment, compared with only 7% in the appendicectomy group. The 26.7% difference exceeded the preset 20% non-inferiority margin, confirming that antibiotics were inferior. Still, children in the antibiotic group returned to school earlier and needed almost no pain medication. A limitation is that 10% of patients had incomplete data, and that consent refusal reasons were not collected.
Cool. Dr. Inge, can I ask for your opinion on this trial? Because you're the ones, I think you raised your hand when you had treated just one patient. So,
yeah, I think that this trial really confirms what a lot of us were worried about, which is, what is in pediatrics in large numbers, what is the failure rate? And so over 30% is actually concerning.
I think the endpoints are different when you look at non-op versus operative standpoint. So I think it's not an apples to apples comparison. And I think the take-home message is still safe. There were no adverse events in both groups. So it's still very safe to do non-operative management.
I think this lights up a very heated debate among the surgical community. We're going to pause this debate right now because we have a full 20-minute session after the lunch break. So please join us for that session, and we'll just keep going with these articles. So we also do infographics. I'm hoping that you've seen this into Global Cast social media or the Chilean Society social media. Anyway, so clinical scenario number 2. So there's a patient admitted overnight after a car crash accident with a severe brain injury and a femur fracture. Now it's been repaired. Vitals and labs are stable now, and there's no signs of active bleeding. No signs of active bleeding in the brain injury, mainly. That's a key question. So let's vote. Would you give DVT prophylaxis? Choice is yes, give it now, please. B is yes, but maybe let's just hold it up until tomorrow, not quite safe yet. And B is nope, too risky. The reason... 8-year-old. 8. So the reason I brought this study is because we were chatting with the volunteers and someone said, look, this has been published in JAMA, and what do you do about DVT prophylaxis? And I had no idea. This was not part of my algorithm. I kind of was neglecting my patients. I was aware of non-operative management, the ATOMA guideline, etc. But this was not into my algorithm, so I brought this article just because of my own ignorance. Reading the article, then you find out that I'm not the only one. Like some guidelines actually recommend against it, and in the study we're going to see only 50% of the doctors caring for these children actually administered a DVT prophylaxis. Okay, so we have vote results. Yes, give it now. It's about, can someone move the cursor around to, it's about 15%, and 50% no, too risky. Okay, let's find out about this. This was been published in JAMA Surgery, and Joanca Ramirez from Chile will give us a 1-minute summary of this article.
When facing a severely injured child, the question often arises, should we start chemical prophylaxis against venous thromboembolism? And how soon? This study, published in JAMA Surgery in 2024, prospectively evaluated 460 pediatric trauma patients with high risks for deep vein thrombosis across 8 level 1 trauma centers. They compared outcome based not only on whether prophylaxis was given, but also when it was initiated. The recommendation for all patients was low molecular weight heparins twice daily, 24 hours after the injury. No major bleeding even occurred in any patient who received anticoagulation. Children who received prophylaxis within 24 hours had a venous thromboembolism rate of only 1.6%. In contrast, those who received after 24 hours had a rate of 6.9%, nearly identical to the 5.3% observed in patients who never received prophylaxis. In other words, starting late was essentially the same as not giving it at all. The main limitation of this study were the low adherence to VTE guideline, with almost half of the patients never receiving prophylaxis, and the relatively low absolute numbers of VTE events, which restrict statistical power. So here's the question: do you use VTE prophylaxis in high-risk pediatric trauma patients? If so, how early do you start in?
Cool. Can I ask for Katie Russell's opinion, please?
Yeah, thank you so much. I think Dr. Kodegal actually made probably the most important point already on this case, in that this kid is 8 years old. And so typically in pediatric trauma, we use a cutoff of somewhere about the 12-year range or puberty to be that breaking point for when we think about DVT prophylaxis. So in this kid, I would not give them DVT prophylaxis.
Cool. Does anyone want to share their opinion? Or should we move forward? I agree.
But what if the kid's 14? Obese and 14. So then we think that we should be thinking about that and that those kids are at risk. And so then the kid needs the femur fixed. So you give it before the femur or after?
I mean, I think you start as soon as the patient is present and then, you know, as necessary. Standing up, sorry. Yeah, I think you give it as soon as the patient has presented, unless you have contraindications like TBI or something else. But I would start right on admission.
I think that's a great point. I after reading this, I think I need to come up with reasons not to give it. Like the default is you need to give it, but unless this or that. And you pointed very accurately that it has to be given early. Otherwise, there's no point. So that B choice It's usually not the right one, is it? Like, oh no, let's wait till tomorrow, then you're not gaining any benefit of it.
I think the other thing is that we have a tendency to hold, and we can move quicker to start if we have conversations. So a lot of times people will say, okay, no, that kid has a TBI, don't start it. But if you call the neurosurgeons, they say, yeah, it's fine, right? So a lot of it is really being proactive about how we initiate and making sure that we have a conversation with every patient that we need to, okay, should we be starting, can we start now, et cetera, so that we don't miss the window.
Yeah, so this article was actually powered to detect any adverse event, and there was no adverse event whatsoever from prophylaxis. So that's another big take-home message. We'll just keep going with article number 3. Again, we're doing the infographic. I'm forgetting to show this. There's a lot of work behind this.
Where can they get those infographics?
So there are all across Global Cast, Stay Current app, and the Chilean Society of Pediatric Surgery social media. We're working on a repository for people just to look through things, but it's not ready yet. Maybe next year. Okay, scenario number 2, laparoscopic appendectomy on an 8-year-old girl. Histology just came back. It's a neuroendocrine tumor of the appendix, 2.5 centimeters, positive margin and present lymph nodes. What would you do about this patient? Very easy, also, well, not easy to choose, but very easy alternatives. She is treated, no further management is needed. Or B, she needs a right hemicolectomy kind of right away. The reason to bring this article, I was a bit hesitant, but at the end, Dr. St. Peter convinced me to do it. It's just that this is so rare, it's only 1 every 1,000 patients will come back with a tumor in the appendix, and not all of them are neuroendocrine tumors. So what I'm trying to say is that every surgeon will only treat a handful of these cases in their lifetime. So it's important to get it right. No one can, I don't think anyone can accurately say, out of my experience, so that's why we need to be mindful of these larger database studies that we're going to show. Do we have any data on the polls? I made it especially difficult because I think most would agree that the finding on histology of a simple tumor would not trigger these questions, but I made it especially difficult, this tumor being more than 2 centimeters, positive margins, and lymph nodes. So most would recommend no further management, but there's still like 40% that would recommend hemicolectomy, a bit higher than the study we're going to show that's based on the US.
Would you still take a child with an appendiceal neuroendocrine tumor to a right hemicolectomy? This article, published in the Journal of American College of Surgeons in 2025, might interest you. Using the National Cancer Database between 2004 and 2022, the authors identified 1,339 patients under the age of 18 years with appendiceal NET and compared appendicectomy versus right hemicolectomy. Primary outcomes were 5 and 10-year overall survival. Right hemicolectomy patients had larger tumors and more lymph-vascular invasion. Despite this, survival was excellent and equivalent, 99.9% at 5 years and 99.4% at 10 years, without the use of chemotherapy or any other additional treatment or further surgery. Notably, no deaths or disease progression occurred among children treated with appendicectomy alone, even when high-risk features like tumor larger than 2 centimeters, positive margins, or positive lymph nodes were present. Some limitations for this study include retrospective registry and lack of recurrence as an important outcome to calculate disease-free survival.
Okay, now there's the infographic just summarizing what we just heard. Dr. Aldrin, can I get your opinion? Do you think there's a role for hemicolectomy in this situation, or should we just leave it out of the equation?
Yeah, I think you purposely left out some of the the histology components and the way the cells look and the MKI and things like that. But I think regardless, multiple retrospective studies, this large database study has shown that appendectomy alone is sufficient. And even to go further, you don't even need additional imaging because it doesn't really change management. So I agree with appendectomy alone.
Thank you, Dr. Aldrin. Anyone else?
So
totally agree with the fact of not jumping into right hemicolectomy. The first year I was an attending, I had actually 4 kids with carcinoid, so I started having an interest in it, and reviewed 5,000 kids who had an appendectomy at Sick Kids when I was still in Toronto, and of these, about 30 had a carcinoid, and only 10 really underwent a right hemicolectomy. But then when we looked at these 10, actually maybe half of them only needed it. And so please do look at your pathology report. That's important, because it can avoid, of course, further imaging and unnecessary surgery. And it's not just to look at, if there's tapeworms or anything else, but it's actually interesting to see whether the carcinoid, and if it's there, the size, whether it evades, if there are clear margins. So it's just good practice.
Thank you, Dr. Sani.
So I think everybody in the room would not consider me a surgical oncologist, but something about leaving margins that are positive, Jenny, I think many of us would be concerned about.
Yeah, I think what we probably don't understand is it's a totally different biology in children compared to adults. And I think a lot of that hasn't been sorted out, but the behavior of the tumor in pediatric patients and adolescents is entirely different than the behavior in adults. So margins really haven't made a difference in doing appendectomy alone.
And it's very difficult where you draw the line between children and adults. And actually the previous studies were kind of drawing the line up to 15 years. And these database studies actually compared up to 18 years. So all these conclusions are still valid up to 18 years. I don't know how much further you can push that line, but that's another thing to take into consideration. So this happens every year, Todd. We never had time to run the last one. We have only 1 minute, so I'll just... That's okay. This is an NEC baby where you've resected 30 centimeters of small bowel, and there's no more distal disease, so what would you do? Stoma or anastomosis? And there's a reason why this study is at the end. I would prefer this study to be second, because I think it comes second in the award of best quality article of last year. We have, again, Simon Eaton present online and Dr. Augusto Sani, who both are authors of this article. And to me, it was a dogma that stoma was the safest option. That was what I was told. This is a fragile population in which you don't want to risk it. And I think this article, I don't want to overstate it or overcall it, but I think this article might inverse or change the narrative. So let's have a look at the video. Oh, sorry, poll results. 50-50, cool, that's very cool. So we really don't know what we're doing here. We have no idea. Okay. There's no sound, I think. So the STAR trial was the first multi-center randomized controlled trial. Time's up, okay. Yeah, I'm trying not to steal the thunder for the next. This is just a bridging, an introduction into the next presentation. That's why we kept it short. So sorry. Was there audio on the streamline? So I think we're running out of time. So they basically randomized patient during laparotomy, either to stoma or anastomosis, when 2 of the options were deemed feasible for the child. And they actually found no difference in mortality. They found no difference in complications in general, but when they analyzed for multiple intestinal and stoma complications, of course the group with stoma had up to 19% of complications, and the likelihood of being weaned from parenteral nutrition was much higher in the anastomosis group, and the children were weaned 20 days earlier compared to the anastomosis group. I don't think we have time for comments, but we'll keep talking about this in the next session. And thank you very much for all of you. Thank you for thanks to the society. Thank you to all the Journal Hive volunteers. And hopefully I'll see you next year.
All right, so M, who's next? I don't have the run of show. Who's next? Come on up. All right.
Primary anastomosis.
Oh, yeah, she did. Here you go.
He'd start.
Here, is this it?
Okay, so thank you, Todd, for the kind invitation. It's me here in person and Simon online. So we're going to talk about necrotizing enterocolitis. Of course, wrong. All right, so of course a lot of dilemmas. So we still don't know what causes it, but just for us surgeons, how do we really diagnose it? So we really don't know, and what's the right time to operate? Are there some babies that are too sick to be operated on? And then when we do an operation, which one we should choose? What is the best operation? When do we restart feeds for these babies? Antibiotics, which antibiotics and for how long? Do we refeed the mucus fistula if you have one? And when to close the stoma? So these are some, we won't touch on everything, but some of the surgical dilemmas that are still out there. So we have a 28-week male infant, 900 gram on CPAP, on trophic feeds, EBM, and TPN. It's day 12 of life. Baby develops abdominal distension, episodes of bilious vomiting and bloody stool. On exam, baby is irritable, tachycardic, tender distended abdomen. Labs show high white count, metabolic acidosis, and a high CRP. We do an X-ray that shows no free air. There's some bubbles in the intestine. So we decide to put the baby on triple antibiotics, Ampgent and Flagyl, and bowel rest, so MPO. But how do you follow up on this baby beyond your physical exam? Should we do serial abdominal X-rays every 4 to 6 weeks? Should we do another X-ray in 24 hours? Should we do an abdominal ultrasound? Should we do an abdominal CT scan?
Not 4 to 6 weeks, 4 to 6 hours.
Hours, sorry. As I said, weeks, sorry. All right. Okay. All right, so.
Would anybody do ultrasound to start with?
Then I would agree with the NICU in that case. And maybe it's not that popular, but the ultrasound really gives you a lot of more clues than the abdominal X-ray. Abdominal X-rays are highly specific, but have very low sensitivity. Studies show a sensitivity between 13 and 25%. What does it mean? When you have a low sensitive test, it means that there's poor ability to catch those patients with the condition. Which condition? Of course, we want to know when the baby has surgical neck, when we need to operate. Well, an ultrasound scan can tell you a little bit more about the bowel wall, thickening, thinning, perfusion, peristalsis, what's inside the abdomen, what happens at the level of the peritoneum and the liver. So this study from end of 2023 touched on this. It's on pediatric radiology. So first of all, when not to do an ultrasound scan. Well, when the baby has free air, of course, then they need a surgeon, not an ultrasound scan. Or when the baby, we think, is sick, and we have an X-ray that actually gives us all the clues that we need. But when to do an ultrasound? When for instance, they call us for a consult on a baby that we don't think has necrotizing enterocolitis, and the X-ray is equivocal. Early stages of neck, when actually there's not much to see on an X-ray, very low sensitivity, when the baby is really sick and the X-ray doesn't match the clinical scenario. So in this study, they looked at risk findings, as they described them, on the sonogram. So high ones are pneumoperitoneum, focal fluid collections, complex fluid. These are more concerning for bowel perforation. Intermediate, you have increased bowel wall echogenicity, absent perfusion, portal venous gas, bowel thinning and thickening. The more of these you have, the more likely you need to do something about it from a surgical standpoint. And low ones, like increased bowel perfusion, not so much. There's also more that have been described, again, by the same group. You can see a thickening of the mesentery, hyperechoic intraluminal content, and also there's this inability to see the tissue plane. So they divided patients group A and group B. Group A, babies successfully treated medically, no need for surgery. Group B, medical management failed and they needed surgery. Now, all these findings are present in both groups, but much more in the ones, of course, that needed surgery. So we go on with the clinical scenario. It's day 14. Baby gets worse, more abdominal distension, acidosis, started on inotropes, high event settings, blood transfusion needed. We do an X-ray, and there's free air. Okay, and so of course, the classical controversy in necrotizing enterocolitis management. What do you do now? An intraperitoneal drain, exploratory laparotomy, wait and see, redirection of care. There's free air, yes. People voting on this? Okay, that's good. I agree with them. I agree with the majority that actually would do laparotomy. But obviously this is, as I said, the classical, though we don't touch on these 3 randomized controlled trials in the past. So we decide to proceed with surgery. But then I ask you, which kind of surgery? Do you do a resection and an anastoma, resection and anastomosis, clip and drop, or you just withdraw care?
I mean, all these things depend on how sick is the baby. I mean,
yeah, of course, yes. But let's say it's a baby that is stable, not so sick. It's not total pancolitis. It's not a focal intestinal perforation. It's just like 10 centimeters of necrotic bowel in the middle of the ileum. What would you do? Oh, sorry. Do we have the poll? Oh, cooking. All right. Well,
can we show the poll cooking? Okay.
What will people do? Anyone
by
doing
show
an
of hands,
anastomosis?
who would operate, or who would do an anastomosis by show of hands? Not too sick, stable. Yeah.
Yeah.
Who would do one?
Who would do one? Interesting.
Not so
who would
many.
not?
I'm still not convinced.
Clearly.
Yeah, because I can't tell. They're sick post-op. This is the problem I have. They're sick post-op,
Yeah.
whether you do the anastomosis or not.
Sure.
So how can you don't have a reliable exam to know.
You get up, Did she listen?
What?
You get up, post-op.
Pulls up? Oh. Okay, so the majority would do us.
Has anybody used ICG in a neonate? In a neonate, has anybody used ICG in a neonate?
But also, it's not very much about the perfusion of the margins. People feel uncomfortable doing an anastomosis in a 500 gram or 800, 900 grammer like this one.
But I think the ICG thing is a great idea. I mean, if your facility has the ability to do ICG, if you had ICG that showed you had good perfusion, would you hesitate doing an anastomosis? Anybody? You'd still hesitate?
Yes, because it's progressing. It's a progressive disease. That's my
Is it when you take it out?
Yeah. The bowel is a symptom, is a result of the illness. It's not the cause of the illness.
Yeah.
So the disease still progresses. Even that's the problem of going too early. You resect, it's still progressing. That's my concern, is I feel like it could look totally different tomorrow.
True, not all babies are the same. Of course, there are those ones in which you open up, you just need to bring up a stoma because they're too unstable. But the ones in which, as I said, like let's say 10 centimeter of a segment, you remove it, so you have source control. Not necessarily they do so poorly. And then afterwards, when you're actually looking at the next slides, you'll see that in the long run, actually, there's a benefit. The benefit is not immediate survival, for instance. That would be, of course, there's babies that die, unfortunately, in both groups.
So let me ask you this then. So you're saying it's progressing. Will you put a silo and come back next day?
I would do, no, first of all, I change my practice every year when I do this. Okay, so I will change my practice and part of me is a wimp. Well, we all know that. But I mean, like in general with this, if was like, all right, I'm doing standard of care now. Like, I'm not on the fringe. I would say, all right, this is accepted. The data shows it's better. I'm uneasy. I won't sleep for the next 3 nights. I won't be able. Right. So after this, if I'm convinced of the data, I probably, if I feel like the baby is well, I would be convinced to do a primary anastomosis, because I do agree doing a stoma, doing a siloed clip and drop, maybe they won't do as well if the data shows that. Right now, I'm a clip and dropper. I would come back 48 hours later. I would not do a stoma, because I feel like I would have an answer in a couple days. Why? What am I saying that you don't like?
No, I think it depends on hemodynamics, right, on the kid. If your lactic is correcting, if your thrombocytopenia is correcting, if you're getting off inotropes, right, and you come back the next morning and the bowel looks potentially viable.
Yeah.
You're resecting 5 instead of 35 potentially.
Yeah.
You can bring that up as a stoma or do an anastomosis. Depends on hemodynamics, I think. We do not have a standard of care as of today.
I agree, but can I just ask a question though? Go ahead, Steve. Is this a bowel perfusion problem? Because I'm not sure it's the same as like anyone that has poor perfusion. This is a very more complex disease.
So you come back and you do a clip and drop, 24 hours later you look pristine, no further progression. Would you do an anastomosis now?
Yes.
Now, the case is of a perforation. Of course, there are those babies that we start medical management and then they just hover along and you don't know what to do, and then it's a sort of failure of medical management, you don't know what to do. And those ones are the ones that maybe it's difficult to decide. But when you have clear, you have perforation, you've got a necrotic bowel, you know where the necrosis is.
So there's a comment from the chat from Sean Safford.
Yeah.
Spontaneous intestinal perforation is totally different.
Totally different, absolutely.
Then
Yeah.
I would definitely do a primary anastomosis.
100%. So that was one of the exclusion criteria for the trial. So because the vast majority of babies can do well with an anastomosis.
Yeah.
Same with the pancreatitis, which is the other end of the spectrum. You cannot do an anastomosis.
Remember, this trial randomized intraoperatively.
Intraoperatively.
So the decision was made in the operating room after
Yep.
resection of the necrotic
Yep.
portion
Yep.
of bowel.
Should we go ahead with the next? Yes. So Simon, can you hear us?
Can you hear me?
Very well.
Yeah, okay. Sorry, Augusto, do you mind moving to the next slide?
We are the meta-analysis.
Yeah,
Do you see
please.
that? You want the next one?
No, the meta-analysis. Yeah, that's fine. Okay, so in Great Ormond Street Hospital, they've been using primary anastomosis here as the operative choice for quite some time under the guidance of Mr. Kiley and Professor Spitz and also Agostino Piero. But a meta-analysis in 2017 highlighted that there may be some advantage to doing a primary anastomosis compared to those that undergo stoma. However, none of these were from randomized controlled trials, and so this might have been due to differences in the severity of NEC. And this meta-analysis concluded that a randomized controlled trial was necessary. Next slide, please, Augusto. Yeah. So we designed a randomized controlled trial, and I have to pay credit here to Dr. Agostino Piero, who is very much the driving force behind getting this trial started. It was a very, very difficult trial in many ways. Not just the difficulty of the trial itself, but also the fact that Dr. Piero moved from Great Ormond Street to Toronto part the way through the trial. And so the key here was that the final decision on eligibility was dependent on the surgeon's judgment during the laparotomy. So some infants were always going to be candidates for primary anastomosis if they had a very small perforation, spontaneous intestinal perforation, where no one realistically would do a stoma. On the other end of the spectrum, you've got those infants that always had very extensive disease, or it was very difficult to judge. where it may, when no one really would want to do a primary anastomosis, they just want to get out after having done a stone. Next slide, please, Augusto. And click through the other two. Yeah. So consent was taken from the parents for randomization before going to theatre, and then the decision was taken at laparotomy when the bowel could actually be examined, and then intraoperative randomization took place. For those of you that know me, you know I am not a surgeon. It's not me that's making the decision to randomize. So I'd just like to hand back to Dr. Zani, who actually did randomize a lot of patients in this trial, just to comment on that randomization process and how did you really have to feel comfortable every time that you could potentially do either operation?
Yeah, thanks, Simon. Yeah, it was quite tricky, and of course, you're in the middle of the operation. Now, this means, of course, that the baby is stable, hemodynamically stable, and then you would unscrub and go to the computer and go for randomization. It was, of course, also a conversation between me and the fellow. I randomized more than 20 of these babies for the whole trial. So, and sometimes I really thought it was better to do one rather than the other, but it was just my gut feeling. There was no evidence. And so we did what the machine told us, what the computer told us, and I can tell you that the fellows, when it was like an anastomosis, were like, oh my God, now we're doing this to 500 grammars. And but then they were the strongest believers when they saw how these babies progressed afterwards. Simon.
Can you get back to the slides and to the next slide,
yep.
Please? I don't see the...
We're on the...
Ah, that's it. Yeah, thank you. So the primary outcome for the trial was quite difficult to decide on because we knew that we were never going to be able to power a trial for mortality or for neurodevelopmental outcome. So we decided to take the primary outcome on time on parenteral nutrition. And as you can see from this Cox regression analysis, those that had a primary anastomosis got onto full enteral feeds sooner and finished their parenteral nutrition earlier. Next slide. And then there was no difference in terms of, no significant difference in terms of mortality. If anything, mortality was ever so slightly higher from the stoma group, but not significantly different. And then complications, stoma complications were inevitable in the stoma group. We did have obviously some complications in the primary anastomosis group, but overall we felt that complications were worse in the stoma group than the primary anastomosis group. Next slide, please. So in conclusion, we decided the conclusions of this trial was that the primary anastomosis led to reduced duration of PN, reduced intestinal complications, and that there was no difference in mortality. So although obviously one accepts that there are, if you are uncomfortable doing a primary anastomosis, then doing a primary anastomosis is not for you. But nevertheless, there are some children that we believe are definitely candidates for primary anastomosis, where otherwise you might consider of only doing a stoma. So moving on to the clinical scenario, in this particular patient then, after having decided to do a primary anastomosis, the patient then became markedly clinically unstable. So the decision was taken to do a stoma instead. And so there's all sorts of questions on almost every stage in NEC. So here we have a question, how long do we make them NPO after a laparotomy? We don't have time to consider that today. But then on post-operative week 3, there's a conversation between the surgeons, neonatologists, and the nurses, who are an important part of this conversation, about mucus fistula refeeding. So we'd like to give you the next poll about mucus fistula refeeding. Should this baby be refed via the mucus fistula?
Yes, 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 yes. See the poll? Yes, the majority of people say yes. Okay, so where are we in terms of evidence for mucus fistula refeeding?
Next slide, please, Augusto. Yeah, so there has been a systematic review and meta-analysis from Bonnie Jasani, who's a neonatologist from Toronto, Sick Kids, and the evidence isn't strong so far. Next slide, please. Luckily, there is a randomized controlled trial that's going on at the moment, which is, again, this is a very, very difficult randomized controlled trial. We don't know the data from this at the moment, but it's a randomized controlled trial of mucus fistula refeeding, time to full enteral feeds. Most of this population is an NEC population, but it does include other neonates with a bowel resection. Next slide, please. And then the final question we wanted to just pose is time to stoma closure. So, if you have done a stoma, do you attempt to close and think about closing it less than 8 weeks, 8 to 12 weeks, or you leave for even longer?
The poll says less than.
Yeah. So so a significant amount of people will close either. Oh, it's shifting quite a lot.
I have a question. Are
Yeah.
people in here answering the polls? So you should. Here's what I'm guessing. If there's a delay on the polls, the initial response we're seeing is this room. Is that right? Because there's a delay on the, oh, there's no delay. Ah, okay, never mind. I got excited that we were going to see if our audience disagrees with the rest of them. Okay.
So just quickly, the data from that show that people are pretty split between the three possibilities there. Sorry, but could you mind to go back one slide, Augusto?
Time's up.
Yeah, okay. So optimal timing of stoma closure, recent paper in Journal of Surgical Research, basically showing that it seems to be safe to close early. However, this study is very underpowered, so it's concerning that in less than 8 weeks there were 2 infants that had a repeat episode of NEC. And I'll hand over to Augusto to, final thing there is that there is an ongoing preparation for a randomized trial in the UK. And I'll hand back to Augusto there for the wrapping up personal practice check.
So take-home message from our group on this session is that you can use an ultrasound if the abdo X-ray is equivocal. Primary anastomosis is a viable option in stable babies. Mucus fistula feeding seems to be nutritionally advantageous, and ostomy closure can safely be performed earlier than 8 weeks. Thank you.
That was awesome.
Do we have time for one question?
Yeah. Actually, I was just texting you. Can someone make sure I know how we are on the agenda timetable? Because I don't see it. Perfect. All right, go ahead. We'll get delayed. Go ahead.
We'll get delayed.
Go quick. Yeah.
So Augusto, coming back to the STAT trial, given it was not powered to detect a difference in mortality, do you think there's a risk where just looking at the benefit of early PN weaning, but maybe giving them an increased risk of mortality? Because I know there's no statistical difference, but the numbers are quite shocking. It's 11 versus 21, isn't it?
Well, of course, these babies are, sick, and obviously this is what you see. But this is 80 babies that have been randomized, and so mortality was definitely. We know that there will be mortality in both groups. I don't think that if we have more babies in a second trial, we would necessarily see differences in that regard.
Could you comment on how many babies were excluded? So how many out of the roughly 80 that went in the trial were considered and the surgeon thought, okay, this baby is not a viable option for both?
Yeah, I mean, the exclusion was mainly up front, parents that didn't want to give consent. Of course, it's very dramatic when you talk with them and you say, okay, your baby has perforated bowel, needs to go to the OR. So some parents were really too distressed. But during the surgery, again, I don't have the numbers. I don't know if, Simon, you have the numbers, but definitely those with, as I said, focal intestinal perforation instability, and there's of course a bunch of babies that go to the OR and still are unstable. Your anesthesiologist wants you to be as quick as possible. Those with colitis or with distal colonic disease, those ones were definitely not considered. I don't know the number of those ones. I don't know, Simon, do you have those numbers?
We were unable to collect any numbers that I would give any kind of index of reliability to. We have some information, but very little on which to base any conclusions.
Quick poll for the people in the room, because we can't do it online. I'm a big believer of ultrasound. Like, I've seen it's real. The radiologists are super good at it, and the technologists are really good at it. If you had a baby that didn't show free air on a plain film, but the radiologist said, this baby has a perforation, who would operate on that baby based on the radiologist telling you it's perforated? By ultrasound.
Yeah.
It could get to be a good radiologist.
Yeah.
You have to trust your radiologist. But I don't think as surgeons we've actually embraced ultrasound the way we should, because on the radiology side, they're doing stuff that is just ridiculously sensitive.
I think you need to be prepared to have some negative laparotomies. There will be some in which, unfortunately, you think it's perforated, actually it's not. But definitely if there's like turbid free fluid, there's something going on there. So.
But you don't see that in the x-ray. And so you got to trust
Exactly.
your radiologist to some extent to say, like, this baby's perforated. Okay,
Yeah.
well, we've got to operate on
Yeah.
it.
You don't see it on the x-ray, but eventually a lot of those kids will get better, but they won't open up, and then you'll go in there
Yeah,
and you'll have clear evidence that there was a perforation
That's
that
it.
we missed.
Yeah.
All right, sorry.
Awesome. Yep.
Does everybody do refeeding?
Yeah.
Yeah, if you can.
All right.
All right, next.
Perfect
Awesome.
timing.
Thank
That
you.
was awesome. I will change. So I will. I mean, this is where I change my practice every year. So I will start doing it. I'll send you my notes afterwards. All right, we're going to move on to the next session. What's it? Yeah. Who do I call? Augusta, I'll call you if things go wrong. All right. Simon, thank you. All right, we're going to move on to the next session. All right. So we're going to talk about updates in esophageal atresia management. We got Dr. Matt Dellinger and from Seattle Children's, and Dan and Steve. Are you both moderating this? Okay. Perfect. All right. Go for it.
So we're going to talk about updates in esophageal atresia. 3 topics I wanted to touch on was the utility of preoperative bronchoscopy when you're in the operating room right before you do the esophageal atresia repair, how people think about and manage tracheomalacia intraoperatively, and also the role of recurrent laryngeal nerve monitoring during EA repair. So we'll jump right into the first scenario. So you have a 3-kilo baby transferred to your hospital, just born, no prenatal diagnosis of esophageal atresia. You presume they have a type C EA. They have a replogal coiled in the proximal esophagus. Looks like our arrow got moved down. They also have distal gas. That's not where
It's going to be a slam dunk operation with that.
That might be where the fistula is. Normal work of breathing on room air. The baby's not in any distress. You have an echocardiogram that's unremarkable with a left aortic arch. So the first question is, should you or would you perform a routine preoperative bronchoscopy? Does the poll auto-populate?
Does anyone in the audience here not perform bronchoscopy? And then at your institutions, who performs a bronchoscopy?
Show of hands for surgeons.
Show of hands for if ENT does it. So it's for those in the audience, virtual audience, 50-50 here. So it looks like what?
The question is, why are you doing the bronchoscopy? Are you doing it to see where the location of the fistula is, or are you looking for some other problem, a vocal cord movement or something like that?
Yeah. So you want to repeat the
question?
question?
So the question is why do the bronchoscopy? Is it to look for the position of the fistula or other associated abnormalities?
Which we'll touch on that.
Yeah, go ahead.
Well, I think that's an important question because that's the only reason ENT, to me, would be doing the bronchoscopy would be to look at the vocal cord movement. Because they're not going to, it doesn't make much sense to me to be the surgeon sitting in the lounge or even in the room and having the ENT doc tell you where the bronchoscopy is. I mean, which could be where the fistula is. So anyway, to me, whoever's doing the bronchoscopy, it's relevant on what they're looking for.
So this is based on some old data. This is a survey of IPEG surgeons. Dr. St. Peter, you did this study, or survey in 2012, and 60% of IPEG surgeons, about 170 surgeons over 30 countries, responded that they would routinely do preoperative bronchoscopy. In our institution, as soon as recent as 5 years ago, we were not doing preoperative bronchoscopy. One of the arguments was safety, and I think safety, it can be done very safely without major complications. One of the other considerations is the likelihood that you're going to find a proximal fistula. So a type C is going to actually be a type D is so low. Why do it? But I think there's a lot of utility in doing it. This is an Italian group that looked at bronchoscopy in patients and found that it was useful. You can define useful in various ways in 45% of patients. A proximal fistula in type A or even type C, but I think fistula occlusion, if you're worried about abdominal competition and distending the GI tract with gas when you're intubated, and alteration in the operative approach. If you did find a proximal fistula and you think you need to do a cervical approach, I think there's utility in it. Our ENT surgeons do our bronchoscopies, and they actually look at laryngeal clefts as well. So if the baby's stable, they'll put them in suspension and look for a laryngeal cleft, which I think is really important just because these children have a lot of respiratory issues, a lot of feeding issues, and there's utility in knowing whether or not they have a laryngeal cleft and developing a safe feeding plan for them.
Of those in the room, if you did your own bronchoscopy, how many would consider having ENT bronch that patient before they go home to see if there's a cleft? So for those online, nobody raised their hand. But it's a real diagnosis occurs all the time, and we may be ignoring that. So it's also something you should consider. We do the bronchoscopy. We don't look for clefts, right? We don't suspend the patient. We can't see it. So it's something you should consider before they leave, is to have the ENT guys just scope them to make sure there's no cleft, because they could miss the respiratory issues that go along with it.
I think that's why Dr. Holcomb's question is so relevant. Depends on what you're looking, and at least in our center we try to do it together, or at least one doing it, the other one watching, or if not, we get the video and we kind of analyze it together.
I do think there's an argument for efficiency in talking to your teammates. I mean, a full ENT eval can take a while, and you have a kid who's sort of vacillating between great and not so great, so it's important to be in the room with them, talk about what your goals are, and getting through it in an efficient manner.
I just wanted to add, over in Mexico, it's a pediatric pneumologist who does it, and where everyone's in the room when it's done.
Okay. That's it. Yeah, keep going.
Yeah.
You know, one last comment about the clefts, like they come in different forms. So we've had like 2 major clefts in the last year where you probably shouldn't proceed with general anesthesia without really thinking about that, because the kids can decompensate if you try to intubate them. So I think that's another reason that sometimes we don't talk about, that it's important to do this bronchoscopy.
The other thing I like doing after you've done it with the ventilating bronchoscope, you can take the ventilating part off, put the ET tube over the scope itself, and then position the tube tip exactly where you want it.
I wanted just to add, beyond, of course, of the cleft and the proximal fistula, I've had at least 3 babies with a peak bronchus, an additional bronchus. It's nice to know about it before you do your surgery, because that anatomy can actually be a little confusing.
So just a couple additional points, and I think these are all brought up in the discussion. You can have an unusual fistula location, whether that's a pig bronchus or a main stem bronchus fistula. Up to 20% of patients with EA will have a laryngeal cleft, and I think it's important to know about that. And then you get more rare things like a subglottic or a vallecular cyst that may have implications for respiratory support and how the baby does postoperatively. We're going to jump to the next scenario. So you say you're doing a preoperative bronchoscopy, the baby's under anesthesia, but they're ventilating spontaneously, and you see this. You see that the distal trachea collapses during spontaneous ventilation. And so this baby has tracheomalacia. You can see that the anterior cartilage is more D-shaped, and they have a wide trachealis muscle.
Hey, Matt.
Yeah. Yep. So what is your intraoperative approach to tracheomalacia at the time of the index EA repair? Do you do no intervention? Do you plan a second bronchoscopy before discharge to see how the malacia may have changed with repair? Do you do a selective tracheopexy, or do you do a tracheopexy in any child you see that has tracheomalacia on a preoperative bronchoscopy?
Who does tracheopexies in the room? So for the virtual audience, I think it's 2. and
so of those that don't do it, who does it in your institution? Oh, you're talking routinely.
At the time
okay.
of the index
It's like,
operation.
whoa, wait a minute, we're just gave away tracheopexies to somebody like the cardiac surgeons or something? Go ahead,
Yeah, can you toggle between the choices just to see the percentages? So it looks about like about half of people don't intervene. Maybe a quarter do a planned second bronchoscopy. Up to 20% do a selective tracheopexy, and then 7% do a tracheopexy. Does anybody in the room do a tracheopexy selectively or at the original operation?
Thanks for asking. I think what is like the hardest thing to decide right now, whether to do that or not. I think in Cincinnati we tend to do them selectively. I wish I had a better answer about which kids get it and which don't. If you have a stable patient who had a pretty impressive bronchoscopy before surgery, then I think that's taking 15 to 20 minutes to do a couple extra sutures makes sense at that time. And I think that's because we don't infrequently get asked to go back and do a tracheopexy after, which is a lot harder if needed. So hopefully someone can answer this question for us, though. I know they all look like that, so no, I can't define that for you.
So,
right.
Wait, Rick, you can't talk without a mic.
So Aaron, if you're doing a thoracoscopic TF, it only takes you 15 minutes to do the tracheopexy?
Maybe 30, 45, yeah. The fellows are doing it, of course, right? And then as far as doing the scopes, I do wish that our fellows were able to do them. It's nice to have ENT in the room, though. Not infrequently those patients get sick. There's a plug in the ET tube, and having ENT around to come in and help or change the tube out, we have found helpful in our institution.
Yeah, I think we're really bad at predicting what a preoperative bronchoscopy will mean for clinical evidence of tracheomalacia. We're just not very good. The sensitivity is probably only 50%, and so this has been studied retrospectively in patients that did not have evidence of tracheomalacia, that about half of them would go on to develop tracheomalacia that was clinically significant. So I don't think there's a great way, even with the shape of the cartilage or the amount of posterior intrusion, that you can really predict in a given child what their clinical course will be. We will selectively perform tracheopexy. Usually it's at the location where you divided the fistula. Usually we don't do a more robust tracheopexy because that seems to be the area where it's the most prominent collapse, and I agree doing it at the time of the index operation in a baby that's stable is far easier than going back and digging through scar tissue to get to that anatomy. This has been looked at by groups in Boston and Johns Hopkins All Children's, as well as a group in in the Netherlands, and put primary tracheopexy at the time of EA repair in children that have moderate to severe tracheomalacia, so 75% or greater collapse, seem to have fewer life-threatening events, fewer hospitalizations for respiratory illnesses, and actually improve weight for age Z-scores at 12 months of age. And so I do think there's merit in doing a primary tracheopexy at the time of esophageal atresia. Obviously, there's a learning curve to it, and so this may be more generalizable at one point. These are just some brief pictures about posterior tracheopexy for people that may not be as familiar with it. It was originally described in the cases of recurrent tracheoesophageal fistula, and the question was, how do you separate these suture lines to prevent yet a second recurrence? After the fistula is divided, you can see the esophagus in figure B is moved to the right, and you put stitches in a horizontal mattress fashion under flexible bronchoscopic guidance in the posterior membranous portion of the trachea, and then you suture them to the anterior longitudinal ligament of the spine. And so picture D depicts that nicely, where before you have the trachea anteriorly, a recurrent TEF, and the esophagus posteriorly. And then once you've divided the fistula and done your tracheopexy, the esophagus is moved into the right chest, and the trachea is there, pexy to the spine.
Would anybody do an anterior tracheopexy at this point? Let's think of a past. No, at all. Like if you needed to have a tracheopexy, you're 3 months out from your repair, or let's say you're a year out. Would anybody do an anterior tracheopexy versus a posterior tracheopexy? Preferentially?
Mike Mayhole, Lurie Children's, Chicago. I'm not sure that there's data that say that one is superior to the other, anterior versus posterior tracheopexy. And in fact, maybe thoracoscopically, if you went in through the opposite chest of your repair, it's actually virgin territory to do an anterior tracheopexy quite easily.
Yeah, we'll keep moving forward in the interest of time. These are just some quick pictures in regards to tracheopexy. You can see these sutures, the esophagus here that's being tented anteriorly. You can see the pexy sutures. The trachea is pexied back to the spine, and the esophagus falls back into the right chest. Very quickly, 3-kilo baby undergoing esophageal atresia repair. Would anybody do recurrent laryngeal nerve monitoring at the time of the index operation? Or would you only do this in a reoperative setting, or would you do it if you're going through the neck? So the audience poll is no, depends on the subtype, only with a cervical dissection, or routinely.
I would love to do it, but we don't have that size available in Chile.
And I think that's one of the big challenges in doing it. Is
and
getting
we've seen the videos of how to adapt one of the big laryngeal nerve monitor electrodes to a tiny tube, but we have not been able to make it. Oh, sorry, I have not been able to make it work.
Yeah, it's really challenging to do, and I think to your point, it's hard to modify this for small endotracheal tubes in children. I think we injure recurrent laryngeal nerves maybe more than we appreciate in 11% of patients, and this may be an underestimation. H-type injuries, which are often addressed through a surgical approach, is up to 50% of patients. Injury rates may be higher during a thoracoscopic repair when you're mobilizing the proximal pouch. There is some data out of Boston that shows that intraoperative recurrent laryngeal nerve monitoring appears to decrease nerve injury rates in high-risk cases, which they defined as esophageal, tracheal, cardiac, or a combination thereof. So I think there's merit in it, but this is probably something that's going to take a while to get widely adopted, in the sense that modifying the electrodes to small endotracheal tubes and troubleshooting that is challenging, and there's definitely a learning curve to it. Any other comments or questions?
Great, thank you. That was perfectly on time. Thank you, man. That was awesome. Thanks, Matt.
Stand by for intro.
What? All right.
Intro?
Yeah. All right. I told everyone this goes fast. We're going to move on to the next one now. We have Dr. Juan Guria from Cincinnati Children's, who's going to be talking to us about robotics. What's that?
Oh, 15 minutes. That way, so, yeah.
You're good, you're good.
Oh, there you go. Thank you, Todd. I love this meeting. My goal is for you guys to convince me to drop robotic surgery, because I'm about to ask my boss right there for a new robot. So let's talk about rapid fire robotic stuff, okay? Who is doing robotic surgery here in the audience? The ones who are not lifting up their hands, who has a robot available?
All right, so for the audience, 4 people out of like 30 or so raise their hand that they have done robotics.
And another 12 they have available, but they don't use it. Why not? Sizing kids. Okay, convince me for that, okay? So, 3-year-old, 15-kilo adrenal mass. Who is a candidate for robot case here? Choledochal cyst, 6-kilogram baby. 11-year-old mediastinal, obese. 15-year-old gallstone pancreatitis, horrible gallbladder. There's nothing like a laparotomy. Mexican robot right here. I love this, gallstone panc, perfect case for robotic, right? You go a little bit to the right, take care of the gallbladder, forget about the pancreas. Never mess with the pancreas. So why not the other ones? All these are perfect cases for a robotic approach. 6 kilo colorectal cyst, perfect case for robotics. Okay, adrenal mass, perfect. Neuroblastic tumors confined to the adrenal mass, perfect case. Dr. Aldrich right here will not let me lie about that. She's using it for this. Okay, excellent. Rapid fire, a lot of pros. Some cons, but convince me. If you don't agree on my pros, please let me know. Perfect 3D, perfect visualization, tiny incisions. Once you see them in the clinic, they're as tiny as your 5mm port. Okay? Please close the fascia. All the other stuff, yes. Do you guys know about degrees of freedom? I'm not an engineer, but the hand has 6 degrees of freedom for mobility. Robotic has 7. That's unimaginable angles that you can reach with a robot up there near the diaphragm, back near the cava for the right adrenal. You can do it, okay? That was my attempt for AI. So some cons listed kind of like pros, but tell me about this. Shortening the learning curve. People think, oh, it's going to take me so long to learn this robot. Open to lab, massive learning curve. Lab to robot, a lot of you guys do MIS. Now you have a 3D camera and a wrist inside that moves with you. Why not use it? The 8mm ports? What do you guys think?
Why don't people use the people who have access to the robot who don't use it? Why don't you use it?
8mm ports. Okay.
8mm ports, and it's not cost effective for us, so
we'll talk about cost in a sec. Awesome. Yes, boss.
I don't mean this, but I'm sure there's people in this room that feel this way. I can do it as good laparoscopically as I can do with the robot. And I'm just going to rip the Band-Aid off and say that because I'm pretty sure people feel that way.
I love it. Let's talk about a median arcuate ligament release. Would you guys do it laparoscopically or open anymore? Going back into that angle near the celiac trunk. Right? We will never do it lap anymore. No, we will never do it open. Use ICG to look at the vessels. It's game changer. So laparoscopic versus robotic, right? You have 3D, you have your wrists. Have you guys been doing 12, 14-hour cases like this, right? You're sitting in your console, head straight, neck straight, life changer, right?
So the concern I have is you have to have cases lined up to get the training. So you have to go through the training.
Yes.
And I can't think of enough cases where I initially would use this that they're big enough that it makes sense with the port size. So I would have to have 3 cases and big kids lined up to do this. That's why I don't do it.
3 gallbladders to do. Line it up. You're not lifting the weight of the patient anymore.
Are there FDA indications for the robot for pediatric surgery?
Great question. No. Great question. No. And by the way, no robotic system pays me at all. Disclosure, I have 0. Okay? No, there's no FDA approval for it for pediatrics, but it should be coming soon from different systems, different consoles. So talk about, training centers and how long it's going to take me to be efficient on this, right? If we look at laparoscopic versus robotic, not only the learning curve is better, right? Your time to efficiency and time to reduce your operative times is way faster than laparoscopic after a few cases. So you're talking about cost. After a few cases, you're decreasing your operative time. Initial cost for robot is high. I'm gonna talk about that in a sec. But all the pediatric fellowships are integrating this. We're graduating currently fellows in Cincinnati Children's training robotics for a reason. This thing is here to stay. Remember the first laparoscopic towers, right? You're like, nah, lab collie, don't do this. This is here to stay. We're getting more and more robots available, right? So you have a perfect depth perception. Some people say you cannot feel anything. New systems you can feel, by the way. In the current system, you can tell when the suture is about to rupture, expresses a little bit of water out of it, right? But you get your feedback from your eyes. You get used to it. It takes only a few cases to do that. There's no tremor for the older guys back there, right? There's no tremor anymore, right? Yes, sir. So speaking in specific cases, colorectal gallbladder, right? Lower conversion to open in the robot than laparoscopy. Cholecystectomy, slower, bile duct injury risk, okay? Now, it takes longer to set up. If you train your system, if you train your personnel, it will take the same amount of time to turn over the room for robot than for lap, okay? We're at 30 minutes currently. So, this is key in a gallbladder case. Your cases needed for basic proficiency, 20 to 30 laparoscopy. These are the current numbers, robotic 10 to 15. Is decreasing the amount of cases in half to go to advanced efficiency and proficiency in a case, specifically for your trainees. So that is gonna decrease your operative times. That is gonna decrease the cost of the robot, that initial cost, which is around $4,000 in most institutions. So here it is. If you train as we talked, 30 minutes for turnover, create a lean process. Don't open all the trays of the robot. Peel pack them. You don't have to waste money on those trays. If you don't open them, they don't charge you. They charge you by the use, right? Again, nobody pays me for this, okay? And I hope there's more robots coming, not only the current one that we have. I don't know if I should be showing these numbers. My boss will tell me in a sec, but $4,000 more than lab initial cost for that case. But each additional 15 minutes is the exact same as laparoscopy. So when you reduce your operative time at the end of the day, which I fact-checked myself against my partners in gallbladders, I'm faster in the gallbladder with a robot than laparoscopy. I didn't want to show that because my partner is there, but but that will decrease the cost. So speaking for Todd, what are the cases? I don't have cases. Gallbladders, appendix. Don't do it for appendix.
Don't do it for appendix, and most people don't have a ton of gallbladders either. So it's appies, hernias, and babies.
It's a very simple operation. Don't make it complicated, right? It's awesome.
Yes, so next year, I mean, like it doesn't. The cases you would do every week, unless you're getting a ton of gallbladders, most pediatric surgeons have babies and appies and hernias.
Well, let me show you some
Cincinnati
cases.
Children's is different. Yeah.
Let me show you some cases. You're saying I don't have the patience. This is from our institution. What have we done in the last year and a half? I'm not going to read them to you, but perfect cases. Thymectomy, go for it. Diaphragmatic hernia repair, not the newborn. Extra lobar sequestration, right? All the urology stuff, all right? There's no urologist here, but they love this robot. You can do everything there, right? J pouches, we have colorectal surgeons here. What about, this is a picture from Miles. Would you guys go in there laparoscopically in that angle? Can you do it? Yeah, we can do it, right? Half the time with the robot than laparoscopy. That's the aorta and the C-electron. Fundoplications, perfect case for a trainee to make those sutures. Morgagni hernia, as Dr. Cordova was mentioning, perfect for this. Colorectal cyst, I cannot stress this enough, perfect case for robotics. Have you tried to train your fellows to suture that hepatic ostomy laparoscopically? Can we do it? Yes, and we're very efficient at it. But this is a game changer for that. Miles? Adrenalectomies, you guys have done it really well back there. We do it too in Cincinnati. I think it's a no-brainer. You can see those adrenal arteries being supplied by the renal and the diaphragmatic and the aorta. You can see them live right there in front of you. What about pancreas? Whipple is coming in some institutions. We do all the distal pancs like this. Splenectomies without a splenectomy is a perfect case. FIOS, partial adrenalectomies. You can see exactly where the tumor is delineated if you use ICG. No brainer. Who's using it for tumors here, other than Dr. Aldrink? Try it. Neuroblastic tumors confined to the adrenals. Why not? In the chest, neuroblastic paragangliomas. Sure. We're expanding in Cincinnati Children's to transplant. We've done donor nephrectomy. We're going to expand to liver because imagine that dissection in the veins with 3D and wrists. Yes.
I think the robotic nephrectomies for smaller size tumors and robotic partial nephrectomies are great cases to do that way.
Yeah. Some tips, because they're like, 8 millimeters. I don't have enough space between my pores. They recommend 6 centimeters. Select your patients well. Take over early, right? With your trainees, you can just swap. You're in charge right away. Take over. Don't wait for them to like get into bleeding. Position patient first, then dog your robot. Play with your choker position. It does not have to be a straight line that they say. Play a little bit, especially with smaller babies. You only need 3 centimeters between the port. Pull it back to the thinner line. That increases your angle outside dramatically. They don't recommend this, but it works. And there's no problem with your incisions. Use 3 ports when able for smaller kids. Is there a question, comment?
So the one comment, you're talking about robots. So everybody I think in this room probably knows Yuri Kozlov from Russia. He's done like 300 plus robotic cases. He was in Phoenix when I was still there. And he gave a presentation, and we had about 10 general surgery residents in the room. And I asked them, like, what percentage of minimally invasive surgery are you doing robotically? And to a person, they said 75 to 80%. So whether we like it or not, the people that are going to be coming into our field to do pediatric surgery, they are not going to be doing laparoscopy. They're going to be doing robotic surgery. And so we need to embrace this and be prepared for that, because otherwise we're going to try and teach them a whole generation of people who have never done laparoscopy. And we think they're good now, but they won't be good. They'll be used to doing robots. So it's the reality of where the future's headed in terms of our field of doing robotic surgery. We're going to be doing it, whether we like it or not. So we may as well embrace it and start doing it now.
Yes.
First of all,
agree with that.
I want to be a believer, but let's take a broader scope. How could we make this international standard when the initial acquisition cost for this is so much bigger when compared with other MIS tools?
I agree with you, and I've trained through Mexico and Mexican, so I hear you. This is not a standard of care. We're not implementing standard of care. This is a tool. It's like when you bring your ligature, I don't get paid for that, but ligature into the room. You bring the robot. It's a tool, an aid to help you with efficiency, with cost, with getting to those angles, to MIS benefits, right? It's just an aid, a tool that you can bring. It's hard internationally, of course, yes, it is, but you need your backup from your institution for sure.
With Moore's Law, every year technology gets half the size and half the expense. And it's taking longer with robots. Eventually there will be competing companies, the technology will cost less, and the size, I do think it's going to be a lag.
It's great that they're competing, right? Competition is awesome. They're bringing better and better robots. I'm going to go through some of our recent cases. Oh. Sorry, go ahead.
Okay, so I think we failed to convince you to drop robotics. That's okay.
I'm going to show you that.
And it might be the Grinch of this talk, but why does robotics avoid the trial of the clinical evidence? Like everything we do, so I see lots of arguments, pros and cons, and I've seen a lot of this enthusiastic, of course I want those angles, of course I want the ICG, the good view, everything you said, it's okay. But I have seen very few clinical articles, and robotics is not that new, And the studies have been done, and it's always equivalence. And with that, I do not convince my hospital manager too. And I think costs are going to drop, but we should not be doing something because it's cool or because it's cheap. We should be doing because it's better, but clinically proven better. So where is that?
I think that is a key. And let's not get confused. We're not trying to implement guidelines. This is MIS, period. It's just like having a better instrument in your hands that gives you wrist, that gives you access to those angles that might have caused a bleeding otherwise if you're super stiff. But now you can get under that vein. This is not about being cool. It's about efficiency and outcomes. Less cases to, no, it's proven now. Less cases to proficiency, less cases for decreased length of stay, less cases to have outcomes. It does not impair outcomes in oncologic surgeries either. That's been published also, right? For certain tumors, right? So I guess this is not trying to implement a guideline. It's just a tool that would not make you cool, but it's proven to cause better efficiency, better outcomes in MIS.
Well, I'm going to push back on my most honorable surgeon, Dan. I think that the new generation, we're not going to develop a 3mm robot. right? And we're not gonna have 3 millimeter wristed instruments. So what I'm seeing is the people that are coming across now in training from these programs where they're doing a lot of robotics, they can't tie, they can't sew. And if they can't do that, you know, with a 3 millimeter instrument, that's gonna be a problem because it's gonna make their learning curve even harder.
What we don't know is it might be coming. Remember, we were talking about the first laparoscopy towers. New robots, smaller robots are coming. We just seen the tip of the iceberg for MIS.
I think also with the age of social media and patient selection or patient choice, people are seeking out, particularly in adult centers, you know, where can I get my robotic Whipple done, and I'm going to go to that center. And so this isn't going away, and I understand there's not a lot of direct comparison or science that shows it's superior by far, but patients are going to be asking for it. And as the technology improves and things get faster, I think it's going to be more.
Yeah, this is a quick picture of the colorectal cyst. With the use of ICG, you can get really far back into the head of the pancreas to get that tapering down. Okay, so that will decrease your chances of having a cancer in the future. Like 1 minute. 1 minute left. Yeah. I'm almost done. The new systems are coming. They're already here. DB5, you guys have seen it. Again, I don't get paid for this. Senhance, right? The Mira, like consoles, different open console technique. Like tiny robots, like the one you see on your right to triangulate for a thyroid, for example, without a tremor, without, you know, chances of injuring nerves, right? So, but look at this, Japanese, they have pneumatic systems that reduce the force application by 83% and with tactile sensors. So things are coming, things are changing. We're gonna have a talk on AI, but image-guided robotic surgery, right, for vessels, for tumors, for lymph nodes is here to stay. I hope I can convince you about this.
Yeah, all right. Is that okay? You want to take like a 2-minute break? Okay, we're gonna run right through. Here's the deal. If you guys have to take a break, you can just go on your own. Let's skip through the breaks. And then we have another one after this, so. All right, we're going to move on to the hot topic of ERAS. Do we have Ben? Where's Ben? Yeah, all right. Go ahead. So here's Mira Kodagal from Cincinnati Children's.
All right, we have a ton of people coming up because we're going to talk about lots of different things ERAS related. But we are going to start with Ben, Dr. Ben Ham, who's going to go over some principles of ERAS, just so everybody's on the same page, and then we'll launch into lots of different ways in which you can use these tools.
So we'll cover a few different areas: neonatal ERAS, colorectal ERAS, thyroid and oncology ERAS, but we also wanted to just take a moment and discuss that all these principles that we'll talk about for these specific surgeries, can we also apply them just in general to every kid we take care of, or nearly every kid? So first case, a case is being scheduled from clinic at your institution. The new resident is working on scheduling the patient and pre-op orders. So which of the following is true at your institution? ERAS principles have been incorporated into scheduling, patient education, pre-op and post-op order sets for no surgeries, some pediatric general surgeries, almost all pediatric general surgeries but not others, almost all pediatric surgical subspecialties, or what is ERAS?
What about in the room? Can folks raise their hands? Who is doing some version of ERAS in some cases at your institution? Is there anybody in the room not doing any ERAS at all?
About half and half.
Come on, raise your hand. Okay.
None. So looking at the poll, it looks like almost half are for some pediatric general surgeries. 16%, almost all pediatric general surgeries, but not others. D is currently, looks like about 12%, almost all pediatric surgical subspecialties. 10%, what is ERAS? So some opportunities there. and about 15% not for any surgeries. I know Mehul will talk some about for colorectal surgery. As we were going through everything with the trial, we worked to incorporate it not only for pediatric colorectal surgeries, but also for any patient coming through clinic. So we built the same things in terms of optimizing clear liquids, pain control, avoiding opiates, et cetera, into all of our pre-op scheduling. And then also, as we did it, we had other departments also be like, oh, what are you doing? Can we be involved in that too? And so plastic surgery, it's in the orthopedic surgery order sets and several others too.
Hold on. Whit just brought up a point, just to make sure we could say what ERAS is for the world here. So it's enhanced recovery after surgery.
He's gonna do it right now.
Yeah, okay.
Have it right there.
Yeah.
Yep. Enhanced recovery after surgery. And it consists of many elements and principles, and various papers will delineate specific ones, but they can be applied to most all elective surgeries. And in order to be successful with it, it does require significant system design, education, and reinforcement of that education. And I know some have worked to decrease opioids after appendectomy. At our center many, many years ago, it was 84%. And then I know David worked to decrease that with some ERAS principles. And then most recently in our NISQIP report, we were down to 0%.
You have about 1 more minute, Ben.
And so here are some common ERAS components. I'll put these up there, but not going to go through all of them. But many different things can be done to try to speed up the patient's recovery, get them home quicker, and get them back to being kids. And so these things have the potential to improve care across the spectrum of pediatric surgical subspecialties. And it takes a lot of work in terms of scheduling, building the system, patient education, and getting your team on board in order to be effective with these.
All right, we are going to move through some topics and actually give you examples of different ways in which people have used these principles to improve outcomes for their patients. So I think first, oh, that's backwards, sorry. Dr. Hoffman.
Hi, I'm Cassie Hoffman. Nice to meet you guys. I'm from Akron Children's, and I am going to be presenting ERAS for neonates, our smallest patients. So here's our clinical scenario. We have a 10-day-old female with intestinal atresia. She's scheduled for an XLAP for primary repair, currently in the NICU, vital signs are stable, and she's on room air. So here's our poll. Is this patient a candidate for neonatal ERAS? No, this neonate is undergoing an XLAP, so it's an open abdominal procedure. Absolutely not. Yes, B, or C, unsure. It's difficult to manage neonates perioperatively.
So for folks in the room, are you guys using ERAS for your neonates? Is anyone doing ERAS for neonates? The folks behind me are. No one else? Dr. Lee looks confused about the question.
All right, so I see a lot of yeses and unshores. About 52% yes, 28% unsure, or 30% unsure, and then 16% is absolutely not. Okay, so the answer is yes, according to our literature. So the World Journal of Surgery came out with a consensus guideline around 2020. Okay, so this was for intestinal surgery only for neonates. And then after that, there was a more broader guidelines that were developed just for ERAS in essentially all neonatal surgery. So there's multiple consensus guidelines that exist for these neonates that are undergoing surgery, and how do we apply ERAS for our smallest patients? So this is from our World Journal of Surgery guidelines. We have our pre-op guidelines. Okay, so we're going to have our antibiotic prophylaxis, we have our conservative transfusion guidelines, and then we have this big thought about perioperative team communication and how that's going to be one of the major goals of establishing this at our institutions. Intra-op care, it's still multidisciplinary. Now we're with anesthesia. We have opioid-sparing analgesia. We're going to have regional techniques that we are establishing at our centers. We also have that scheduled Tylenol, perioperative fluid management, just as we have with our older patients. We're preventing hypothermia, and then we're getting that primary anastomosis. And then post-op, again, with our NICU team, what we're developing collaboratively, we have that essential handoff, right? Our communication is essentially key for this. We're doing our multimodal opioid-sparing analgesia. Hopefully we were able to do some sort of regional technique. We still have that scheduled Tylenol. We're going to have our perioperative antibiotics. We're stopping in less than 24 hours of surgery. We have our post-op nutritional plan. And then we also have parental involvement, which is huge, right? We're getting the parents involved right once we get up to the NICU with that handoff.
Okay, I have lots of questions, some of which I think you'll probably get to. But what are you doing for regional in the Tiny Tots?
I'm going to get to all of that.
Okay.
Sorry, I'm going to be quick. Okay, so I wanted to first go over the quality and the strength of the evidence, because before I talk about what we do, I think it's really important to dive into the literature and show that this is why we're doing it. So in the 2020 World Journal of Surgery consensus guidelines for intestinal neonatal surgery, we are going to have moderate evidence for regional anesthesia and also high. So we have, in this box, we have, sorry, I misspoke, high quality, strong evidence for the regional, and then the opioid sparing is the moderate and strong. So regional anesthesia, what are we doing? That's our next one. All right, so let's blame anesthesia. Some anesthesiologists may or may not be really comfortable blocking neonates and using fascial plane blocks. My ideal fascial plane block for a neonate would be the QL block. Why? Because it has great dermatomal coverage. It can be T6 to L1 to 2, depending on how you dose it. And then it also isn't going to have any sort of limitations with anticoagulation. So if you're worried about coagulopathy, this is still a fine block to do. And so let's say, this is from one of the papers, right, with the guidelines and implementation I guess, blocks, or what are we going up against? So this quote that I added, I hate words on slides, but I thought this was extremely important. I guess the one thing that maybe I might not have done would have been the regional blocks. There's a bit of discussion, that's a bit of a discussion area. But then I found a colleague who was quite keen on doing regional blocks, and he was quite willing to help. So that was great, but that may or may not be feasible. This is a quote from an anesthesiologist in one of the guideline implementation papers. So then my response to that is, what about the original greats of regional anesthesia in neonates, such as the spinal and the caudal? And then if you want your caudal to last, you can always put Precedex in it.
About 2 minutes.
Okay, I'm gonna be really quick.
It's quick, it's fine, we're moving
Sorry,
through.
I'm trying to move fast. So the caudal. I think pretty much everyone can do this block that's a pediatric anesthesiologist. If they have trouble, we can always go in with ultrasound to do the caudal and do landmarks. So this is what we call the frog eyes view. It has our cornea on either side, and then we have our sacrococcygeal ligament in between. That's where we would go for that block. So if someone's having issues, we can always get our short axis view and then go into long axis and make sure that their injection is appropriate. Spinal, so original great number 2. This obviously isn't going to be for every case. It's not going to be for every abdominal case especially. And you are limited on surgical time, right? We got to be ready to cut if we're doing a spinal, and the surgery can't be longer than 120 minutes, ideally 90. So it's not for every patient, and it's only for certain surgeries, and it has to be well indicated. To prolong or not to prolong. Let's say we have an anesthesiologist that doesn't feel comfortable doing fascial plane blocks. That's fine. I guarantee you they're probably comfortable doing a caudal. I'm an anesthesiologist, I can say that stuff. But we can make the caudal last, okay? So you can still get a big bang for your buck if you put Precedex in the caudal. It can prolong the caudal. This table specifically is from a meta-analysis in kids less than 1 year by Regional Anesthesia and Pain Med in 2021. So it's not that new. People probably know about this. And also, most of your institutions probably run Precedex infusions in the NICU now. That's something that's really started in the past few years, and so they have a lot less hesitancy to use that drug and to put that in our regional. Okay, sorry, I'm running. All right, buy-in, it's hard, and I already went over some of the implementation issues.
Awesome. Thanks, Dr. Hoffman. Super appreciate it. Okay, I think Dr. Revolve. I think this one, yeah.
All right, thank you. And that's a really hard topic to tackle. I would say that if of all the things that we're trying to do in terms of enhanced recovery after surgery, the neonatal population is probably the next big frontier, and we absolutely need more data and evidence. But it's challenging, and a lot of the challenges relate to the implementation woes. When we talk about enhanced recovery as surgeons, we as pediatric care providers are oftentimes getting our inspiration from our adult colleagues who are years and years ahead of us. So for us, it's not a foreign concept. I would say even for our anesthesia colleagues, it's not that big a leap to embrace some of the enhanced recovery principles. But really keep in mind that our neonatology colleagues, they do not know what ERAS stands for. They do not know what enhanced recovery means. The concepts that underpin an enhanced recovery protocol are really challenging in a complex environment like a NICU. And so as we go on this journey, and that was a really fantastic talk, I would say to everyone, it is going to be a journey. It's going to be a step-by-step thing that we're going to have to work through. I'm going to pivot and talk about where it's a little bit of an easier sell, this idea of colorectal or GI surgery. And I'm going to share with you some data from a recently completed 18-center step wedge randomized clinical trial that we just wrapped up earlier in the summer. And I presented some of these data at APSA in May, and so this will rehash a little bit of that. So the topic here is maybe we're going to talk about the current state, talking about some of these enhanced recovery principles, and then share with you that trial data. So here's the clinical scenario, which I think is a very real situation that could happen even today in 2025. 13-year-old Crohn's disease has a stricture that's refractory to medical management and now needs an elective intestinal surgery, an ileocecal resection. Coming into surgery, she's lost some weight. She's told by the pre-op nursing team that calls her the night before surgery that she can have nothing to eat or drink after midnight. We usually are going to treat her pain with opioids in the OR and after surgery. She has an NG tube, a Foley that stays in place at the end of the case. She's told that she can't eat or drink anything until she passes gas. She's given IV fluids and boluses overnight, and she's in the hospital for about a week, right? So this is kind of, imagine a current state of affairs. So here's the poll for the audience. What are the most challenging aspects of implementing an enhanced recovery after surgery protocol at your hospital? Is it that we're having issues with early advancement of diet? Is it family engagement and education? Is it getting these patients up and moving after surgery? Or is it just changing the overall culture?
Can I pick one that's not on your list? I make our team turn off IV fluids on post-op day 1, and it makes everybody profoundly uncomfortable because the kid may not be drinking great or may not be necessarily taking a great diet, and people are really nervous about not having the fluids running,
Absolutely.
even though that's one of the principles.
Yeah,
so that's
for
somewhere
sure.
in the changing culture probably bucket.
I like it. I like it. Changing culture, yeah. All right, I'm not sure if we have audience. Okay, here we go. Changing culture is the dominant one. It's actually a trick question. The answer is all of the above. These are all challenges that people face when trying to implement enhanced recovery. And so once again, I'm going to tell you a little bit about this trial. 18 centers across the U.S. We enrolled about 600 patients, 10 to 18-year-olds undergoing elective GI surgery. We picked this because this was the closest approximation to what the adult literature was telling us, right? So this was very much so a segue to introduce enhanced recovery to us as the pediatric care providers. And so I'm going to tell you some lessons that we learned from this trial that are going to really hit home, I hope. The first one is this idea of decreasing perioperative fasting. And Ben alluded to this in the introductory comments about this field, but in general, what we're talking about is a horizontal integration. Rather than trying to reinvent the wheel for each and every procedure or specialty that we wanted to implement an enhanced recovery protocol, at Lurie Children's, where I work, we were able to get our anesthesia colleagues, to work with our nursing colleagues, and to change the overall policy to where we were now going to allow patients and educate patients and counsel patients across the enterprise for all of our surgeries that they could have clear liquids up until an hour before surgery. And so rather than, once again, reinventing the wheel, this horizontal integration is a great lesson learned and helps with implementation. This is Colon Man. This is from Le Bonheur Children's in Memphis. They were one of our participating sites, and they worked with the patient stakeholder group and came up with Colon Man. And this was put up in every patient's room. And as the kids progressed through their hospitalization, you progressed through the colon, and eventually you were discharged. So this is fantastically cute, works on multiple levels. But this is where you can really find ways to integrate the enhanced recovery principles with your patients and families and have them be a part of the stakeholder group. Our colleagues down at Children's Memorial Hermann Hospital in Houston, Texas, they were struggling with getting these patients up and ambulating soon after surgery. Everybody knew that they needed to do it, but the patients just weren't motivated. And so we suggested, well, can you get your physical therapist to come by and see them? But they had a paucity of physical therapy availability. But what they did have were these wonderful child life support dogs that would come by, and the kids would get out of bed and walk the dogs. And they were highly motivated to do that. And it was something that was, I would say, embraced by the patients and families. Ultimately, the social workers or the child life support workers would actually leave a note in the chart saying how far the patients walked and how many times a day they took the dogs for a walk on post-op day 1, which then met the need of being able to check the box for compliance with the early ambulation metric. And then last, this is a screenshot of some pictures from Cohen Children's in New York, where they celebrated the launch of the enhanced recovery protocol at their institution. They had the C-suite really buy into this. They made T-shirts, they had cake and balloons in the lobby, and they really made it a big deal, because it is a big deal, to really change the paradigm. And this is how you change culture. You make it a priority for all of the people, from the frontline staff to the patients and families and everyone involved, and it really does help you celebrate success. So the trial data, really quickly, how much time do I have? 1 minute. Trial data in 1 minute. 600 patients enrolled across a 5-year time span. They were undergoing, I would say, some real deal surgeries, proctocolectomies, ileocectomies, et cetera. And what you can clearly see is here's the distribution of the number of elements that patients received. And the take-home point here is that median of 13 elements. Of all the different bundles of enhanced recovery that are out there, when we put ours together, what we saw is that when you reach that threshold of 13 elements being delivered to a patient on a day-to-day basis, we could actually see a significant decrease in length of stay associated with that. And in addition to the length of stay improvements with 13 elements or more, we see the number of patients that have a prolonged length of stay of 7 or more days, the proportion that have that decreased significantly. The amount of opioids that we're exposing these patients to decreases, and our complication rates are actually lower.
Hey,
So-
quick question. I don't know if you're going to get to it, but when ERAS came out, I loved the idea of every single thing. And at the same time, and many of us were really skeptical about doing bowel preps. And that's kind of, the elephant in the room maybe on colorectal ERAS. But there was a time not long after ERAS came out that there was an evolving kind of fuzzy set of data showing that if you bowel prep in some way, including oral antibiotics, there seems to be moving in the direction of better outcomes. But early ERAS was no prep. So is this the evolved ERAS with colorectal including a prep or no prep?
For this study, we made it dealer's choice because there is a lot of literature swinging one way or the other. The reality is that you should not do a mechanical prep without the oral prep added in.
Without antibiotic.
Without an antibiotic oral.
Both or not.
That's right. So if you're not going to do neomycin flagyl or whatever your choice is for antibiotics orally leading up to the time of surgery, you should not be doing mechanical prep. That's for SSI and anastomotic leak rates. In general, though, what we found is the same thing that you talked about, which is really you should do what you feel comfortable doing. There is a lot of fluid shifts that occur with the mechanical bowel prep. And then going back to Mira's earlier point about IV fluids and the need for boluses, we do think that limiting the fluids will enhance the recovery. So that's all part and parcel. Same clinical scenario. Fast forward. I'm not going to read through all the details, but there's a way to mitigate each of the things that I talked about when I introduced this 13-year-old girl to you all earlier. And ultimately, the hope is that by doing all these little things, you put them together in the bundle, and implementing the bundle is the real challenge. But if you can implement that bundle, your outcomes will be better.
Thank you. Awesome. All right, I think Dr. Aldrink is next, I think. Yes. Here you go. Dr. Aldrink's going to talk to us about thyroid.
All right. Make sure I do this right. So you may think, why is ERAS important for thyroid? We do pretty good. They spend the night, like who cares? There's probably only maximum 30 patients a year you might see compared to our other discussions on neonatal and colorectal. But thyroid is important surgery. If we can make progress, we need to make progress. And as Mehul mentioned, we do kind of follow the guidelines and the steps of our adult colleagues, and they're doing a lot of outpatient thyroid surgery. And so, why is this not a safe or appropriate application for pediatrics? And so I'll just go through this a little bit too. We all know, particularly for some of the rare diseases, that surgical volume and outcomes, surgical volume impact outcomes, and particularly this has been shown for thyroidectomy. And I won't go through these, but just to remind everybody that. And so here's a particular clinical scenario. You have a 15-year-old female who's referred to endocrine for amenorrhea and some fatigue, pretty normal vital signs. On exam, she has an enlarged neck, left neck with a 4-centimeter palpable nodule that's appreciated, so labs and ultrasound are obtained. She's mildly hyperthyroid, and here's her ultrasound, which shows a thyroid nodule, and her nuclear med scan shows that this is active. So you have a 15-year-old with a hyperactive autonomous nodule. And so she's referred to your office, and in your mind, she's a candidate for same-day surgery, but you want to ask your colleagues. And so how would you manage this patient? Total thyroidectomy and observe, left thyroid and observe overnight, left thyroid as an outpatient, or because of her amenorrhea, just refer her to a gynecologist and follow the nodule.
I'm just even curious, how many people in this room have somebody in their practice who does thyroids, or how many people do their, yes? Do a lot of people have ENT folks who do thyroids at their institutions?
No.
Okay, so mixed bag.
Yeah. And while the poll is going in, I think I'll make a comment on that because I do think it's really important for some of these rare diseases that we were talking about, esophageal surgery earlier. If you have the capabilities and you have the setup at your institution, and not everybody does, but to make these as sort of subspecialist. And so at our institution, we actually partner with our ENT colleagues. We have one ENT surgeon and myself who do the cases together and collaborate together, and it's a really nice program. Okay, so I think most people would do left thyroid lobectomy and observe overnight, so I'm glad that that was the majority of the answer, but there's a good number of people that would send the patient home. So useful topic that we'll kind of go through. And so at our institution, we would do a left thyroidectomy as an outpatient. And so standardizing care improves outcomes across a lot of surgical diseases. At our institution, we developed an EPIC order set that basically starts from clinic all the way to post-op care. And someone had mentioned buy-in. I think Dr. Hoffman had mentioned buy-in, and this really includes, from clinic nursing to anesthesia staff to the perioperative nurses. And so, with the ultimate goal to facilitate same and safe same-day discharge and enhance parent and patient satisfaction. And so that was kind of our goal. And we, many institutions may be doing this. We just recently published on this, a single center study, which we hope to kind of collaborate with some other institutions and see if we can show the same patient satisfaction among, varying types of practices, but an enhanced recovery for a single lobe thyroidectomy with the goal of being compliant with these process measures to about 80% and facilitate same-day discharge. And so the key drivers for our quality improvement plan for here was minimize variation in care, optimal analgesia so they're comfortable going home, and then of course minimizing complications. And these were our interventions, again, starting with developing clinic order set, nursing education, and really just setting the stage for the family and the patient that we expect you to go home, except for a few particular instances that we would go over. I think one of the important factors is adding a preoperative selective COX-2 inhibitor. We use Celebrex particularly, and we start that the night before and the morning of surgery and continue that twice a day. and the patient can stop that when they no longer need it. But instead of giving intraoperative NSAIDs or things that might not work in time, they've sort of been loaded with that. And then multimodal pain control with minimization of opioids in the operating room and then the peri-op or post-operative care.
One more minute.
Okay, I'm almost done. This is our study, and essentially we had 100% compliance. We had one patient that did require staying overnight, and this was just over a year, so it's a young study, but we had one patient stay overnight who had some substance abuse in the past and had some postoperative nausea, and so we just elected to watch her overnight. Importantly, no complications, pretty significant change in our length of stay, no change in emergency room visits or urgent care, essentially none. We implement a post-operative phone call, 48 hours, just to touch base with the family and the patient, make sure they're doing fine. Everybody was extremely, 16 patients in this small study, and everybody was very happy by going home. So, and essentially, practice guidelines, standardization in all phases of perioperative care can improve outcomes or improve patient satisfaction and facilitate same-day discharge. So,
awesome. So, thank you. I have the last topic for this session, which is oncology stuff, and I'm going to blaze through this because we've talked a lot about these principles. But this is a patient with a 10-centimeter right renal tumor who undergoes an upfront nephrectomy for management of their renal tumor. So what would Siri would like to know if I need anything, unfortunately. What would people do in the room here? Would folks use ERAS for this? Would folks use ERAS for this case? Yes. Siri has a lot to say today. Okay, so if this, this is the poll that we have, and it really looks like the majority of people would actually start clears on post-op day 0. I will say that when we started doing ERAS for oncology cases about 3 or 4 years ago, this is a big deviation for us from what we had been doing before, and so it was a real change in practice for us. So
I will do that case robotically.
Dr. Ria is working on his introp spill, so he's going to do a 10-centimeter renal tumor robotically. So we could start. We would start clears on post-op day 0, and then work to advance. And I think that's been a huge change for us. So these are our what we use. This was actually a study that was created by Kyle Rove out of Colorado, and Cincinnati, St. Jude's, and Colorado were the 3 sites that participated in this. And so these were the guidelines. They're very similar to what everybody's been talking about in terms of opioids, fluid reduction, early feeding, and then regional pain management. And so I'm not going to spend time going through all of these, but what we found were very significant improvements. So these were abilities to reduce, by just having the protocol and asking people to follow it, we were able to reduce opioids in the operating room, we were able to get to early feeding, and to reduce postoperative opioids, and then we actually saw a significant reduction in complications for these patients as well over the course of their stay, and then obviously here significantly improved pain scores. And so this was the neuroblastoma subset of the population as a whole. But so for a lot of these big abdominal tumors, we're going ahead and doing ERAS with early feeding. And our length of stay, while it wasn't significant in this cohort, I think over time we've gotten much closer to a 3-day sort of postoperative length of stay as opposed to the 5, 6, 7 days that we used to have these kids stay on service. So I think worth remembering that ERAS is feasible for big abdominal operations, even the large retroperitoneal dissections or big tumors, and that using the regional anesthesia and minimizing opioids is key to that, and then using that to actually improve outcomes. So as many have said, we see better outcomes in these patients. So reduced complications, shorter length of stay, and then earlier, folks were able to get to chemo earlier, which for especially things like neuroblastoma is key to their long-term survival. So I'm going to turn it over to Dr. Huntington to wrap us up.
So I was just going to say, I think my takeaway from this session is we've gotten really good at doing ERAS for the patients that we are comfortable doing ERAS, and we've excluded some populations like the oncology patients, the neonatal patients. Oh, sorry.
Step into the square.
And I think those patients should be included, and everything that's been presented, all the literature seems to show, that they should be. And I feel like I've been doing it for oncology because I stole everything Jenny does in her practice. But the neonatal stuff, I feel like when we round in the NICU, I get in this time machine, And I go back to the surgeons when I was a medical student who say, you know, you have to wait for the NG to be clear and then having bowel function. And like, I'm not really sure they should be excluded to that degree. And it seems like the literature supports that. And then the final thing I would say, if you're starting these things, don't do it alone. Ask these people because that's extremely helpful.
All right. Thank you guys so much. This was phenomenal. You got a lot done in a short amount of time. Good job. We are going to take, yeah. All right, we're going to take a 10-minute break. And when we come back, we're going to be talking about central line management. So take a nice break.
Know there's someone working relentlessly. If you're struggling, know there's a team on your side, pioneering breakthroughs. If you're questioning, know we are finding better answers. Because in the pursuit of healthiness, we're changing the outcome together. Cincinnati Children's.
Some said Tiago had 1 week to live. But this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds. It's about changing them for all kidkind. Hope, care, cure. Seattle Children's.
Welcome to John R. Oshai Children's Hospital, a place of hope, healing, and miracles. Oshai Children's Hospital is one of only 43 standalone children's hospitals in the nation, and the only one of its kind in New York State. The only one. Why is that so important? Because our whole staff is specifically trained in and devoted to the care and treatment of children from conception to 21 years of age. Because the entire building has been designed with patient and family comfort as a top priority. And most importantly, because the best of the best practice here at Oshai Children's Hospital. As a teaching hospital for the Jacobs School of Medicine and Biomedical Sciences and the University at Buffalo, our physicians are practice and thought leaders, training the next generation of physicians to provide the highest quality of care to our community's children. There are many things that make Children's different from other hospitals, even beginning before arrival. By downloading the My Kaleida app, families can use its GPS navigation to get to the hospital. And upon arriving, it automatically changes to walking directions so that families and visitors have no problem reaching their destination within the building. Parking is plentiful, safe, and close. Whether you choose to self-park in the parking ramp located on the corner of Ellicott and Goodrich, or use our convenient valet service. Walking into the hospital is like Dorothy opening the door to Oz. Bright colors, artwork, playful interiors, and comfortable seating are just a few of the distinctive sights you experience upon entering. The lobby features a gift shop that's any child's dream. A Tim Hortons, which is many a parent's dream, and an entertainment space to host holiday parties, performances, and special meet and greets with local and national celebrities. Each inpatient floor has a playroom where children can put aside their illness or injury and simply experience the joy of just being a kid. There's an outside terrace that allows visitors to get a breath of fresh air, soak in the sun during our beautiful western New York summers, and enjoy a view of the cityscape that's simply spectacular. But at the core of Oshai Children's Hospital is our team of expert clinicians. Their goal is complex, yet singular, to treat and cure sick and injured children. They've devoted their whole lives to that goal, and every single day they give their all to provide healing and make miracles happen. And at the end of the day, that's what John R. Oshai Children's Hospital is all about.
You asked. We delivered. The all-new Stay Current MD app was built with your feedback and your workflow in mind. We've shifted from browsing to search first, so you get the answers you need faster. Search understands typos, synonyms, even clinical shorthand, because at the bedside, there's no time to waste. Whether it's protocols, podcasts, quick videos, or more, everything is at your fingertips. A fully redesigned experience with smarter search, customizable spaces, advanced discussions, direct messaging, cross-institution collaboration, and more control over your profile, notifications, and content sharing, all built to keep you one step ahead. The new Stay Current MD, smarter, faster, built for how you work.
There's nothing more important than our commitment to children. Our roots run deep, and we're always finding new ways to care. For more than a century, across the Mountain West, we've been dedicated to keeping the child first and always. Our team of passionate caregivers are combining forces in new ways to help children live their healthiest lives. It's the power of we. We're better together. Together, we're building something truly special. Together, we get to ensure the best outcomes for all patients. And together, with your involvement and generosity, we are building the nation's model health system for children. So, what does it mean to build a model health system for children? Intermountain Children's Health is the best outcomes for our tiniest patients, the nonprofit health system serving the most expansive pediatric geography in the United States, world-class hospitals, quality pediatric follow-up close to home, more than 1 million patient interactions annually, thousands of nurses specially trained to treat and support kids and the families who love them, nationally ranked subspecialty care, local pediatricians going above and beyond in their communities, a team of caregivers more than 10,000 strong, all united to help kids, caring for minds as well as bodies. It's finding new cures and delivering care in new ways, considering the whole child to help keep kids healthy and safe and out of the hospital in the first place, connected to our communities, accelerated by partnership, all powered by philanthropy. Intermountain Children's Health is and will always be the child first and always. Thanks to you. Join us in building the future our children deserve.
I'll just show off. No.
I'm just saying, I wrote you an email.
Yes, I got it. Thank you. It's nice to meet you personally.
All right, up next we have Dr. Nathan Fagan. He's at Akron Children's. He's an interventional radiology doctor. He's been at multiple Ohio children's hospitals too, so many of you probably know him. And this is our favorite topic of putting lines in.
Well, thanks everybody for having me here. So, we are going to talk about some updates, but really the main point of my talk is please don't forget about your friends in interventional radiology. So we're really happy to help you with these problems. These can be very complex patients, and also we love troubleshooting very simple things that can also be very powerful. So with that in mind, we're just going to kind of talk about a couple easy ways that I can kind of help you, and then where the updates come in, I'm going to show her some new technologies that, if you guys have complicated issues in access, you can come talk to me. But really, again, if you take anything away from this talk today, it's the power of friendship. So I think of us in IR and with my surgical colleagues are kind of two halves of the same coin, right? And really with these patients, there's a lot that we can benefit from one another, just helping out. So, I have a whole thing here where I was going to compare you guys. You guys are Superman, and I'm kind of Batman, and I'm weird mixing MacGyver too. And that might be why you guys forget to call us sometimes, right? Because like Batman's aloof, he likes to hide in the shadows, and you just have to put the bat sign up and hope that he shows up. I will say, if you can get a hold of us and talk to us, we love to help you with these cases. And so let's just move on and get talking through a case. And this case kind of spurred what I want to talk about today. So the clinical scenario is just a real simple thing. It's a teenager with a left subclavian dual lumen port. They have a history of subclavian thrombus around that line that was successfully treated with heparin. But the surgical team was consulted because, lo and behold, the medial lumen won't flush. Lateral lumen looks like a dream, but the median won't do anything. So I don't have any polls, but I kind of wanted to, I just kind of want to pick everybody's brain in the room. So here's the chest X-ray. Any thoughts on what you would do next? And keep in mind, this is not only the radiologist is going to figure this problem out in the room. This chest X-ray is otherwise normal, but in that clinical scenario, what would you guys do in the room? What would you guys do next if you had one lumen that didn't work? Yep, dye study. That's good. Any other thoughts?
Altiplace.
Altiplace is another good one. So they couldn't flush the port at all. They couldn't get anything forward, so that's why they didn't try Altiplace. So initially, they initially consulted the surgical team. Surgical team got a hold of me and like, hey, let's do a dye study. But they wanted it done the same day, and I couldn't do it because I was busy. We only have one room, and I pretty much took up the whole day with cases. So they then contacted the APPs on surgery, and the APPs are, okay, well, you need it. We'll just take it out and replace it. Any thoughts on that? Would you just take the port out? Would you just do it the APP? No, I agree with you. So don't do that. And the reason why is, sure, it could be a whole bunch of complicated things. It could be due to a narrowing, like I have up here. But really, it's Occam's razor, right? It's almost always a simple problem. And I'm glad they called me. So here's some intra-procedural pictures. And the first one on the left is I haven't done anything yet, but you can see they've accessed both the lumens. Both lumens look fine. And then the picture on the right, it might not be projecting well, but I was pushing very hard to get contrast through, and there's just a little bit of contrast kind of welling up into the around the port and in the pocket itself, and not actually going to the reservoir, right? So this was a really simple problem. It just wasn't accessed right. So, and then all I did was like, oh, well, I re-accessed it, and it worked, and it flushed like a dream. Yeah. So, so it was a beautiful port, no problem at all. But this kind of demonstrates my point, right? Yeah. Don't forget about us in IR. I know sometimes we can be busy, and like I said, we're aloof and hard to find, but we can help you with really, really simple problems, right? Because if you think about it, why is this so powerful, right? Like, okay, Nate, this is stupid. Why are you showing me this, right? Well, think about it, right? They were going to put, the surgical team in a bad situation. They just, the hematology oncology team wanted the port now, and so they set him up for a removal replace, right? And so the patient may have gone through a whole procedure or a whole thing that they didn't need and required recovery and all of that stuff for just a poorly accessed port. Right. The other thing is there was a ultrasound read at some point that said, hey, there might be some narrowing around the port catheter itself, right? And so, what happens in that scenario? If you just pull the port catheter out, right, you've now lost any potential access for us to kind of work together to kind of maintain it. And really, I think that the most important point, and I have no data to back this up, but I think that things like this kind of start this cascade of what I call, I'm sure you guys have heard this before, the vasculopath, right? The patients who have like no upper and lower central access, no normal access. They're the ones that have to go through the weird ways. And I think that simple things like this are kind of what start that cascade, right? Like odds are, if they would have pulled the left subclavian port, they maybe didn't put one on the right side totally fine. But now maybe the left side would have went down, and now we've lost a potential point for future access, which is a huge problem. So okay, so what if I'm wrong? So what if it doesn't matter if you get IR involved at all, and you're still going to end up with these vasculopath patients no matter what. And so we can still help in those situations. And so these updates we're going to talk about are not really. There is some new technology, but they're well-hashed techniques. I just think we use them more in the adult world a lot. And that's the reason being is there's more of these vasculopath patients in that population because they end up having more hemodialysis lines due to the chronic renal disease, and therefore everything goes away. And because of that, I think that we don't know, a lot of people forget that in the pediatric world, we can do these techniques as well. So, but before I go on, how many people in the room have a dedicated peds IR team? Okay, all right. How many used to? How many people in the room have like an adult center covering for you? Okay, how hard is it pretty hard to get a hold of them? Or are they pretty easy? Good, that's what I like to hear. So that tends to be my experience is sometimes they can be hard to get a hold of. But again, still keep us in mind, throw up the bat signal, page us. Sometimes we could be pretty difficult to deal with, but we're usually always willing to help. All right, so what if we're dealing with one of these vasculopath patients? So again, this is not a new technique, but how can we help? How can we help this? So a lot of times, some patients might go to like the more complicated forms of access, which I'll touch on later. But something that we can do in interventional radiology is we can do a sharp recanalization of the SVC. Okay. And the most basic way of doing this is we use ultrasound to look at the jugular vein, and then some combination of fluoro and ultrasound to guide a really tiny needle through the area of stenosis and into through the SVC beyond the stenosis and into the right atrium. So full disclosure, these are not my pictures. I tried to get some pictures from my prior institution, but my colleague is a little slow with replying to text messaging. But the technique is relatively the same. So I'm showing two different techniques here. So the one on screen left is what you're seeing a contrast injection from above. There's a little circle there. I don't know if it projects very well, but there's a little circle here which is a target that the interventionalist is then going to come from below from the femoral vein to use to try to drive a needle through that target to connect the two, balloonplasty, stent, and then go ahead and place the line. And then have the patient leaves the room with a perfectly functioning line at that point. The screen right is another technique. It's just basically the same thing, just showing two ways to do it. Instead of using like a circle as a guide, they're just they come from below, blow up a balloon with contrast, and try to jab that balloon with a needle. And that sort of acts as like a kind of a safety net to know I hit the balloon, we're safe, we're not outside here. And then they go through the same steps and place the line and go from there. Questions or comments about that? No? All right, Justin.
All right, this is my partner Nate Hines, Erling's patient. This is a patient with intestinal failure that lost all traditional access, and this predated you, or we would have just told you to do it, I guess, using that last technique. But has anybody done this, thoracoscopic? One, two.
Wait, what are you guys doing there?
Like thoracoscopic approach for.
Cervical approach, thoracoscopically guided into the SVC.
Yeah, like to get below the occlusion in the SVC.
Do you have a video of this? I saw this at Jorgensen 1.
We forgot to hit record, but there are videos of this.
So, are you gonna? I think it's worth taking 30 seconds to explain it. Have you seen it or done it, or do you want?
This is our patient. We've done it.
You were there with Nate.
Yeah.
I didn't know if you were. Okay,
He did it. This patient survived.
Because it's worth explaining. Because I had a
100% survival.
Mark
so far.
Wilcon and Tom learned it from Keith Jorgensen, and I had to have him like really explain it.
Yeah, it's actually pretty easy. It kind of feels like doing the laparoscopic inguinal hernia repair. I mean, you stay, inside the pleura. You can use the ultrasound and kind of see where the carotid is. You obviously won't see an IJ; it's completely occluded, but you sort of stay anterior and a little lateral to the carotid, and then you see it. It's just one port to insufflate and see inside the chest, and you basically get the access. And then it's just a regular central line. Is that a needle? Yeah, that's the needle. Yep.
Yeah, so this is a great technique to show, but I've been convinced that this is maximally invasive compared to our radiology colleagues these days, but definitely something to have in the armamentarium.
I was just curious about making the angle around the clavicle. Like when you put the dilator down and then you put the sheath or put the catheter through it, does the catheter still function? Because it looks to me like it's a really sharp angle around the clavicle.
No, it's just an IJ. I mean, you just make the same curve in the neck and tunnel it down. This is for a Broviac, but tunnel down to the chest.
Okay, so you're going above the clavicle here.
Yeah, you're going
okay.
Just above the carotid in the neck. Just like you would normal
Yep, I'm with you now.
central line. Yeah, and you'll see when you dilate it. I mean, it's kind of scary. You see the whole thing because it's see-through, but you'll see the wire, and then you'll see the dilator. You get like a little bit of ecchymosis in that pleural space. Just ignore that; it'll stop. And it works really well. So for this sort of predated him.
No
to be
drain.
honest, but no drain, no chest tube.
No, but still, though, I can imagine it's like, if I show these pictures, it looks real. It looks real easy, right? No sweat. But I can imagine a scenario that maybe I get in there or something, it might not go quite as well as I want it to, right? Or it's just not working, or I don't think it's safe. And this is not a bad option in that scenario too.
Yeah. So. And usually the clot and the scar are kind of more up in the neck, so you've got good SVC you can access there.
Any other questions? Good comments?
Yeah, I'm going to make a little plug. So on the new version of Stay Current, there's now a way to direct message anybody. So I'm going to offer up these guys to direct message them, because whether you have telementoring in your hospital or you can honestly jerry-rig it, it was really helpful for me to have somebody mentoring me virtually as I was doing my first one. So I really think we need to do better as a community by messaging each other and reaching out and saying, hey, can you show me how to do this for my first few? So I'm offering up your help.
N of one, so it should be good.
It's more than most.
I've seen one, now I've done one, and I'm ready to, I guess, teach someone.
All right, so we're going to go on kind of the more, we're going to talk about new toys essentially, or kind of the way that I think that the technique might evolve in the future, or ways that it is evolving now. So there's this newer thing called, it's the Surfacer. It's made by Merit Medical. It's basically image-guided SVC recannulation using a special piece of equipment. And it's not going to work in all these patients. I think it's probably going to work the best when there is at least a remnant of something there that you can get through. But if there is something, I think this might be safer than me trying to jab a needle down there and get through into the right atrium. So the way this works is the patient has to have a patent femoral vein. We come up from the femoral vein and get into the SVC right in the area where the clot is. And this is what I mean. If you don't have a remnant of something, you can imagine this not working, right? But you have to bury this special catheter where you want your exit site to be. And then we can use a special, on our machines, we can essentially draw a target that we can kind of use, where 90 degrees where we think we're going to come out of. I think excellent. Yep, I submitted them out of order. But so this is the next step. So what you do is you kind of define where you want your target to be, and then you move our big X-ray machine around so that way you can see that little marker on the catheter come out of where you want your planned exit site to be. And then what you do is you drive a special needle through the catheter that you've pulled up there, pull it through the skin surface, and now you've got you got body floss through and through access. And then over that, you can go ahead and drop your sheath and then drop your catheter like you normally would. So, but again, you can see how this is probably good in a lot of cases because we tend to deal with more acute clot in the pediatric realm as opposed to the chronic, scarred up, there's just nothing there. So this might be really good for our patient population. But so where I'm kind of interested in something that I've kind of toyed around with is this in the ones that are harder to deal with, the ones that might require sharp recannulization. So there's this thing called 4D ICE or intracardiac echocardiography. So it's used more in cardiology. They use it for their procedures, their ablations or left atrial appendage occlusions. But could I use it to drive to basically do that sharp dissection safer as opposed to guessing with fluoroscopy? So this is what the thing looks like. It's basically a special kind of ultrasound probe. It's got a whole bunch of doodads on there. All the companies make them: GE, Siemens, Philips. But the cool thing about it is it does this. So what I'm showing you here this is from the Siemens website, but it's a catheter that basically projects a ultrasound wave in all 360 degrees. So then you can reconstruct that image in any plane you want. Whether it be anterior, posterior, inferior, and then you could use all the pieces and parts on here to kind of twist it any way you want. But the idea being is that I know this image is confusing, but just pay attention to the bottom right. And what that's showing is that these are pictures of the heart of them doing a right atrial appendage occlusion, but they're essentially projecting all three different planes during the process with just one catheter. So my thought is if we can do that with that special catheter, can I, instead of just driving a regular catheter up to where the occlusion is, can we take one of these special catheters up there, up to where the occlusion is, get access from above with a normal ultrasound, then use this special catheter to reconstruct and just guide the needle across the occlusion. So nobody's doing this yet. We're using these more for tips, but the premise is still the same, right? Can you guide the needle intravascularly using these special kind of probes? So, any questions about that? Comments?
Nate, any size restrictions, like in terms of size of the patient or size of the vessel you can do this? 10 French. Some are 10 French. Some of the newer ones are coming down to 8 French. So there's the traditional ICE catheters. Those get, I think, 7.5, but you can usually get away with a 8 French catheter. There's some people using special, like the radial sheaths in pediatrics. They tend to be smaller with a bigger lumen. You can get away with a little less, but 10 French is typically. If you go with 10 French, you're safe.
Sorry if I missed this, Nate. Do you dilate at all or no?
For this, no.
Yeah.
Well, yes, we do. So you have to be able to get the catheter across, right? And so you can imagine if it's that tight, nothing's gonna go across there. So usually what we'll do is we'll get in from above, right? And then we'll put a really tiny wire down there. Over that tiny wire, we'll put a really tiny catheter. Use that to drop a more robust wire, and then dilate up, and then allow us to get the catheter across it.
Can you see this ever being automated? You get an MRV or a CTV or whatever, and then you clamp a thing around the neck, and then the computer just guides the catheter based on fiduciaries?
Yes and no. There's a lot of work being done in sort of the image-guided automation center. I have an interest in interventional oncology, and there's a lot of newer ablation techniques with ultrasound and stuff like that, where they use the CT guidance and stuff like that to go where you need to. And to be honest, MRI overlay is actually really good too. So there's no work being done in that, but I don't see why that couldn't.
Nate, they're actually, so Dan von Allman, he worked with Ben Gurion University, and they made a robotic
IV inserter. So
that's kinda cool.
So yeah, so it lays on, it sees it, and it inserts it in. And then another company also, so they're like competing companies. So the good news is, hopefully one of them will get to be an actual mainstream product.
I know, put me out of business.
It'll put you out of business.
Oh man, come
yeah.
on.
Yeah.
No, but if that already, I mean, and that does, I could imagine it being great because a lot of MRI-guided biopsies, they're starting to come out with some of those probably based off the same principles, like some of those robot arms to guide it to target. So I could imagine with fiduciaries and all that, it'd probably work just fine.
Hey, quick question.
Yeah.
When you dilate across that gap there, are you using, do you have better dilators than I have?
Yeah, so we're using balloons.
Yeah.
So we're not, so don't, when I should have, it's not like a regular dilator that you're pushing real hard. Please go, don't
tip
bet.
looks like it's like flanging out.
Yeah, no,
You're
and
like,
flopping
that's
around.
going to take a core biopsy as it goes through.
No.
Okay.
So what we do is by we'll usually use a balloon. So there's a whole variety of them in different sizes. If they're real, if the stenosis is real tight, we usually start with cardiac balloons, like just 5 millimeters, just to create enough space, so that way we can kind of keep going up and up and up. But yeah, trying to dilate with a regular traditional dilator is, that ain't gonna. It's hard. It never feels great. Anything else? I think we got 4 minutes. All right, so just briefly going to touch on the big guns. So let's say, none of that, you don't want to try that. You feel like the patient is not a good candidate for that, and all the potential options are exhausted. So I just want to briefly kind of touch on these, the transhepatic and translumbar access. There's kind of a debate on let's be honest, there's a big debate on which one to do, right? In my mind, I think transhepatic access probably makes the most sense because if there's bleeding or if it gets dislodged, particularly in pediatric patients, I feel like it's easier to get to or control. The problem with transhepatic access is there's some really weak evidence that shows that they might have more thrombosis, but it's kind of a top-up. But there otherwise, now caveat, I haven't done any of these translumbar access, and I think that's sort of my other selling point is I think if you get us involved earlier, we can kind of do what we talked about previously, or kind of help to manage the patients up front more. You might not end up in this scenario, but if you do, it's real straightforward. Again, even though I haven't done it, I use all the same principles of what I've done everything else, whether it be for biopsy or whatnot. I think the easiest way to do this is CT. Some of the old school guys will just do it under fluoro where they start jabbing with a needle, because there's an old principle that you can jab anything with a 21 gauge needle and get away with it, and boy do they take that to an extreme. But what I would do is I would locate the IVC at the lumbar level using CT, and then guide a Chiba needle down to that, get access, and then go ahead and place the line. And this is just an example for a port placement here. Yes.
Hi, I'm Gloria Gonzalez. Before I worked in Chile, and now I'm Cleveland Clinic. I had 2 patients with transhepatic catheters done by interventional radiology, of course, but they get dislodged to the peritoneal cavity because of the breath movement and everything.
Yep.
So both of the patients had all the TPM placed into the abdomen, and they started doing really bad, and when you cannot realize the catheter tip is in the peritoneal cavity. That's why I change, and I prefer translumbar.
Okay.
In kids.
I mean, that does make sense, right? That is definitely one of the, yep, and there are it's like one of those vague, like you don't know until the patients, days have passed, they've gotten how many bags of TPA dumped in their peritoneal cavity, and they're all blown up, right?
And usually the people go and try to do the reanimation through the catheter because that's the only access.
Yep.
So they finish with the patient death.
Yep, and so in that scenario, that makes sense. To me, I think the translumbar access, I think of, it's more, it makes me nervous because if it gets dislodged, it's just going to bleed, and there's no way. It's hard for me to get back to try to plug the hole, just because now a lot of the adult patients, they're a lot bigger than our patients, right? So you can hold pressure, you might get lucky, but I just get real nervous about that, like, the patient rolled, the catheter flipped out, and then I got no way to get back in to try to plug the hole, essentially. So.
Yeah, it's true, but it's retroperitoneum, and the muscles are in there, so it's like a contained hematoma. In the other one, it's an hemoperitoneum, and the patient goes all the way.
Yeah, definitely true. Definitely true.
I mean, that's my experience at least.
And I think the caveat is neither of them are great, right? So if we can avoid, I think they both have their caveat. They both work well. And if you look at the literature, there's a bunch of really tiny studies, and they work well, they're safe, and they do. But like from your experience, there are problems, right? And so I think if we can, again, don't forget about us. Interventional radiology is around, right? And we're best friends. Get us involved early. You might hopefully be able to avoid, any potential issues like that. So. All right, so that's all I got. Questions?
Have you had any experience with azygos vein catheterization?
I have no personal experience, but there's been a couple close, like, ooh, are we going to have to do that? Sort of scenarios. But just like actually getting access into the azygos vein and putting the catheter there. No, I have not personally had to do that, but I am up to date on techniques on how to do that, and they can be interesting.
And is that an interventional radiology technique, or is that something you need to do thoracoscopically?
I think.
Do you know?
I think we can do interventional radiology, but I'm assuming the same principles would apply, right? Like, usually it's a little. I always say for interventional radiology, it's more, even though what Justin was doing is minimally invasive, with mine's just a venous stick, right? And like at worst, a 5, 6, 7 French catheter, and if it doesn't work, generally there's very minimal complications from it, right? And if that's the case, then we can go to more of a surgical approach. But
all right, thank you so much. It's so fun to have this session. It always gets so much interest whenever we talk about this. So thank you so much. Yeah. All right, we'll play the intro. All right, appropriately so, colorectal is our last session before lunch. So.
Oh, hey, everybody. Yeah, so we're the only thing standing between you and lunch. Don't worry, we have about an hour and a half of material, so it'll be fine. Hey, next slide. Where's the little magic ring here? All right. Backwards, forwards.
Your virtual speakers are here.
All right. Okay, and all right. So, hey, Nelson Rosen from Cincinnati Children's with Aaron Garrison and Annie Ledwin with me here. We got Elizabeth Speck, Jamie Harris online, and we're excited to give you guys an update. And our intention is to talk about some things. These are roughly the topics that we're going to hit. And this was a real challenge. And like I heard earlier, if you want to go into the real innovative, you have to look into adult literature too. And we do. However, there isn't a ton of earth-shattering stuff that's occurred in the literature in the past couple of years that is really game-changing that we could put out there. So, but I did think that it would be a really good exercise to hit these points because some of these articles are still quite fresh. Not all of you may know about where things have gone. And now that things have been out a year or two and people started doing them back in their home places, you can see maybe it's not exactly the way they talked about. So hopefully some of that will come out in the conversation. And I think with that, we'll move into a clinical scenario. And Jamie Harris, take it away if you're online there.
Hi, good morning. Everybody hear me okay? Yeah. Excellent. So thanks so much for the opportunity to present the colorectal update. Our first case is one of my favorite calls to get from the NICU, actually. It's a term female infant. She weighs 3 kilos, and she's got a rectovestibular fistula. They've done the workup in the NICU, and besides her anorectal malformation, her Vactral workup is completely negative. So that brings us to our first clinical question that we're going to pose to the group here, which is, what is your next step? You can do dilations only, dilations and elective surgery after discharge, a diverting stoma, or a neonatal PSARP. I think we can hopefully do our poll everywhere.
All right, what do we got there? So on the poll, it looks like dilations and then delayed PSARP is leading by a substantial margin over a neonatal PSARP making a little comeback there. All right.
I think as we go through the answers, we can agree that doing dilations alone is probably not the correct management of this for a number of different reasons, but certainly dilations initially will allow for decompression. And I would recommend only dilating to a 7 Hagar to decrease the potential scarring along the tract for future PSARPs. Along those lines, if the fistula is decompressing, a diverting stoma often not necessary. And those are our two other answers that it seemed like the group kind of felt similarly with, which is dilations in a later surgery after discharge or a neonatal period PSARP. And a little bit of controversy in these, but there is data to support either of the next steps. So kind of the next question is, you've calibrated the fistula, you're able to get your 7 Hagar dilator, and the baby's decompressing well via the fistula. And so it brings us to the next question. When are you going to do your PSARP? Are you doing it ASAP before the baby leaves the NICU, at 1 month of age, 3 months of age? Do you have a weight requirement, or are you going to do it later because you're on vacation? What does our panel think? Or what does the group think?
Yeah. Go for it. Start talking.
I guess so. This is a 3-kilogram baby, a term baby. I would rather do it at 1 month of age, just because you do if the patient can be decompressed with the rectal dilations, the fistula dilations, and then just so the baby can grow a little bit bigger, I would be more comfortable at 1 month of age.
I think Nelson and I disagree a little bit on this. He likes doing them up front. I hope I'm not putting words in your mouth, but I like also getting them a little bit older, let the babies go home, and then so somewhere between B and C, I think makes sense to me.
Yeah, I guess I'm old school on this. Like, I like to, I'm fine maintaining patency, and I think, Jamie, you brought up a really important point about if you're going to just try to keep it open, you just have to keep it open enough for like little soft mustardy poop to be able to make it through there. So there's no reason to drive that dilation like up big. But I like to do this operation like when I can. It doesn't have to be the next day, the day after. You can get it done. But I like to get it done on the neonatal admission, provided that there's no comorbidities or that the kid's not like 1.2 kilos or something.
Yeah. And I think that's kind of our sort of gestalt in the group is, I think both are safe. And understanding kind of the surgical principles of the PSARP and this operation can be performed both safely in the neonatal period or after the patient's discharged. There were 2 kind of important studies that both came out in 2021 sort of looking at this. Ifrin et al. Looked at female perineal or rectovestibular fistulas. This was a NISQIP study, and it defined early repair as less than 7 days, delayed 6 weeks to 8 months. And again, they found no difference in those groups between wound complications, reoperations, and readmissions. And again, there was another study in 2021. This one looked at 30-day outcomes, and it was neonatal versus delayed anoplasty in a multi-institutional retrospective study through the PCPLC. They had 164 patients, and their early repair was defined as 14 days versus a late after 14 days, and that one average was about 172 days, and the neonatal repair was about 3 days. And again, their primary outcomes were looking at 30 days. There were more in the delayed group, which is kind of what goes along with what our poll showed. There was about 81% in that delayed group versus the neonatal group. But what they found was that wound breakdown and dehiscence was the most common complication in both groups. And it was about 5% in delayed, 6% in neonatal. But there was no significant difference in any of the incidence of post-operative complications in those 2 groups. So they concluded kind of it was the same thing. This slide here shows just kind of the discrepancy in terms of delayed repair from a couple of months to multiple months of age. And so there's no kind of right timing of delayed repair, but significant variation in the literature. I would propose a couple of downfalls of a delayed repair. One, like we talked about, that theoretical fibrosis of the fistula tract, potentially making your dissection a little bit more difficult on the PSARP, not impossible. And if you're staying at that 7, I think it's probably okay. The other is if you're not completely decompressing it, the rectum can get distended and make it a little bit technically more difficult to perform that PSARP. And then if you do the neonatal repair, they don't require the readmission for their surgery, and with some of the social determinants of health that have been looked at recently, it's not always easy for families to make that trip multiple times for the readmissions, and it's a long distance and can also be pretty expensive. And so kind of want to open it up to the rest of the group. Any other thoughts on terms of these timing of PSARP? And Nelson kind of mentioned size cutoff of these babies. Is it 2.5, 2 kilos, 1.5 kilos?
Yeah, how many people are doing primary PSARP in the neonatal period in this room? Like before discharge from the first NICU stay? Like a very few. Like I'm a dinosaur with that. which is a little bit bizarre because, like, in surgery we do it younger, do it smaller, do it quicker, get it done. We always try to do that. So moving to a delayed approach is actually really interesting, and I think in many ways mature, because if you're more comfortable later in the course, maybe the patient's a little bit bigger, maybe you have less complications from the way you do that operation. And talking about vaginal wall injuries and things, the things that people say never happen, except they totally happen. So I think that's important. Yeah, Justin.
Yeah, I think the data is so mixed. I think it's a decision to share with the family, because I just don't think there's strong data one way or the other. But if it's a trustworthy family, I think they're fine to send home. And I would agree, don't dilate them to like a 12, like a crazy person, because that will make it way harder to do the surgery later, like just enough to let stool go through.
Right. Yeah, and it depends on how tight they are. Like, we use this term dilation, like we're stretching something that can be stretched up to a certain size, except that's not true. Like, when they start out like a pinhole, it's a controlled tear. So if you're doing a controlled tear, get it to be just as big as it needs to be, and then leave it alone until you actually fix it. Yeah. Well, excellent. All right. Let's see, next slide on that. All right, we're moving on.
All right, well, that was a good lead-in. So now, how is everyone performing their anorectoplasty? The classic PSARP? Are you taking an anterior approach? What about the perineal body preserving PSARP? Or maybe you guys have some other way that you're doing it. Let's start the poll in there, Nelson.
All right, let's see what the poll says. Interesting. And the one other that, I was in a presentation that somebody gave not that long ago talking about laparoscopic approach for vestibular fistula, and of course my brain exploded and still hasn't recovered, but, if somebody would want to defend that, knock yourself out. But what did that poll show? We missed that.
I didn't see the final results.
Yeah.
What was?
All right, so most people, a lot of people doing perineal body preserving PSARP, won out on this one, and classic PSARP a close second. And there's still a few folks doing the anterior sagittal approach.
Well, there are some data around the perineal body preserving PSARP. I think it's our next slide. I think the first publication was in 2023, where they demonstrated at the 1-year follow-up, no dehiscence, no prolapse, and only 13% of the patients required revision of their anal stricture, and 2/3 of the patients went home on postoperative day 1, which is faster than my most recent PSARP for sure. Nelson, I think you're a big proponent of this. Tell us your tricks to not injuring that anterior or posterior vaginal wall when you're coming around the anterior part of that rectum.
Yeah, that's a great question, because when this came out, and this was really first described and first done by Belinda Dickey, and when you see an article like this, you're like, oh wait a second, because for vestibulars, I was basically doing giant PSARPs, from above the coccyx all the way down to the fistula, and so started to do this and really picked up on that this is basically the same thing one would do in a bulbar fistula, but applied to a vestibular fistula. So I do it, and it's hard for me to think about how this lateralizes, because when you're a PSARP surgeon, that's what you do, and you're used to the concepts of working really religiously about cleaning up the lateral planes before you come around the front. And I think that's the biggest thing. But before that, I think it's perfectly fine when you're starting out doing these to go a little bit into the perineal body on the front and a little bit behind it in the back, just to make sort of your incision that you're going to work through, not the tightest pinhole incision that you could make. You make a little bit bigger to start with, still keeping a perineal body largely intact, but then that classic PSARP thing of really get to the back wall and mobilize the sides and really mobilize it well, staying on that bow wall before you decide to come around, and then very, very slowly and meticulously making it through that common plane. But this is one of the big things that, people who do this like very frequently have a different comfort level than those who don't. So like, I'd like to hear different experiences. Why don't, let's go.
Yeah, I like it, mainly for the post-op recovery, in that you can let them go home earlier. You're not sweating that breakdown in the perineal body, which is like the biggest concern. And remember, these kids, when I was a fellow, would stay in the hospital for a week on TPN. So it's come a long way. I think it's worth doing just for that alone, but I do think it's harder than opening it all the way anteriorly, and you have to, like I think Dr. Harris on the call said in our planning session, like you can convert this to a regular PSARP, you can try it, and you can always extend your incision if for some reason you're not getting the visualization that you think you need.
Yeah, I think that's pretty key, is like if you are lost in the anatomy and you need to make a bigger incision and convert, it's super easy to do that. And if you're not sure where that anterior wall is and where the vagina is, just convert to a standard PSARP and go from there, which would make you do it safely.
I think I agree with both.
That's been my experience as well. Oh, sorry. Go ahead, Annie.
I just agree with both Dr. Garrison and Dr. Rosen. I just remember doing one of my first perineal body sparing PSARP when I was in fellowship back at St. Justin, and we just took our time through the small incision, and the patient did really good afterwards, but it was a little bit more confusing than doing our classic PSARP for these type of cases.
I think that point about time is important too. In the second article that came out with that was one of the factors they looked at, was the time of the operation, and it actually doesn't add any time in that small experience that they had from a standard PSARP to a perineal body sparing, which I think is important in these neonates to minimize the anesthetic time that they have as well.
Yeah, how many folks in the room are doing it? Like a few. I can tell you, if this is the kind of thing that you do, it's a joy. It's like become one of my favorite operations to do. All right, let's keep going.
I think it's important just to mention, kind of to your point, Annie, I tried it one time. It was the fellow's first operation doing a PSARP, week 1 of fellowship. We ended up extending our incision so that we could both feel comfortable with the anatomy. If you've never done one, it does have a little bit of a learning curve. You want to make sure you're comfortable doing it, make sure everyone can see what they need to see to do this safe. So I think the end result is do what you're most comfortable with, but I like the idea, Nelson, of pushing the envelope. Yeah. Like you suggested.
And I think you bring up a really good point, and it reminds me, it's sort of like the anti-PSARP, because the PSARP was, we did an abdominal, perineal, sacral incision, and that was Dr. Pena saying, well, let me make it bigger, until he had the whole thing flayed wide open. And this is the opposite of that. So there's nothing wrong, by the way, with, well, I'll make it a little smaller. And as your experience grows, the next thing you know, hey, I did it within the confines of the muscle complex. So I think that's a great way to do it. What about, okay, we got another poll.
All right, do you guys do anal dilations after your PSARP? Yes, no, maybe?
A divisive topic.
Very divisive. This is why we included this. We need to know what people are doing.
How many dilators in the room? Show of hands. Dilators. Routine dilators. Wow. Okay.
Nelson, keep your hand up.
Yeah, my hand is up.
I know where you fall in this one.
All right. And that couldn't be more even. That's like kind of a third. It's like all right.
I think there are data around this. I think we have to start to question this paradigm. On the next slide, we'll show you that there are data that support parental anxiety, PTSD for both the patients and the caregivers, post-traumatic stress symptoms in the families. This is a big stressor, just like enemas. When you have to do something to these patients, or it turns out they're not patients, they're the families, it's their kid. They're at home, they're having to dilate. Preoperative dilations seem to be a little bit more tolerated than the postoperative dilations. I think families are worried that they're gonna hurt their babies and they're gonna hurt this repair. And I think we have to question this paradigm in how we manage postoperatively. The next slide shows single institution review. If you wanna click through that, Nelson, I think the next slide shows, I think this one's out of Spain. And the gist is they followed sort of the historical Pena anal dilation protocol that we've all heard about. Post-op week 2, you start dilations, you try to get them to the neoanus size that they need to be. And the gist in this study was that the kids who were smaller than they wanted them to be at that initial appointment, they got dilations, and those who were adequately sized, according to the table on the bottom by age, they didn't get dilations. And on the next slide, another single institution review in kids under 2 years of age that shows, at least the way I interpret this data, half and half dilations versus no dilations. 2 kids in each group had to have a reoperation for that neoanal stricture, and about 15% of the kids required a Heineke-Miklowitz stricturoplasty, which, by the way, is a nice backup plan. If you're not going to dilate, you at least have a surgical option that's pretty minimally invasive. Poll in the group up there, Aaron and Nelson, what are you guys doing? Dilations, no dilations? Jamie?
Personally, I think with a neonate, we dilate, or I dilate. If it happens to be an older kid, a redo, and they're ambulatory or old enough where I think that's traumatic for everybody, then I will hold off.
I also usually dilate for neonatal cases. One of the things when these studies came out for the stricturoplasty, one of our concerns in Canada is that we don't really have easy access to schedule elective cases. And so this is why we prefer to dilate all of these cases up front.
Yeah, we could go on the dilation. We're gonna fly past it because we got lots of stuff to hit in the last 10 minutes. But thankfully, there is a big PCPLC study coming out looking at this, because a lot of this study is quite flawed, and I flayed it at the last PCPLC meeting. I don't want to rehash that, but well, let's keep moving forward. All right, new scenario.
Okay, so next case, you have a term newborn patient with delayed passage of meconium, no other anomalies. You do a suction rectal biopsy, which is diagnosis for Hirschsprung's disease. First question, when would you perform the pull-through procedure? Before NICU discharge, at 1 month of age, at 3 months of age, or would you rather perform a primary ostomy and delayed pull-through in this patient? Okay, so 30% would perform it before NICU discharge, and 39%-ish at 3 months of age. So our consensus in the literature, there's not really evidence of the good timing to perform a pull-through procedure. There were some studies that were published. This was a study from 2021 from PCPLC. It's a retrospective study that compared outcomes of neonatal pull-through versus delayed primary pull-through. And so for the neonatal group, the median age at surgery was 11 days versus 98 days for the delayed primary pull-through. And they found no difference in terms of preoperative enterocolitis, postoperative enterocolitis, and fecal incontinence and follow-up. I just have a question for the panel or the audience. When do you usually perform the pull-through procedure?
I tend to do it a little bit more delayed, and it's because I like the families to demonstrate that they can do irrigations at home. I think that's such an important skill for them to have. And the rate of enterocolitis after pull-through is obviously not zero despite our best efforts. And so I think if a family is really competent with irrigations, they're going to be much more comfortable after a pull-through doing those irrigations, and that's what's going to save the baby's life. So I delay at least a month, sometimes 3 months, depending on when the family can get back. And that's assuming it's a reliable family that is good at irrigations and can come back if they need to.
Steve?
I completely agree with that. The family who's really good at irrigations will save a baby's life. And I can't tell you that the outcomes are any different with regards to incidence of enterocolitis, but I can tell you that they start treatment before they ever even call me.
I'm curious if whether the length of the aganglionic segment affects the timing of your pull-through.
Good question.
Absolutely.
Yeah.
I can tell you from experience what I've learned in the kids who are not able to go home because the family can't ever do really good washouts. They usually have a longer segment, and that pushes my hand to do something while they're on the inpatient side, which is important so they don't go home and then they're not adequately decompressed and they end up in the hospital with enterocolitis or a perforation, even worse.
I would say I used to do them all in the NICU, and I've kind of shifted to more delayed for the points you made. I think it's good for the family to do irrigations. The surgery is frankly easier when they're a little bit bigger, and some of the data seems like it suggests maybe better continence in the delayed group, but the studies have all been underpowered. But I think it is still shared decision making with the family. I think the last primary pull through I did, the mom was in prison, so I didn't think that was a good situation, so I did it before they went home from the NICU.
All right, we got to keep moving.
And so at the time of your pull-through, would you inject intrasphincteric Botox at the same time?
How many in the room do Botox at the primary pull-through? Yeah, when I remember.
Okay, so from the poll, 50% would not inject Botox at the same time of the pull-through, and then the rest is either yes or variable. So we, as a group, would inject Botox at the same time of the surgery. There was a multi-center study that was retrospective, published in 2022, that evaluated the use of Botox in patients with Hirschsprung disease, and 24% of them received at least one Botox injection. We did a study at Cincinnati Children's, which is a prospective study from 2020 to 2024, and the results are not published yet, but what we found is that within the 31st days after the pull-through procedure, there's a decreased risk of enterocolitis. So I think it was 50% versus 30%. And the other thing that we found is that patients that received Botox at the time of their pull-through had a higher risk of a diaper rash in them. Higher risk, yeah, 60% of them. And then another question for the audience or panel: what kind of botulinum toxin are you using? How many units are you using? The injections frequency, and then do you use ultrasound guidance to do your injections?
Yeah, we start out with Botox, and like it took me a while to learn that there was like multiple brands, and we only change when there's like some type of allergy or some issue with one particular one. But the number of units is challenging because there's no evidence on it. You know, like I was taking my guidance on like the early work, like an early paper from Sam Nurko's group in Boston, where they took, they did like a per kilo up to a maximum of 100, but then tapped out there. But when I came to Cincinnati, everybody was doing like 100 regardless of the size of the child. And that didn't make much sense to me. But then again, I've always been underwhelmed by my weight-based dosing. So maybe we need a little bit better data on this.
I definitely use an ultrasound, but that's just my practice. I use the ultrasound for everything.
Do you find it more practical to use the ultrasound so you know exactly where you go?
Yes, ma'am. I can see every layer. I can see where the needle is. I can see how much I put where and where it diffuses to. It's really nice. But you have to be comfortable using the ultrasound, otherwise it's kind of useless if you don't know how to use it.
You have to have it available. Yeah.
Spec, when you inject, do you go in through the anal canal, or do you go on the outside through the
On the
skin?
outside. Yep, on the outside, and then I can follow the needle in line, and you can see the internal and external anal sphincter. You can see the superficial external anal sphincter. You can tell, you can see the puborectalis sometimes.
Great. Last case, and I don't think it'll be long because we've been sorting through a couple challenging patients with ARMs and trisomy 21 at our center, so thought it would be a good review kind of which patients to screen for this, and maybe a discussion about looking at fistula tissue. So I guess let's start with the poll. What is the rate of Hirschsprung's and ARM together? That's right. So it looks like most people, 2%, 2 to 5%, and I think A is probably most correct based on a few of the papers, but there are some that show as high as 3 or 4%. Dr. Pena's paper, looking at his series, was about 2%, and then in the recent paper that was less than 1%. So it's still, it's very rare, but it is something to be aware of as you're working through some of these challenging patients. Next slide. This is 2 learning points that we wanted to take away from this paper, also from the PCPLC. They, at a single center, looked through all of their rectal fistula specimens that they took down, or that they did during the PSARPs, and just to kind of establish what is a baseline for ganglion cells when you send that tissue, because that's not physiologic tissue, right? It's fistula tissue. So they found ganglion cells in 90%, and hypoganglionosis or absent ganglion cells in the rest. And I think it's important to know that just because you don't see ganglion cells in fistula tissue does not necessarily mean it's Hirschsprung disease, although may warrant further workup. So to add to power for this study, they looked at the PCPLC database, and there were about 1,700 patients in this, where they looked to see who had both. And the main thing to take away for trainees or for those who need a reminder is that the patients that tended to have both diagnoses tend to have chromosomal anomalies. So trisomy 21, Pallister-Killian, and some others. So looking at this the other way, if you have a complex patient who's really not responding to laxatives, to enemas, and they have those diagnoses, then that's someone that we think is worth working up. Any comments, questions, or about this?
Hey, do you think, Aaron, like as we move in minimally invasive PSARP and smaller incisions, and one of the things that comes with smaller incisions, by the way, is the concept of how much do I actually need to mobilize? You know, and as an early PSARP surgeon, I was taught to mobilize to like completely, like all the way up from like bottom to mouth practically, so that you could move this thing anywhere and there was as minimal tension as possible. But like the older I get, every little flick of the bovie, like that's a blood vessel, that's a nerve, and that's another week in the bowel management clinic. And I think like that. And that's gotten me to say, like, hey, maybe I don't need so much mobilization. Maybe I can stop right there, and maybe I can resect even less, just like the pure fistula.
I knew you were going to use that line, and I was going to say it if you didn't. So I think you have to mobilize what you feel comfortable mobilizing, but I think more importantly, in regards to this topic, is talking to your pathologist about where they're looking at the specimen. So are they actually in the deep portion, full thickness bowel, and not in that distal fistulous tissue? And that may be worth having a conversation with them as you send the specimen. 2 seconds left.
Man, we hit that one out of the park. Thanks, everybody.
All right, we are going to take a break for the in-person people here. Miguel Gilfon got here perfectly in time for lunch. Before we break, I just want to, and I'll have my phone out here to make sure I don't forget, just to give a quick, we've now been doing this for not just this course, but content, everything, about 15 years. We try to make it free to the world. We've been successful for the most part for 15 years. And as I was telling everyone last night, it's because of the hospitals and the sponsors that have supported this. In fact, Carl Storz, we had no money to do this. We had the vision, and over, the company kept supporting this. So thank you so much for continuing. We know that pediatric surgery is not a huge specialty, and you guys have always come to the table to help us keep this alive. Cincinnati Children's, Kansas City, Mercy Children's Kansas City, Buffalo Children's, Children's National, Primary Children's, Akron Children's, Lurie Children's, Seattle Children's. These hospitals continually, for nothing other than just to support education, keep helping us keeping this alive. All right, so my wife's getting tired of me writing checks all the time to keep this alive, and so we're looking for ways to keep it supported. So I appreciate people donating. We're coming up with creative ways to get this to keep going, and we just want to keep it free for as long as we can. So that's why we're doing it. The other thing we put a few poll questions up. Wanted to know if people want CME for this. It would just come with a fee. And the reason we haven't done it is because we don't want to charge anyone. But if people want CME, let us know, and we could provide that. It would just come at a fee. The other thing is, the part you're not seeing is what happened last night. The in-person party is what has been the most well-known part of this for years. And we've talked about inviting everyone to that. We would have to charge just for the food, but let us know if that's something that people would come. We've tried it once before. We put on a laparoscopic course. We got a lot of people from all over the world that came. So let us know if that's something we can do. And then the last thing is Stay Current is another option. If your hospital, we now have, 20 hospitals that have joined this network where you can share content with each other and have your own private space for protocols and guidelines and lectures and videos. So let us know if your hospital wants it or you personally want your own private space to join the network. Those were the three things. I have asked an incredible superpower to help me going forward, Dr. Katie Russell. She has run courses. I've been to her courses. They're phenomenal, and she's agreed to help because I'm getting too old. So we are, I think we'll see some exciting changes coming forward. And if anyone's interested around the world or in this room, we would love, it's volunteer. So if anyone's interested or willing to help us make this better in the future, figure out what we can do. And in the audience, please tell us. I see we didn't answer the audience responses enough. There's a lot of things we could do better, so please let us know. So we are going to take a break. And Katie will decide where this is going to be next year, and I think you'll see some exciting changes. So thank you so much. We'll take a quick break, and we'll come back for the second half.
Ohio, Cincinnati, and Cincinnati Children's are no strangers to firsts. Our pioneers traversed brave new worlds, and Cincinnati Children's freed the world of polio. Our engineering inspired others, and Cincinnati Children's created new treatments that changed the outcome for kids. Our state was the first to electrify cities. Now, Cincinnati Children's is lighting the way for advances in organ transplantation. Ohio gave birth to aviation, allowing kids like me from around the world to fly to Cincinnati Children's for care they can't receive anywhere else. Cincinnati is home to the first professional baseball team. Now, Cincinnati Children's is using game-changing proton therapy to cure cancer. Today is another first for Cincinnati Children's, for the Queen City, and for Ohio. Cincinnati Children's is proud to be the #1 children's hospital in the nation.
Welcome to Ann and Robert H. Lurie Children's Hospital of Chicago. Every aspect of our 23-story, state-of-the-art hospital was designed with kids in mind. An extraordinary place for healing and family-centered care, its flexible design and advanced technology enables our caregivers to provide superior care to the most critically ill children in Chicago and around the world. The second floor is also home to our Emergency Care Center, a state-of-the-art emergency room that sees more than 60,000 patients each year. Floors 3 through 8 are reserved for outpatient clinics, diagnostic testing, and procedural care. This includes our Chicago Institute for Fetal Health, one of only a few comprehensive fetal centers in the country, dedicated to the care of pregnant women with fetal complications. And our modern surgical suites, where we perform more pediatric operations than any other pediatric hospital in the state, using the most advanced techniques and minimally invasive approaches. As a tertiary and quaternary care hospital, Lurie Children's intensive care units care for the most critically ill and injured children and serve as a referral center for the community's hospitals whose patients require specialized, life-saving care. Our Center for Cancer and Blood Disorders offers the most comprehensive cancer care in the region. The space was designed to evolve to accommodate new technology and include special features to ensure the safety of our immunocompromised patients. On the top floor, you'll find our cardiac care unit, one of the only pediatric units of its kind in the country. The enhanced model of care combines the technology and expertise of intensive care with pediatric cardiology to provide patients highly specialized care in the same unit for the duration of their hospital stay. This incredible building is one small reason Lurie Children's is the top pediatric hospital in Illinois, but it's the people inside that make it a truly special place for kids.
You're in clinic or rounding. You need a protocol, a technique refresher, or a contact number, but it's buried in your inbox, a desktop file, or that giant binder no one opens. Stay Current MD is your team's knowledge organized in one app. Protocols, guidelines, how-to videos, technique refreshers, even links, contact lists, and department updates, all searchable, all mobile. Join one of the fastest growing medical networks, trusted by over 18,000 medical professionals in the world's top hospitals, with nearly 1 million views and a 20% annual increase in hospital spaces. Evidence clearly shows that guideline adherence leads to better outcomes. And you're not just accessing your own team's content, you're joining a network of hospitals sharing best practices, each curating their own space, all in one place. This isn't another app you'll forget to open. It's built for what you actually need. Quick answer, smart teaching, and better team alignment. If you've ever said, why isn't this easier to find? This is the fix. Stay sharp, stay connected, stay current.
At Akron Children's, we know that childhood is precious. Every moment matters, every smile, every milestone. We strive to create a positive experience for every child, every parent, every step of the journey. Pediatric surgery is different. Children aren't just small adults. Their bodies are still growing. They have unique needs. Our pediatric surgeons are experts in delicate anatomy. They know how to use tools built for small spaces and techniques designed for growing kids. We plan care not just for today, but for the lifetime ahead. Surgical care at Akron Children's goes far beyond the operating room. We know that surgery can be scary, for kids and for parents. From the waiting room to the OR, our spaces are designed with kids in mind. Everyone on our surgical team is passionate about caring for kids and their families. Because surgery can feel overwhelming, we guide the process with comfort, communication, and trust. We talk with parents, we sit with kids, we explain things simply, we listen and reassure. Because when families feel seen and supported, healing begins. Our goal at Akron Children's is to get kids back to being kids, to give families peace of mind, and answer every request for more childhood please with everything we have. Every decision we make supports a child's growth, development, and future quality of life. Because we know every child has something special to share with the world, and we're honored to be part of their story. At Akron Children's, we're a pediatric surgery team that puts families first, and we're proud to help bring a little more childhood to every child we serve.
Some said Tiago had 1 week to live, but this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds, it's about changing them for all kidkind. Hope, care, cure. Seattle Children's.
Welcome to John R. Oshai Children's Hospital, a place of hope, healing, and miracles. Oshai Children's Hospital is one of only 43 standalone children's hospitals in the nation, and the only one of its kind in New York State. The only one. Why is that so important? Because our whole staff is specifically trained in and devoted to the care and treatment of children from conception to 21 years of age. Because the entire building has been designed with patient and family comfort as a top priority. And most importantly, because the best of the best practice here at Oshai Children's Hospital. As a teaching hospital for the Jacobs School of Medicine and Biomedical Sciences and the University at Buffalo, our physicians are practice and thought leaders, training the next generation of physicians to provide the highest quality of care to our community's children. There are many things that make Children's different from other hospitals, even beginning before arrival. By downloading the MyCallida app, families can use its GPS navigation to get to the hospital. And upon arriving, it automatically changes to walking directions so that families and visitors have no problem reaching their destination within the building. Parking is plentiful, safe, and close. Whether you choose to self-park in the parking ramp located on the corner of Ellicott and Goodrich, or use our convenient valet service. Walking into the hospital is like Dorothy opening the door to Oz. Bright colors, artwork, playful interiors, and comfortable seating are just a few of the distinctive sights you experience upon entering. The lobby features a gift shop that's any child's dream. A Tim Hortons, which is many a parent's dream, and an entertainment space to host holiday parties, performances, and special meet and greets with local and national celebrities. Each inpatient floor has a playroom where children can put aside their illness or injury and simply experience the joy of just being a kid. There's an outside terrace that allows visitors to get a breath of fresh air, soak in the sun during our beautiful western New York summers, and enjoy a view of the cityscape that's simply spectacular. But at the core of Oshai Children's Hospital is our team of expert clinicians. Their goal is complex, yet singular, to treat and cure sick and injured children. They've devoted their whole lives to that goal, and every single day they give their all to provide healing and make miracles happen. And at the end of the day, that's what John R. Oshai Children's Hospital is all about.
You asked. We delivered. The all-new Stay Current MD app was built with your feedback and your workflow in mind. We've shifted from browsing to search first, so you get the answers you need faster. Search understands typos, synonyms, even clinical shorthand, because at the bedside, there's no time to waste. Whether it's protocols, podcasts, quick videos, or more, everything is at your fingertips. A fully redesigned experience with smarter search, customizable spaces, advanced discussions, direct messaging, cross-institution collaboration, and more control over your profile, notifications, and content sharing, all built to keep you one step ahead. The new Stay Current MD, smarter, faster, built for how you work.
If you're worrying, know there's someone working relentlessly. If you're struggling, know there's a team on your side, pioneering breakthroughs. If you're questioning, know we are finding better answers. Because in the pursuit of healthiness, we are changing the outcome together. Cincinnati Children's.
There's nothing more important than our commitment to children. Our roots run deep, and we're always finding new ways to care. For more than a century, across the Mountain West, we've been dedicated to keeping the child first and always. Our team of passionate caregivers are combining forces in new ways to help children live their healthiest lives. It's the power of we. We're better together. Together, we're building something truly special. Together, we get to ensure the best outcomes for all patients. And together, with your involvement and generosity, we are building the nation's model health system for children. So, what does it mean to build a model health system for children? Intermountain Children's Health is the best outcomes for our tiniest patients, the nonprofit health system serving the most expansive pediatric geography in the United States, world-class hospitals, quality pediatric follow-up close to home, more than 1 million patient interactions annually, thousands of nurses specially trained to treat and support kids and the families who love them, nationally ranked subspecialty care, local pediatricians going above and beyond in their communities, a team of caregivers more than 10,000 strong, all united to help kids, caring for minds as well as bodies. It's finding new cures and delivering care in new ways, considering the whole child to help keep kids healthy and safe and out of the hospital in the first place, connected to our communities, accelerated by partnership, all powered by philanthropy. Intermountain Children's Health is and will always be the child first and always. Thanks to you. Join us in building the future our children deserve.
Ohio, Cincinnati, and Cincinnati Children's are no strangers to firsts. Our pioneers traversed brave new worlds, and Cincinnati Children's freed the world of polio. Our engineering inspired others, and Cincinnati Children's created new treatments that changed the outcome for kids. Our state was the first to electrify cities. Now, Cincinnati Children's is lighting the way for advances in organ transplantation. Ohio gave birth to aviation, allowing kids like me from around the world to fly to Cincinnati Children's for care they can't receive anywhere else. Cincinnati is home to the first professional baseball team. Now, Cincinnati Children's is using game-changing proton therapy to cure cancer. Today is another first for Cincinnati Children's, for the Queen City, and for Ohio. Cincinnati Children's is proud to be the #1 children's hospital in the nation.
Welcome to Ann and Robert H. Lurie Children's Hospital of Chicago. Every aspect of our 23-story, state-of-the-art hospital was designed with kids in mind. An extraordinary place for healing and family-centered care, its flexible design and advanced technology enables our caregivers to provide superior care to the most critically ill children in Chicago and around the world. The second floor is also home to our Emergency Care Center, a state-of-the-art emergency room that sees more than 60,000 patients each year. Floors 3 through 8 are reserved for outpatient clinics, diagnostic testing, and procedural care. This includes our Chicago Institute for Fetal Health, one of only a few comprehensive fetal centers in the country dedicated to the care of pregnant women with fetal complications. And our modern surgical suites, where we perform more pediatric operations than any other pediatric hospital in the state, using the most advanced techniques and minimally invasive approaches. As a tertiary and quaternary care hospital, Lurie Children's intensive care units care for the most critically ill and injured children and serve as a referral center for the community's hospitals whose patients require specialized, life-saving care. Our Center for Cancer and Blood Disorders offers the most comprehensive cancer care in the region. The space was designed to evolve to accommodate new technology and includes special features to ensure the safety of our immunocompromised patients. On the top floor, you'll find our Cardiac Care Unit, one of the only pediatric units of its kind in the country. The enhanced model of care combines the technology and expertise of intensive care with pediatric cardiology to provide patients highly specialized care in the same unit for the duration of their hospital stay. This incredible building is one small reason Lurie Children's is the top pediatric hospital in Illinois, but it's the people inside that make it a truly special place for kids.
You're in clinic or rounding. You need a protocol, a technique refresher, or a contact number, but it's buried in your inbox, a desktop file, or that giant binder no one opens. Stay Current MD is your team's knowledge organized in one app. Protocols, guidelines, how-to videos, technique refreshers, even links, contact lists, and department updates, all searchable, all mobile. Join one of the fastest growing medical networks, trusted by over 18,000 medical professionals in the world's top hospitals, with nearly 1 million views and a 20% annual increase in hospital spaces. Evidence clearly shows that guideline adherence leads to better outcomes. And you're not just accessing your own team's content, you're joining a network of hospitals sharing best practices, each curating their own space, all in one place. This isn't another app you'll forget to open. It's built for what you actually need. Quick answer, smart teaching, and better team alignment. If you've ever said, why isn't this easier to find? This is the fix. Stay sharp, stay connected, stay current.
At Akron Children's, we know that childhood is precious. Every moment matters, every smile, every milestone. We strive to create a positive experience for every child, every parent, every step of the journey. Pediatric surgery is different. Children aren't just small adults. Their bodies are still growing. They have unique needs. Our pediatric surgeons are experts in delicate anatomy. They know how to use tools built for small spaces and techniques designed for growing kids. We plan care not just for today, but for the lifetime ahead. Surgical care at Akron Children's goes far beyond the operating room. We know that surgery can be scary, for kids and for parents. From the waiting room to the OR, our spaces are designed with kids in mind. Everyone on our surgical team is passionate about caring for kids and their families. Because surgery can feel overwhelming, We guide the process with comfort, communication, and trust. We talk with parents, we sit with kids, we explain things simply, we listen and reassure. Because when families feel seen and supported, healing begins. Our goal at Akron Children's is to get kids back to being kids, to give families peace of mind, and answer every request for more childhood please with everything we have. Every decision we make supports a child's growth, development, and future quality of life. Because we know every child has something special to share with the world, and we're honored to be part of their story. At Akron Children's, we're a pediatric surgery team that puts families first, and we're proud to help bring a little more childhood to every child we serve.
Some said Tiago had 1 week to live, but this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds, it's about changing them for all kidkind. Hope, care, cure. Seattle Children's.
Welcome to John R. Oshai Children's Hospital, a place of hope, healing, and miracles. Oshai Children's Hospital is one of only 43 standalone children's hospitals in the nation, and the only one of its kind in New York State. The only one. Why is that so important? Because our whole staff is specifically trained in and devoted to the care and treatment of children from conception to 21 years of age. Because the entire building has been designed with patient and family comfort as a top priority. And most importantly, because the best of the best practice here at Oshai Children's Hospital. As a teaching hospital for the Jacobs School of Medicine and Biomedical Sciences and the University at Buffalo, our physicians are practice and thought leaders, training the next generation of physicians to provide the highest quality of care to our community's children. There are many things that make Children's different from other hospitals, even beginning before arrival. By downloading the My Kaleida app, families can use its GPS navigation to get to the hospital. And upon arriving, it automatically changes to walking directions so that families and visitors have no problem reaching their destination within the building. Parking is plentiful, safe, and close. Whether you choose to self-park in the parking ramp located on the corner of Ellicott and Goodrich, or use our convenient valet service. Walking into the hospital is like Dorothy opening the door to Oz. Bright colors, artwork, playful interiors, and comfortable seating are just a few of the distinctive sights you experience upon entering. The lobby features a gift shop that's any child's dream. A Tim Hortons, which is many a parent's dream, and an entertainment space to host holiday parties, performances, and special meet and greets with local and national celebrities. Each inpatient floor has a playroom where children can put aside their illness or injury and simply experience the joy of just being a kid. There's an outside terrace that allows visitors to get a breath of fresh air, soak in the sun during our beautiful western New York summers, and enjoy a view of the cityscape that's simply spectacular. But at the core of Oshai Children's Hospital is our team of expert clinicians. Their goal is complex, yet singular, to treat and cure sick and injured children. They've devoted their whole lives to that goal, and every single day they give their all to provide healing and make miracles happen. And at the end of the day, that's what John R. Oshai Children's Hospital is all about.
You asked. We delivered. The all-new Stay Current MD app was built with your feedback and your workflow in mind. We've shifted from browsing to search first, so you get the answers you need faster. Search understands typos, synonyms, even clinical shorthand, because at the bedside, there's no time to waste. Whether it's protocols, podcasts, quick videos, or more, everything is at your fingertips. A fully redesigned experience with smarter search, customizable spaces, advanced discussions, direct messaging, cross-institution collaboration, and more control over your profile, notifications, and content sharing, all built to keep you one step ahead. The new Stay Current MD, smarter, faster, built for how you work.
If you're worrying, know there's someone working relentlessly. If you're struggling, know there's a team on your side, pioneering breakthroughs. If you're questioning, know we are finding better answers. Because in the pursuit of healthiness, we're changing the outcome together. Cincinnati Children's.
There's nothing more important than our commitment to children. Our roots run deep, and we're always finding new ways to care. For more than a century, across the Mountain West, we've been dedicated to keeping the child first and always. Our team of passionate caregivers are combining forces in new ways to help children live their healthiest lives. It's the power of we. We're better together. Together, we're building something truly special. Together, we get to ensure the best outcomes for all patients. And together, with your involvement and generosity, we are building the nation's model health system for children. So, what does it mean to build a model health system for children? Intermountain Children's Health is the best outcomes for our tiniest patients, the nonprofit health system serving the most expansive pediatric geography in the United States, world-class hospitals, quality pediatric follow-up close to home, more than 1 million patient interactions annually, thousands of nurses specially trained to treat and support kids and the families who love them, nationally ranked subspecialty care, local pediatricians going above and beyond in their communities, a team of caregivers more than 10,000 strong, all united to help kids, caring for minds as well as bodies. It's finding new cures and delivering care in new ways. considering the whole child to help keep kids healthy and safe, and out of the hospital in the first place. Connected to our communities, accelerated by partnership, all powered by philanthropy. Intermountain Children's Health is and will always be the child first and always. Thanks to you. Join us in building the future our children deserve.
Ohio, Cincinnati, and Cincinnati Children's are no strangers to firsts. Our pioneers traversed brave new worlds, and Cincinnati Children's freed the world of polio. Our engineering inspired others, and Cincinnati Children's created new treatments that changed the outcome for kids. Our state was the first to electrify cities. Now, Cincinnati Children's is lighting the way for advances in organ transplantation. Ohio gave birth to aviation, allowing kids like me from around the world to fly to Cincinnati Children's for care they can't receive anywhere else. Cincinnati is home to the first professional baseball team. Now, Cincinnati Children's is using game-changing proton therapy to cure cancer. Today is another first for Cincinnati Children's, for the Queen City and for Ohio. Cincinnati Children's is proud to be the #1 children's hospital in the nation.
Welcome to Ann and Robert H. Lurie Children's Hospital of Chicago. Every aspect of our 23-story, state-of-the-art hospital was designed with kids in mind. An extraordinary place for healing and family-centered care, its flexible design and advanced technology enables our caregivers to provide superior care to the most critically ill children in Chicago and around the world. The second floor is also home to our Emergency Care Center, a state-of-the-art emergency room that sees more than 60,000 patients each year. Floors 3 through 8 are reserved for outpatient clinics, diagnostic testing, and procedural care. This includes our Chicago Institute for Fetal Health, one of only a few comprehensive fetal centers in the country, dedicated to the care of pregnant women with fetal complications. And our modern surgical suites, where we perform more pediatric operations than any other pediatric hospital in the state, using the most advanced techniques and minimally invasive approaches. As a tertiary and quaternary care hospital, Lurie Children's intensive care units care for the most critically ill and injured children and serve as a referral center for the community's hospitals whose patients require specialized, life-saving care. Our Center for Cancer and Blood Disorders offers the most comprehensive cancer care in the region. The space was designed to evolve to accommodate new technology and include special features to ensure the safety of our immunocompromised patients. On the top floor, you'll find our Cardiac Care Unit, one of the only pediatric units of its kind in the country.
All right, and we are back.
Hope everyone had a nice little break. We are now going to start onto a topic that we always have to seem to have every year, which is about appendicitis, because after all these years, we still don't agree. Before we get started, though, I do want to point out sort of the unsung heroes, the behind the scenes. So M. Guti, who has been working with me, she was a fellow that I took for my medical media fellowship from Turkey after getting her MD. And I was fortunate to recruit her to stay as my colleague. And she literally did 100% of everything you see here. She put together the agenda, worked with all the faculty, everything. So, Em, thank you for putting it all together. And then, of course, Julie and Claudia who help. And then the video crew, you guys don't appreciate. You don't see this most places, but the fact that they were able to bring in the remote speakers with no audio feedback, I still don't know how they did it. They get better every year, so we love working with them and Red Bicycle. All right, we're going to move on here, and I'm going to hand it off to, who's leading this? You, Nano?
Both,
All right,
50-50, but I'm starting. No. Okay, updates in appendicitis management. So we had to convince Todd to put this talk. And earlier in the morning you said, didn't we talk about this already? So we'll try to convince you why we do need to keep talking about this, and there's some novelty around this area. Hopefully I'll try to convince you. If not, I'm sure someone in the worldwide audience will appreciate it. Anyway, let's go with the vote. This is, again, same voting as in the morning, a 12-year-old patient with 1 day of right low quadrant pain. It's an uncomplicated appendicitis. Let's go straight to the voting. So the alternatives are just like a mixture of, hell no, that's just plain wrong, we should be doing surgery for everything, or E, I do it routinely, only surgery when necessary, and anything in between. So this is just to get an idea of what people are doing. So what does the number say? Don't do it routinely, but have done it in selected cases. That seems to be the most common one. You're winning now. You're winning.
I think one of the great advantages of this is our international colleagues. So in Mexico, what are you doing?
So I was talking in lunch. Mexico is a tale of two tales. In private practice, no pediatric surgeon in private practice wants to do it. On the public sector, I think it would be a D. They're starting to consider it, and they're starting to practice it, just some of them. Exactly, because of money. Because of money. And because I don't think if as a whole, we're having, doctors are having a trust problem. So if you go and offer an option in the private sector, hey, this is an option that you present to it as a viable way, and when it doesn't work, which in most of the times it doesn't work, they say, oh, so he's not good. Let me go for another private practitioner. So that's a very important part of it.
Yeah, I think we don't need to be talking to surgeons about this particular question. We need to be talking to pediatricians and EM doctors, because there's all sorts of things that are non-opt until they need an op, and then they call us. If they called us about everything that they could manage without us, that's all we would do. So the ones like, oh, well, I do the operation because I get paid for it. Yeah, maybe the pediatrician could talk to them, or the emergency medicine doc could talk to them. But if you need an operation, we have a subset of people who actually do that.
Wait, I have a question. I want to make sure I understand what you're saying. I guarantee you will not get past this slide because you brought up the topic of appendicitis. I may have misunderstood what you're saying because it just jolted my brain, which is not, yeah. So, are you saying that theoretically, these patients, we will not need to get called on them at all? That
yes.
So they will be managed in the community
Yes.
And only sent, so they don't, well, let's make sure the surgeon agrees that we can manage this. They won't have to do that.
They won't have to do that.
It will be managed before it comes to us.
And that's not going to be a year. That might be 10 years, 15 years. But it's
nothing
going
happens
to
that long
happen.
anymore.
It's going to
Okay.
happen.
And you were asking why we need to have this conversation.
all right,
Okay,
you're right.
are you convinced already?
I am.
Okay, so
That comment alone was huge, yeah.
okay, that was better than a whole talk, Stephen. Now we'll switch for the next two slides for Dr. Sean Peter, who will tell us a little bit about the history of these trials.
So the first pilot trial that was done in Europe, Thomas Wester and Jan Svensson, they randomized a pilot study with 50 patients, and 24 ended up getting antibiotics. Now, 2 failed early on, and of the remainder, there were 6 patients who ended up getting an appendectomy. Now, when we were trying to develop what our non-inferiority margin would be for the randomized trial that we talked about earlier, we really focused on those patients because only one of them had histologically proven appendicitis. The other 5 were for abdominal pain, and then there was one that was just mom preference. I felt like we needed to count all those because it's a real world situation. Sometimes mom's gonna get uncomfortable, even though the kid doesn't have appendicitis, and say, I'm done, let's take this out. So that was where we started from, and we started having the conversation about the randomized trial that I'll talk about in a second in 2013, before this study was even done and published. Then we fast forward to 5 years later, and they ended up having only 2 patients, and now you're already down to a smaller denominator, but only 2 of the remaining patients ended up getting an appendectomy in the next 5 years. So those failures that occurred relatively early on, and we saw the same thing in our trial. Then the Midwest Pediatric Surgery Consortium with 10 of the centers, Kansas City excluded, as we were working with the international folks on the randomized trial. The consortium did a non-randomized patient preference trial, and about a third of the patients ended up selecting the antibiotics. And they accrued at 1,068 patients, and in that they had a 33% failure rate, where patients ended up getting an operation. And like we found, and like others have found, if you respond well to antibiotics, it's basically like you had a little stomach flu one day and then the next day you're fine. So there's no somatic injury that you've incurred, and with the pain that was just being caused by the appendix subsided, you're good to go. And so these patients, they have less disability days, but when it works well, it's 0 disability days. They're good to play tomorrow. And we were randomizing with 11 other centers around the world. For hard randomization, once you get signed up, you're either going to get an appendectomy or you're going to get antibiotics. We used a computer centralized resource with the ability to tailor it so that with 3 different variables, if you were getting further off one or the other, then it ends up bringing it back to being balanced. And the difficult part was getting patients to consent for this study. And it was more difficult than any trial I've been a part of, because grandma knows you need to take out the appendix, the pediatrician knows you need to take out the appendix. We pushed the education to the ED, we pushed the education out to referring EDs, we pushed the education out to the transport services so that people didn't get sold on, you gotta hurry up and get your appendix out, get to Mercy and get your appendix out. And we still had a very difficult time getting patients to sign up because they didn't like the sound of recurrence. And this is something that we debate. Steve and I have had the conversation, Pete Minichi and I have had the conversation. When parents are sitting around a boardroom and they talk about what's tolerable, they say a pill versus a knife, then I could accept a 50% failure rate. When they've been up 36 hours with a sick child and now they're finally talking to a surgeon, they don't want to hear about any recurrence rate. So it wasn't, those moms weren't even in the position of hearing that we have a 30% failure rate based on our data so far. They didn't get that far, like, could it come back? Yes, it could. They wouldn't ask the question how frequently. They would say, no, that's okay, we'll just go ahead and sign up for the appendectomy. So what we found was we had a total difference in 26%, and we were counting negative appendectomy in the appendectomy arm as a negative result because you're not going to have a recurrence, so we couldn't compare the two. That's where we had 7% patients who failed in the operative group. 1 patient was re-explored within a year, was re-explored immediately for a hematoma. Everybody else was just a negative appendectomy, all the rest of the failures. And that's 7% against the 34% failure rate in the antibiotic arm.
Yeah, we're going to skip this. Are there any questions or comments on all that?
Yeah. First of all, I'd like to compliment you for doing the study, because so many people just kind of just parenthetically just did stuff, but never studied it properly like you did. Whit Holcomb sent me, I reviewed probably 300 appendectomy studies over about 20 years for the Journal of Pediatric Surgery. So we've been looking at this forever. And it's repetitively around 30% and in every study, over and over and over again. So I don't know why we keep asking the same question, truthfully. And so I'd like to ask you a question. If your child had appendicitis, would you go in the take it out arm or the antibiotic arm? For me, I would have my kid have their appendix out. I don't want to sit around and wait for, for a week or a month or a year to see if it's going to recur. We have an operation that we're really good at, and we do it very well, and I would like to know what you would do.
That's a great question. I think it depends on the context, where you're located, who your surgeon is, your anesthesiologist. Because there's a lot more.
You're tap dancing.
No, I'm not, because every study, in your 300 studies, I would guarantee every study has shown non-operative management is safe. That's the key. When you're comparing things, you're comparing differences. So it's a safe alternative. And so one of the things that you can do is a patient coming from Eastern Washington and needs a 4-hour transfer. I could treat that patient with antibiotics. They could stay home. We could follow them up with telehealth. I can then offer an interval appendectomy. I've just saved patient hardship, family hardship. I've saved transfer costs. I've saved all of these things.
It sounds to me like you're still getting an
But
appendectomy.
Steve, what about your child?
What have I missed?
I'll answer the question. If my son comes to my hospital with my partners and he has appendicitis and he's got a golf tournament within the next 5 days, he's getting antibiotics. Otherwise, he's getting the appendectomy. Thank you.
Okay, so I think when you ask a black or white question, you get, well, what's the most efficacious treatment? I think this trial proved it. It is appendectomy. But what we're trying to change the question a bit here, is there a role for it? Is there a grayscale area? Like this 30% gap between the two treatments, is that tolerable for some families or for the clinical situations that Stephen has pointed out? I think the answer is yes.
Name me another operation that we do if we had a 30% recurrence rate that we keep on doing it. I mean, if we had a 30% recurrence rate of our hernias, somebody would send us to jail. Name me another operation that we would do that we'd say, 30% failure rate. That's not so bad.
I think you're missing the question. What if you said it's not an operation? What if you said you can treat hernias non-operatively and 2/3 you can avoid surgery? That's the question we're answering, and it's safe. What would you say to that? What would you say to those who had diverticulitis and said, let's take them out? We'll 100% cure them, but we can treat the majority of them non-operatively. So it's a very different question. What if we could do all of these robotic? No, I'm just kidding. But so I think that's what we're getting at.
So you're saying that
it's not
30%, and you say none of them would ever get incarcerated? None of them would ever have a complication from the hernia? 30%, and we never operate on them? Is that what you're saying?
I'm saying we've shown it's safe, and that's the same thing. I think the point is it's a different endpoint you're looking at. It's not, you're not saying that this is an operation that this is 100% effective, and I think that's what we're trying to show today.
I think somebody, who was it that had the interesting point of if you actually lose your indication for operation because of 4 days of antibiotics, how do you actually take the patient to the OR and convince the system that that's the right thing to do for the interval? For the interval, yeah.
So in general, when you treat them, they're better after their first dose. And what we were going to get to later on is we've shown that you can treat these as outpatients, and therefore you can, as we all know, and even in the first randomized controlled trial, people change their minds. So now you're taking a pure urgent, emergent case to a pure elective. And I could schedule a patient who's hours away they finish their antibiotic course. I could schedule them in 4 or 5 weeks, 6 weeks, whatever it is, as an elective
But I'm
operation.
a medical director at United Healthcare, doctor, and you can't do that. I'm not going to authorize that appendectomy if that parent changes their mind. I'm sorry.
Next year, if you do appendicitis, no No slides, because you're not very
Yeah, appendicitis, that's it. Keep talking. Okay, let's try to get through some of these arguments. I don't think we have time for polls, but if you were to do non-operative management, would you admit the patient or discharge from the ED? I think this is one of the benefits, and I'm standing next to the senior author of the article we're going to present next. So 3/4 of them would admit, and I think if it's an admission for antibiotics or an admission for surgery, I think there's a very narrow gap, and many people would go for an appendectomy. But what happens now if you can send the child home, or as Steven said, we could avoid transfer? So they actually proved, this has been published this year in JPS, they screened 121 patients. They had very strict criteria, they're on the slides, and there was a 12% appendectomy rate at 1 year. I think we don't have enough time to look at this.
Jose, how many more points do you have to make? Let's say 4.
It's like 6 arguments.
So what I would say is, for now, this is what we do when we run out of time. Tell us what we need to know. Go through, and for each of them.
Okay, it is safe to send children from the emergency department. You don't need to admit them if you have strict criteria, and Steven can lead you through those criteria.
No, it actually ended up only a fraction of these patients received a second dose of IV antibiotics. So 2/3 actually went home from the ED, and 1/3 stayed, and no differences in outcomes. So fast forwarding, when we looked at, which one is this? This is parental preferences. Parents like to be asked. They like shared decision making. And in international studies, this was from Singapore, they actually would actually have a higher, again, not in an operative setting like you're saying, Sean, but when asked, they would actually prefer the non-operative approach. But in general, they like the discussion. And then moving on, this was...
So disability days, we've said it already. They lose less school days, parents lose less work days. How much is the gap? Around 4 days. This Midwestern Pediatric study found 10 versus 6 days. I found 10 a little bit too much for a simple appendicitis, but Dr. St. Peter's study actually found that the difference was 1 versus 4 days. So 1 day of disability, that's something I could totally buy in.
And then the last is cost effectiveness. And what we've shown, what's been shown in a couple studies is that the non-operative approach is more cost effective and has a higher quality of life years adjusted. So that may answer your question, Tom, about what the insurance companies, maybe they should treat all of them non-operatively and then go for interval appendectomies. The real reason is that way we don't just, we're not doing these in the middle of the night before. But again, if we're adopting the approach that you can put off your appendectomy to the next day because you have antibiotics that can treat these patients, we can also maybe extend that, saying we can push this off into weeks or later on, and actually only a fractional need, and it becomes a pure elective operation.
Oh, that's the last that's the last one.
Steve,
we haven't finished yet.
One question. In the last slide, did you put the interval appendectomy in the cost?
Yes. Yes.
Okay.
Okay, so
Got
next.
me there.
So this is not for everyone. Like, if you don't want it, if you're convinced surgery, but there's also other reasons not to do it. So next slide, please. Very quickly, appendicolith has been demonstrated to reduce the effectiveness of non-operative management and increase recurrence. And there's also a concern about the age. So when you reach around the age 14, you have double the chance of failing non-operative management. So I think those are two populations that maybe should not be offered this, or should be offered with caution. Let's keep going. Next. So these are the take-home messages. You wanna? Should I go?
We should just
yeah.
if there's more questions.
There's 3 minutes. I think that the discussion is more interesting than the presentation itself. So why don't we take it?
So you guys said 14, right? But isn't the adult data 30%, just like
That's
kids?
exactly what I was going to say, is that the CODA trial had the exact same failure rate. They had 1/3 failure rate, and that was 1,400 adult patients that were randomized. So I think within the pediatric population, you may see a little bit on a subset analysis, but I wouldn't put a lot of weight on it if we can treat 70-year-olds with the same results.
It sounded like I'll stand up. The negative appendectomy rate was used as a balancing factor for those who failed on the non-operative treatment arm. Do you think there's a role, or perhaps a greater role, for the patient with somewhat of a story for appendicitis, maybe an intermediate pediatric appendicitis score? Ultrasound is possible early appendicitis, let's say white count, CRP is normal. That patient that might be a negative appendectomy, if you took them to the OR, but you don't really know unless you do, is that a patient population to perhaps consider more for the non-operative treatment?
That's
versus
why
no antibiotics?
that's exactly why we suspect that some of the early case series had such a high success rate. All the randomized studies have a 1/3 failure rate, but initially people had 90% success rates when they had very selected cases, and probably because 20% of those patients didn't have appendicitis. So that's why they got better. And just since I got the mic, I'd be remiss to say that my name is put on the top of that trial because it got moved to Kansas City for other reasons that weren't anyone's fault. But I want to shout out to Simon Eaton and Nigel Hall and Augustino Piero with the core writing group for that trial initially before I got engaged. And hopefully Simon's still with us.
What about what happens to patients who are sent home and then for a year they wonder, they get a little twinge, they go to a hospital, get a CT scan or ultrasound? I don't know if that's ever been actually measured in terms of loss of work, loss of time, anxiety, and I think that's a part of the missing cost effectiveness question. It's a more question than
So that was all accounted for, like the whole disability days within 1 year, if you're asking about the trial. But no one's saying that antibiotics is definitive management. Like you need to screen for these symptoms for recurrence and treat the patients accordingly. Dr.
Quick question. So where do you all feel we will be in 20 years? What will be the norm for taking care of uncomplicated appendicitis?
So Steve and myself are being led by Pete Minichi, who's submitted PCORI grant twice now. We have yet to get funded. But we're going to be going a third round, and the ultimate plan is going to be to have a funded trial to discharge these patients from the ED. And then once that's established, I suspect that Nelson's correct. You're going to start having point of contact where you're going to get an ultrasound in the pediatrician's office and they'll treat it. And then the second go around, they'll say, why don't you go downtown and talk to the surgeons?
I think that's right, and I think it's interesting to look at the fact that 17 years, is it, that takes evidence to get into change of practice. I think Todd's the key to this. I mean, education, and are those people that are going to be educated going to be the ED docs? They're the ones who are going to control the gate.
Okay, fine. Very good. You resisted too.
I did.
Yeah.
I said I was lukewarm.
You were lukewarm on it. It's almost like we need a whole, yeah. Yeah, intro. This is all you hear?
Yeah, it's not me, trust me.
All right, so Dr. Dan von Allman cannot be with us because now Dan lives in the UAE. He'll be there for a couple years working on Cincinnati Children's in the UAE. So he is not here. So we found the better, smarter, faster, stronger version of Dan, which is his son, Doug von Allman. So Doug, are you there?
I'm here. Can you hear me okay?
Yeah.
Hey, Doug, we've got a hard act to follow here, just FYI.
So I'll let Dan moderate this session, but Doug is one of our absolute spectacular hardcore ENTs that does all the most complex stuff. And we've been asking him to talk about some easier things than the stuff he does every day. But Doug, thanks for joining us.
Yeah, thanks for having me. So yeah, I'm going to go through some of the innovative approaches we have to some of the head and neck pathology that you may come across. So can everybody see slides up there?
Yeah, we can see it. Yep.
All right. So this is a first clinical scenario. So this was a 4-year-old who came in with some painless neck swelling after a viral illness, had a CT scan that was done, and you can see this cystic mass that extends from the thyroid up to the piriform sinus there. She was treated with some oral antibiotics, and she got improvement in the swelling of her mass. Next slide, but I would like to know what you all, how you'd approach this. We've got our audience poll on the next slide, if you can advance for me.
Hey,
There we
Doug,
go.
while they're waiting, would
Yeah, go
would you
ahead.
say most people just jump to CT scan for neck swelling, or is this something that's
That's gonna buy
Yeah,
us.
I find we get a lot of CT scans that are performed in the emergency department before we've seen the patient. I think that's just part of a little bit part of the CYA practice that's just come, along with the evolution of things. But so yeah, I do find that a lot of times we have imaging before we've even been consulted.
okay? Do we have the results?
Yeah. All right.
Can you see it, Doug?
Yeah, so it looks like we get a fair amount of people would get some more imaging. We'd have a couple of people do percutaneous drainage. This is a branchial cleft cyst. And so we try, if possible, to avoid doing any interventions on these until we're ready to kind of resolve the issue. INDs can sometimes make it a little bit more challenging to go and remove these in the future. Traditionally, with some of these, particularly the type 3 and type 4 branchial cleft cysts, you can get some associated thyroiditis, and occasionally you have to perform a hemithyroidectomy if you get in there and it's really stuck, to make sure you excise the lesion. The interesting thing with these type 3 and type 4 branchial cleft cysts is that they typically have a tract going up to the piriform sinus. Can you advance the next slide? And if you can start that video, hopefully you can appreciate that little sinus right there. And you can actually use a little Bugbee cautery probe and cauterize this sinus, and it resolves the lesion and prevents recurrence. So you can see us sort of pulling that probe back, and then you'll see the cauterization right there.
Doug, what do you have
Next
to
slide.
be worried about? I love this because a lot of us do this for like H types or recurrent fistulas, not H types so much, but recurrence. So if we do this, what do we have to watch out for?
So obviously, just having a tube in there, you're using Bovie electric cautery, making sure that you have low FiO2, and you're using your safe fire precautions for using a Bovie in what could be an open airway scenario. And the biggest thing is just watching out for recurrence. It can take more than one, just like for endoscopic repairs of TEFs. Sometimes it takes a second time. So watching out for repeat swelling. I've also thrown a stitch in them as well. You can do that endoscopically.
But how deep do we need to go? Like just at the orifice?
You don't need to go deep. Yeah, you can really just insert the cautery, just tip a centimeter or so past, and cauterize, and yeah, you don't need to Bovie the whole tract.
Has anybody in here used a Bugbee for recurrent TF or this?
Has anyone done this?
No.
Has anyone used a Bugbee for anything other than a recurrent TEF?
And who, if they saw a type 3 or 4 branchial cleft, would send a TNT and not do it themselves? Or
I send.
Well,
would anybody do it themselves?
Now I will. I would call ENT for my first. I would do it with them, and then after that, I think if it's just orifice.
Because they're going to excise it, right? That's the point of this study
Yeah,
Doug's
it's
going to
just-
talk about. Yeah.
yeah.
So go ahead, Doug.
Yeah, so if you can go to the next slide. There it is. Okay. So this is a study looking at the comparison of doing that endoscopic approach versus an open excision, and the outcome of recurrence is equivalent. So it really does suggest that you can potentially avoid some of the morbidity with an open approach, particularly if you're talking about having to deal with thyroid, potential recurrent laryngeal nerve injury. This can save a lot of heartache for the patient. All right. So this next case, so this was a 7-year-old who came to us, had a history of TEF, EA, had a repair, and was having some chronic cough as well as some food impaction issues. She was referred specifically for the esophageal diverticulum, but we were involved to evaluate the airway as well. If you could click on start one of those videos, that'd be great. she'd had a couple dilations in the past without improvement. So that right side is the esophagoscopy. This is the esophageal anastomosis right here, and as you back up, you can see there's a little ledge that's been formed, and essentially that's just a dilated upper pouch. And if you can start the other video, that'd be great. And then this is the bronchoscopy video. So as you go through, you can see that there's some granulation tissue along the back wall. And then as we advance a little further, this was the original TEF, and we explored this, and that was closed. But as we probed that area where the granulation tissue was, you can see that there's a second fairly large open fistula there. And these second fistulas, or H-type fistulas, they can be really hard to deal with endoscopically sometimes. And so, next slide, please. So this was the esophagram showing that mismatch and that little outpouching. And then I want to know kind of how the group typically deals with cervical TEFs. So if you could advance to the next slide, I got a poll question there. So do you approach it laterally? Do you interpose any tissue? Do you do anything to the esophagus at the same time? And then would anyone consider going through the trachea?
You can do thoracoscopically.
Wait, yeah, so Doug, you're talking about an H-type, right?
Yeah.
So you have a group of pediatric surgeons that many of us inclined thoracoscopically. So I think that might be another choice to put up there, which is debated on which is easier.
Yeah, well, this is really high. So this is in the neck.
Yeah? Okay. Yeah, this has been the debate, Doug. I think sometimes it's very, very hard to get if it's really high, but there are people in here.
Or thoracoscopically, yeah.
Yeah, there are people that push for it.
I should have put an other.
I think it's tough. But yeah.
I don't know. I can tell you from personal experience having an H-type that I did with the ENT guys was really high. It was way easier than trying to go up there thoracoscopically and trying to divide it. I mean, I think we got to do what's right for the patients and eat our ego a little bit by saying we can do anything through the chest, because through the neck, in some circumstances, are probably better.
I agree. There are H-type fistula that are in the tongue, and there are H-type fistula that are in, inside the thorax. So I agree. You choose your battle, but I agree that 85% of them you can do it thoracoscopically, but some of them are really, really high.
If you do the bronchoscopy and it's like right under the cords or up high, really high, you're like, yeah, this shouldn't be done.
What I've done is put a guide wire through the trachea and put it out through the esophagus, and then take an X-ray with the patient on the table and see how far above or below the carina, the clavicle is. So that makes an easier decision. So you can actually kind of extend the neck and pull it up for a cervical repair, or actually do the opposite and push for a thoracoscopic repair.
All right, Doug, talk us through
Keep going, Doug.
Let's see the poll results. Let's see.
The poll results showed lateral with interposition of muscle.
Okay.
Yeah.
Yeah, so obviously if you can put anything intervening there, that's always helpful to prevent fistula recurrence. I think especially in younger kids and in the TEF-EA population, it's always you got to be a little careful about how much bulk you put behind there too, right? You've got a kid that potentially already has intrusion of a posterior tracheal wall, and then if you put some bulk behind there, sometimes that can make some of the obstruction worse too. So, but I totally agree. Preventing recurrence up front is really important. So if you can advance to the next slide and start that video. So we elected to do a transtracheal repair, and so this is a video that shows we got a distal tracheotomy here with the ET tube. You can do a bronchoscopy to help localize the level of the fistula and then make a tracheotomy over the fistula. You can divide work through the tracheotomy to divide the layers of the esophagus and trachealis. And then close the esophageal side. This is us putting a little bit of sternal periosteum in as an interposition graft, and then closing the back wall of the trachea. And that gets a 3-layer closure there. And you'll be able to see, hopefully, that closure there of the back wall. And then you can close the tracheotomy incision. And this is a really nice way to deal with a high fistula and completely takes recurrent laryngeal nerve injury out of the picture.
So has anybody done this in the room?
I didn't do it to the trachea. I didn't do it to the trachea. I just went laterally
Yeah.
into the neck.
The Cincinnati people don't get to answer that one, by the way. So Doug, the question in the room is the benefits of going through the trachea. I think you talked about recurrent laryngeal nerve injury.
Yeah, it's really recurrent laryngeal nerve injury I think is underreported. It really involves having a regimented group in place or a protocol where you have people look, and I think a lot of times you don't necessarily always look before and after. You can also have, kids compensate for those nerve injuries sometimes for quite some time, but if it is a true paralysis over time, that muscle atrophies, they have long-term voice problems, and potentially have issues with aspiration as well.
Hey Doug, in this picture, is that endotracheal tube going distal to your tracheotomy?
Yeah.
So you have another hole in the trachea distal to it?
Correct, and you can just close that at the end. If there's enough room for that, it makes life easier in terms of while you're working. Otherwise, you can go in and out or you can have a tube that sits proximal and pull it back if you need to, and you have to work a little bit intermittently with having the ET tube going in and out. So that's doable. It's a little bit more of a pain. So particularly on a bigger kid in this scenario where you have room to make a separate tracheotomy lower, and that should ideally be made about 2 rings below. Otherwise, you risk just tearing through the trachea there and making one big hole.
And that's bad, right?
Yeah. All right, I'm gonna keep it moving forward here. So this last scenario is a case that was a little bit of a struggle from a diagnostic standpoint for me, but I think it, elucidates some of the different ways that we deal with cystic neck masses in kids. And so this was a 16-year-old who presented with right submandibular swelling. It was soft, it was painless, and we can go to the next slide there. Had a CT scan, of course, and so this is the cystic mass that's heading up underneath the mandible there. You can see that in the axial view that it abuts the submandibular gland on that right side. Next slide. All right. How would you treat this? More imaging? Would you go after it? Would you consider aspirating it? Plus or minus sclerotherapy? Had a bunch more people getting more imaging and then some aspirating it. Great. All right, can you go to the next slide there? So I decided to go with the cervical approach. My concern was this coming or being involved with the submandibular gland there. It can be really hard to differentiate a giant ranula from a lymphatic malformation at times. I went through the neck, excised this, and of course, a couple months later, thing came back. So kid let me aspirate it in clinic. This is a technique you can use to potentially try to send this off for amylase to see if it is saliva in the lesion. There's some technical challenges with that, and I found this to be less helpful as I've gone through and tried to use this. The lab tends to have trouble running this thick fluid. And then you can also have lymphatic malformations near glandular tissue that have some leaching of some of the saliva into it, and you get a false positive. I ended up kind of hedging my bets and treating this as assuming that this was a ranula and doing a sublingual gland excision, which should resolve that. But I also had our IR guys go in and do an aspiration and sclero it. Of course, the thing came back again, and I ended up getting an ultrasound as he was developing some of the swelling, which suggested it was lymphatic malformation. And by removing all that sublingual glandular tissue, that made me pretty confident that that's what it was. And thankfully, after a repeat aspiration and sclero, it resolved. Next slide. So this is, so from a ranula perspective, really removal of the sublingual gland has been the key best practice piece of this. When you have a cervical component of that, you can even aspirate that, and as long as you remove the sublingual gland, it should go away because it's a pseudocyst. There is a new technique that's being used called micromarsupialization, where if you can identify an intraoral component, you can throw some silk sutures through the cyst, you let that sit for 30 days, it develops some fistula, and then you can cut the sutures out and it will spontaneously drain into the mouth. There's also been good data about using sclerotherapy for ranulas as well. So some less invasive techniques that can be helpful. Next slide. So when we talk about lymphatic malformations, obviously you've got a mix of surgical and medical therapies. Those medical treatments up there are undergoing clinical trials. Can you go to the next slide for me? This was an algorithm that was recently published in the pediatric surgery literature. Obviously, the component of that lymphatic malformation is going to tell you what to use as far as surgical or medical treatment, but that's often multimodal. Next slide. So the new development is that there are now some gene panels that you can send for that really help guide medical therapy going forward. So particularly the PIK3CA mutations in lymphatic malformations suggest that alpelisib drug can be useful as a PI3K alpha inhibitor. And there's several different panels out there, but probably the biggest, most comprehensive one is VanSeq, which is run in Seattle, at least that I'm aware of. And so that's going to be a big thing going forward in helping to manage these lymphatic malformations.
So Doug, you're saying if you have the PIK3CA mutation, the drugs like sirolimus work better?
So
have more effective?
The alpelisib, yes, that you're a good candidate for that. And as we identify different mutations in these pathways, we're going to be able to better use these drugs. There's some limitations. Alpelisib, you got to wait till they're 2, and so often right now, at least, our group is putting kids on sirolimus until they're ready for that. But there's some different drug profile, or as far as side effect profiles of these drugs, where we can potentially eliminate putting these kids on these medicines for long periods of time and not seeing as good at outcomes. And then if you can go to the next slide for me. And then this is the way we think a lot about pediatric neck masses when we're starting to go through and develop differentials. Can you go to the next slide for me? But I just want to point out that these congenital development neck masses are really the ones that you have to do something special for. So you have to not just excise the mass, but you have to deal with the embryological component or and etiology to prevent that recurrence. So, and with that, I am happy to end and take any questions or comments.
Did you have a clock running in your office there? Because you finished
yeah, you
with
literally
2
finished
seconds.
exactly on time. So
nice.
Any questions for Doug?
I can tell you that we will be sending everyone the high points, the articles, the things that everyone needs that you learned. Doug, this was phenomenal. My only regret was you weren't here in person, so next time.
Yeah, me too.
Thanks, buddy.
Thank you.
All right.
Thank you, guys.
All right. Let's play the intro and we'll get set up for the next one. All right, so the next session is going to be nerve monitoring and nerve stimulation. So wanting to hit the nerve and not wanting to hit the nerve, 2 extremes, by Ben Ham from Buffalo.
Thank you.
So we'll touch on recurrent laryngeal nerve monitoring. I know it's already been mentioned for esophageal atresia and airway surgery some. So we'll focus on for thyroid surgery. Sacral nerve stimulation for children with medically refractory fecal incontinence or severe constipation, as well as diaphragm pacing for respiratory failure. So we'll start with a case. A patient presents with a 1.1 centimeter right thyroid nodule that is TIRADS 4 on ultrasound. On fine needle aspiration, it is Bethesda 3, which is atypia of undetermined significance, in addition to some other possibilities. Otherwise, no past medical history, negative workup, normal labs. Have a few different options up there. So what would be your next step? What would you recommend? I'll open it up to the audience.
Any comments from anyone here? Looks like it's all over the place.
I think Bethesda 3, you can also repeat the FNA.
So the adult guidelines mention that as a possibility, repeating the FNA. You wouldn't want to do it early in an adult because sometimes having a prior FNA can affect a future FNA if it's done more recently. Molecular testing, there's various different companies, Afirma, et cetera. That's in the adult guidelines as well. And it's not currently in the 2015 pediatric guidelines other than being mentioned, but the new guidelines are being written and possibly coming out within the next year or so. And so we'll see if they make it into those, possibly in a different way than they currently are for adults. For this nodule that would have an intermediate risk of cancer, probably 30% or so, would not recommend a thyroidectomy because they probably only need a hemithyroidectomy, and then you avoid the additional risk associated with it. And so then the main question becomes, are you going to do it, or is somebody else going to do it? And then are you going to do it with or without nerve monitoring? And so the 2015 pediatric guidelines do recommend it being done by a high volume thyroid surgeon, which with pediatric disease not being as common as adult diseases, there's not many centers that have, even if they only have one person doing it, 30 a year by a pediatric surgeon. And so you can either have a high volume adult surgeon either do it, or I will typically invite a higher volume adult surgeon to join me for the nerve and parathyroid identification portions. And so potentially a couple different answers, and we'll touch on what TIRADS is later. And so mentioned several of these things already. Lobectomy for pediatrics is recommended rather than molecular testing or repeat FNA currently, because there is a little bit higher rate of malignancy in those populations compared to adults. And then if it did come back as cancer, then completion thyroidectomy would be recommended. So either of these two options, C or E, would be what the literature leans towards currently. And then one recent study published the rate of recurrent laryngeal nerve injury decreasing from 8 to 1.5% with monitoring. And there's various different monitoring options, which we'll touch on a little bit. But in a recent survey, about 80% of pediatric thyroid surgeons do use monitoring. There have been studies in adults that have shown that maybe it helps you identify the nerve more, but maybe doesn't change injury rates. And we don't have studies that I've seen in pediatrics showing significant decrease in injury rates, but there's several that do show absolute, so it's probably open for a meta-analysis to be done. And so with a higher rate of nerve injury in children, it's a smaller nerve, maybe harder to identify. So the rate in children's 9% versus about 6% in a combination of many studies. That may suggest it may be more helpful to use it. And then the main thing is avoiding the risk of tracheotomy if you have bilateral injury. And that may lead you to stage it if you have injury on one side that you've seen with the nerve monitoring. You may want to wait and see if it's just a transient thing that can then recover later.
Hey Ben, can I ask you, what's the downside of the monitoring? You know, is there a downside to the monitoring? Because it seems like to me like a no-brainer, but it might be a resource challenge. But is that the only downside to it?
Yeah, expense is one consideration. And if it doesn't change the injury rates, some have said, well, why use it if it doesn't change the outcomes? And others have said, well, maybe there's just not enough power in the studies to show that. And so those play into the common arguments. The other thing is that oftentimes in pediatric patients, there may not have been devices small enough to monitor it. And you can see in this publication, they've stratified it by ages where it has been tried up to like age 5 or age 4 in others, and in some other recent adhesive publication or endotracheal tube electrode publications, even down to age 0. So we may be getting to where it's available for even the smallest patients now.
I think one of the other downside is when we're not used to using the probe as much as our ENT, as the ENT people, sometimes it just beeps the whole surgery.
So with several studies coming out, intraoperative nerve monitoring can be considered for almost all pediatric thyroid surgeries now that adhesive electrodes can be put even on like a 3.0 ET tube now. It may be most beneficial when you're doing a total thyroidectomy where the contralateral cord is paralyzed to try to help decrease the risk of tracheotomy with bilateral paralysis. May be helpful also in reoperative surgery. And so something to discuss with the patients when you're consenting, if you are using it in the setting of doing both sides, that if there were changes on one side, that might lead you to delay and do the other side later. And so that's how it can impact surgical decision making. In terms of TIRADS, so this was developed for adults. Basically, it risk stratifies nodules based on ultrasound imaging characteristics.
I'll probably skip over because we're almost out of time. So maybe just give
Sure.
like a 2-second summary of what they need to know about TIRADS.
Sure. So it has been cautioned to not use it for pediatrics in one paper, and our radiologists always put this in our reports. But there was a recent paper with one of the authors here in attendance suggesting if you adjust the size criteria, it actually performs better than the 2015 pediatric guidelines. Dr. Aldrink, would you like to comment?
Yeah, I wanted to make one quick comment just about the electrodes too. For if you don't have a tube or if a child is too small for the 5.0 tube, the electrodes come separate too, and you can just do a direct laryngoscopy and put them directly into the vocalis muscle, and it can monitor that way. So just a hint if you have a MEN patient that you want to do that. We did this. This was our smaller multi-center study, and then we just finished through the Pediatric Surgical Oncology Research Collaborative. We did a much larger multi-institutional study looking at TIRADS, and using the modified version or the PEDS TIRADS, which basically says for every TIRADS 3 that's over 1.5 centimeters, we would recommend biopsy. And with using those restricted criteria based on size of the thyroid relative to size of the patient, and that modification, we didn't miss any malignancies. So it does perform better in terms of sensitivity and missed malignancy rate.
Great. Thank you.
If anyone's streaming the event, just make sure your volume's up so we're getting feedback.
So we'll move on to next scenario. A 13-year-old male with a history of idiopathic functional constipation presents with daytime and nighttime fecal incontinence and has been unable to remain clean despite more than 4 years of enema and laxative therapy. PHGI has referred him. Contrast enema showed an elongated sigmoid colon, otherwise normal. Previous rectal biopsy was normal. So what would you recommend? Botox, ACE, cicostomy, sigmoid resection, sacral nerve stimulator, ileostomy, something else?
I see one option that's not there, and the challenge that we find is that often our GI colleagues are all over the place with how they manage these kids. And when we put them through formal enema bowel management, we get a lot of them clean. So like I would put that up there too.
This scenario, the kid has had that, so.
Okay.
We got 3 minutes.
All right. So one thing that could be considered, ACE, of course, or cicostomy tube, is a sacral nerve stimulator trial. And in that trial, the rates of daytime incontinence decreased from, the rate of wearing a diaper during the day decreased from 19% to 2%. And then at nighttime, it decreased from 33% to 11%. It's not FDA approved in kids. There's a Cochrane review in adults suggesting that it can help with fecal incontinence. And so it may help avoid an ACE or other options. And then there was a recent retrospective cohort study with 70 patients. Can we show our poll results? No? Okay.
Have a poll. I would just keep going.
Yeah. All right. And so in this study, it showed improvement in the involuntary daytime and nighttime bowel movement rate. There were side effects of pain and neurological symptoms, and about 40% did require reoperation within about 3 years for dead battery of the stimulator or replacement. So basically with these, the stimulator is placed through the third sacral foramen, and it sends signals to the sacral nerves, and then you see how the kid does for a couple weeks. If it is helpful, then it can be implanted in a more long-term fashion with a battery. And we have a couple authors of this paper in attendance too, if they want to comment.
Well, yeah, the biggest challenge that I found having started doing sacral nerve stimulation when I got to Cincinnati about 7 years ago was who is it a good option for? So you described your case has some of those key points there. So tell me, what do you think? Who's the patient that you're going to try this on, and like the others, you probably wouldn't try it on?
I think it's a conversation with the family to discuss the options and whether an ACE or cicostomy tube and the associated things with that would be the preferred approach, or if it's not a patient who wants those things and they want to consider something else, then that's an option.
Why don't we do
just real quick, the only other thing I would add to that is that the kids with urinary incontinence tend to respond pretty well, and learning from the adults, the urologists put these in a lot of times for urologic indications, so that's usually something that will lead me towards offering it if they have urinary incontinence as well.
All right, you want to just give a quick summary of diaphragm, just like a minute?
Sure. So for kids who have hypoventilation, whether it be due to central hypoventilation syndrome, spinal cord injury, ALS, metabolic disorders, diaphragm pacing is an option and has been able to avoid tracheostomy in some patients or help wean patients with a tracheostomy off of ventilation and get off the tracheostomy. It can be done in different ways, phrenic nerve stimulation or direct diaphragm stimulation. And so here's an image where you can see the leads implanted in the diaphragm. Did you have comments on it, Todd, since I know one of your papers was
it's
in the review?
Thing you guys should all learn to do. Ray Anders invented it here in Cleveland and did Christopher Reeve, and it's incredible. It gets kids off ventilators. It's very easy, so everyone should learn how to do it. I just got a text from Yama yesterday that he's doing them now. He's done a lot. So, all right, you covered a ton in a very short amount of time. So thank you so much, man. That was awesome.
No question.
Oh, okay. 10-minute break. We didn't have to rush them. Okay. Sorry, Ben. We didn't have to rush you so fast.
Ohio, Cincinnati, and Cincinnati Children's are no strangers to firsts. Our pioneers traversed brave new worlds, and Cincinnati Children's freed the world of polio. Our engineering inspired others, and Cincinnati Children's created new treatments that changed the outcome for kids. Our state was the first to electrify cities. Now, Cincinnati Children's is lighting the way for advances in organ transplantation. Ohio gave birth to aviation, allowing kids like me from around the world to fly to Cincinnati Children's for care they can't receive anywhere else. Cincinnati is home to the first professional baseball team. Now, Cincinnati Children's is using game-changing proton therapy to cure cancer. Today is another first for Cincinnati Children's, for the Queen City, and for Ohio. Cincinnati Children's is proud to be the #1 children's hospital in the nation.
Welcome to Ann and Robert H. Lurie Children's Hospital of Chicago. Every aspect of our 23-story, state-of-the-art hospital was designed with kids in mind. An extraordinary place for healing and family-centered care, its flexible design and advanced technology enables our caregivers to provide superior care to the most critically ill children in Chicago and around the world. The second floor is also home to our Emergency Care Center, a state-of-the-art emergency room that sees more than 60,000 patients each year. Floors 3 through 8 are reserved for outpatient clinics, diagnostic testing, and procedural care. This includes our Chicago Institute for Fetal Health, one of only a few comprehensive fetal centers in the country, dedicated to the care of pregnant women with fetal complications. And our modern surgical suites, where we perform more pediatric operations than any other pediatric hospital in the state, using the most advanced techniques and minimally invasive approaches. As a tertiary and quaternary care hospital, Lurie Children's intensive care units care for the most critically ill and injured children and serve as a referral center for the community's hospitals whose patients require specialized, life-saving care. Our Center for Cancer and Blood Disorders offers the most comprehensive cancer care in the region. The space was designed to evolve to accommodate new technology and include special features to ensure the safety of our immunocompromised patients. On the top floor, you'll find our cardiac care unit, one of the only pediatric units of its kind in the country. The enhanced model of care combines the technology and expertise of intensive care with pediatric cardiology to provide patients highly specialized care in the same unit for the duration of their hospital stay. This incredible building is one small reason Lurie Children's is the top pediatric hospital in Illinois, but it's the people inside that make it a truly special place for kids.
You're in clinic or rounding. You need a protocol, a technique refresher, or a contact number, but it's buried in your inbox, a desktop file, or that giant binder no one opens. Stay Current MD is your team's knowledge organized in one app. Protocols, guidelines, how-to videos, technique refreshers, even links, contact lists, and department updates, all searchable, all mobile. Join one of the fastest growing medical networks, trusted by over 18,000 medical professionals in the world's top hospitals, with nearly 1 million views and a 20% annual increase in hospital spaces. Evidence clearly shows that guideline adherence leads to better outcomes. And you're not just accessing your own team's content, you're joining a network of hospitals sharing best practices, each curating their own space, all in one place. This isn't another app you'll forget to open. It's built for what you actually need. Quick answer, smart teaching, and better team alignment. If you've ever said, why isn't this easier to find? This is the fix. Stay sharp, stay connected, stay current.
At Akron Children's, we know that childhood is precious. Every moment matters, every smile, every milestone. We strive to create a positive experience for every child, every parent, every step of the journey. Pediatric surgery is different. Children aren't just small adults. Their bodies are still growing. They have unique needs. Our pediatric surgeons are experts in delicate anatomy. They know how to use tools built for small spaces and techniques designed for growing kids. We plan care not just for today, but for the lifetime ahead. Surgical care at Akron Children's goes far beyond the operating room. We know that surgery can be scary, for kids and for parents. From the waiting room to the OR, our spaces are designed with kids in mind. Everyone on our surgical team is passionate about caring for kids and their families. Because surgery can feel overwhelming, we guide the process with comfort, communication, and trust. We talk with parents, we sit with kids, we explain things simply, we listen and reassure. Because when families feel seen and supported, healing begins. Our goal at Akron Children's is to get kids back to being kids, to give families peace of mind, and answer every request for more childhood please with everything we have. Every decision we make supports a child's growth, development, and future quality of life. Because we know every child has something special to share with the world, and we're honored to be part of their story. At Akron Children's, we're a pediatric surgery team that puts families first, and we're proud to help bring a little more childhood to every child we serve.
Drawing his art. All right. What are we doing here? All right. All right. All right. Are we good? All right. Oh, can I talk or are we on? Are we live? We're live now. We're live? Yeah. All right. So for the in-person audience, we're switching things up. We're going to try something. We're going to let you watch the live stream instead of, so for the speakers, use just this. This will be the live stream. We're going to see if it, James thinks it might freak people out, but if it freaks you out, we'll stop. Okay. We like experimenting always. There's something else I had to say, but I can't. All right. So it seems like the afternoon, before I turn this over, it seems like this afternoon is a lot of things that a lot of people don't do. So we know internationally, we've talked about not doing ECMO and eCPR because majority of hospitals don't do it. A lot of people don't get into heavy oncology, which is coming up. A lot of people don't do thyroids. So we decided this time to do things that aren't necessarily the most common because it's worth doing every so often. So I think this is a great topic. Are you introducing or you want to just let them go?
We'll just let them go. We have Doctors Guria and Rothstein to do our next session on eCPR and ECMO cannulation.
All right, so we're going to talk mostly about eCPR or solely about eCPR.
Just raise hands. Who does eCPR in your institution? Extracorporeal?
Who enjoys it?
All right, we have like 8 people in the room.
All right, so.
Oh.
And you can explain what eCPR is? Or
Yeah, we will. Yeah.
To explain it.
Maybe just go next slide. So we have no disclosures. Which one? Okay. We did chat with each other a bunch, but we didn't use ChatGPT, and maybe we should have, and we'll find out in 2 more sessions, right? So what we wanted to talk about is eCPR. So what is eCPR? It's extracorporeal cardiopulmonary resuscitation, which is different from conventional. And it's the idea of adding ECMO or extracorporeal life support membrane oxygenation to a conventional run of CPR to increase your outcomes. And what is success? We can just define success as survival, probably better to determine sort of favorable neurologic outcomes. I'll leave it intentionally vague. There's lots of things to consider. There's both the technical aspects, the preparation, the ethical and emotional costs. And we decided the eCPR can stand for a lot of things. We won't have enough time, of course, to talk about the ethics, but we talk about ethics of why to go on, what are the disclosures to families, are there equitable use of resources, criteria, very important, who should be considered for ECMO, or eCPR rather, how to prepare, team preparation is really, really critical. And if we have time, let's just mention revisiting, which is long-term follow-up. We wanted to put up 4 or 5 scenarios just to get the mind going. Imagine you're the on-call provider and you're asked to put these kind of patients on a life support circuit if conventional CPRs aren't working. Here's a patient with hopefully a fixable problem. Here is a patient with probably a treatable disease. You don't know why they've arrested, but they probably could be fixed. At least that's the mentality perhaps. Here's a patient with a terrible disease and a bad complication, and now day 15 without much prognosis. Does that change your attitude, or should we be providing the best care for everybody, not worry about why they are in a state where they are? This is a common scenario where out-of-hospital cardiac arrest in kids is not often performed and probably has bad outcomes if you look at adult literature. This is different, perhaps. We have a same scenario of drowning, but now we have immediate response, immediate compressions, and return of circulation, at least temporarily. Pardon me. First poll is who qualifies for eCPR? So we can take a polling section here. Anybody in hospital only, based on underlying illness or other?
Looks like in hospital only. Does anybody here do out of hospital arrest CPR? eCPR, I'm sorry, eCPR. Yes, Utah.
Ron, raise your hand.
Utah. Oh, not outside of hospital arrest eCPR.
We do. We have a pretty robust program for cold water drowning because we have so much cold water, especially with the spring runoff. Now, that said, after reviewing it, our outcomes are, as you would expect, they're pretty low.
Dr. Russell is from Utah for the people online.
Yeah, but then we also do eCPR for other reasons for out-of-hospital arrest.
Okay, big challenge for institution and city, right?
One of our questions here is, do we give offer ECPR for everybody as a sort of equity issue or like a moral issue, or do we actually refine the indications? And it's not dissimilar to anything. Do you do a code? Do you run a code on anybody? So those are philosophically big questions, and we can't answer them, of course. We talked about so we want to add one little layer. So not all drownings or not all out-of-hospital arrests are the same. Somebody might come to you after a kind of a dismal presentation, but they have very reasonable numbers reflecting some sort of circulation. And you may have somebody who's got great response, community response, and has terrible numbers. So this adds to the findings. You want to say something?
Yeah, one other number that we pay attention to is the potassium. And just, the idea is, especially with avalanche victims and then also these cold water drownings, do they get cold first or do they get hypoxic first?
I think of potassium as if I like the number, I use it. If I don't like the number, I make an excuse for it. But
we have a cutoff at 8.
Okay.
Would anybody put on ECMO a baby in-house arrest with a pH of less than 7? Sure? Hands? Yes? 2 hands. Wow.
Okay. Before I turn it over to one, so we thought maybe one way to look at it is if you look at physiology and lab parameters versus the duration of downtime, which mentally seems like they're longest. If they're getting CPR for a really long time, maybe they're a bad candidate. So this box in the right lower side is the best, right? They've got great numbers. They've not been getting CPR for much time. But maybe great numbers are more important than downtime. Don't know. There's some suggestions, and probably the worst, of course, is long downtime and terrible numbers. Upper button close to here.
Close to here. Keep it close. Excellent. Oh, keep it very close.
Yes.
Oh. So who are these candidates? And it's really hard to say like, oh, you're going to be a candidate or not, right? And we need to make sure it's a witness arrest, of course, specifically for the out of hospital, right? Like, there's only maybe 1 or 2 institutions out there doing out of hospital arrest ECPR, which is very tricky both for the institution and the city. You need a lot of resources for that, and the community has to buy in on this. But in hospital arrests, right, you need to have reversible pathology. The ECMO, remember, is not a destination, it's a bridge to try to give or gain more time. You're not fixing anything while you're on ECMO. So, for example, at Cincinnati Children's, we have and this is a big shout out to our PQ team, whoever gets to the PQ, humanically not normal, they get a candidacy, yes or no, before anything can happen to them. So by the time, if there's unfortunately a cardiac arrest, the team already decided whether there's going to be a candidate. So that's huge. When you run up there, you're not struggling to find out. They've already talked to the family in the case of these arrests, right? They question mark or big asterisk there, like active bleeding. Would anybody put a patient on ECMO with pulmonary bleeding? Not dying pulmonary bleeding, but there's some blood in the ET tube. ARDS. Yes? No? Hell no. Hell no is good. They are candidates. We have a lot of new things now. We have inhaled TXA. We have epinephrine through the tube. Bronch, you can go in. ENT docs and pulmonologists are great for this. So they are candidates, okay? So plan ahead early in the cardiac arrest, of course. In our hospital, after the second dose of epinephrine, they activate ECPR. So all the teams mobilize, and then you have it available.
Hey, this is great and all that, and a lot of people are candidates, but you're talking to a group of people that will struggle through this to get a kid to survive, to try to get a kid on ECMO. And I'm on the ELSO registry website right now talking about survived to DC or transfer. But my point is, like, if you don't get real hardcore outcome data back to the world, that not only are you going to have people that will make it not to transfer but to discharge, but that it's a survivable outcome that anybody would want. That's the argument that I think needs to be made a little bit clearer.
And we're not going to answer that here, sorry. There are some data on what helps make things work. Reduce flow interruptions. You're going to get a lot of people counting your time off. Reduce pre-ECMO time. Simulation has been shown to, I think, have better outcomes, at least in terms of team dynamics and patient selection. I think you mentioned that I think it's a critical point, is that ICU teams need to really think every day about ECLS candidates, in both electively and in the crunch. So it's not a 2 a.m. moral distressing decision, say, hey, this person should go on, and nobody really knows why or anything about the patient. I'll breeze through this really briefly. In adults, of course, very different, but much more robust data. There's no randomized trials in kids. In adults, there are some randomized trials that suggest that a robust system that can improve neurologically appropriate outcomes to survival over conventional CPR. But remember, it's a very different physiology, usually cardiac lesions. There have been 3 adult RCTs for out-of-hospital cardiac arrest, and I just want to point out that there's 3 different answers. One, it's better, one, it's worse, and one, it's no different. So a lot more data needs to be done in adults, let alone in kids. The ELSO data, I think 3% of eCPRs were for out-of-hospital cardiac arrest. I think there's a slide coming up. So we ask, what are the outcomes of eCPR to answer, or to address Nelson's question, how does eCPR compare to CCPR, and what predicts success? Here's some stuff.
Yeah, so talking about the ELSA outcomes, right? Like if you look at, obviously, neonatal pulmonary has the best outcomes, right, as we all know, but look at eCPR, right? Survival ECLS, 70%, 60%, survive discharge, 40% in both pediatric and neonatal. It's very close to our other indications for ECMO, right? So eCPR provides these numbers now. So that's your answer. You wouldn't make that patient a candidate. We have 58%, 70%, 50% discharged.
But it's not. It's survival to transfer or discharge, and I would argue that is a completely useless outcome metric.
To discharge.
Yeah, so what's the survival to discharge? Take that transfer out of there. That's like a dirty number. So clean that up.
So easy. Coming from a colorectal surgeon. So we know from published data, right, ELSA database, eCPR improves survival to hospital discharge in pediatric cardiac arrest. If you compare it to conventional CPR, survival to discharge 40%, favorable neurologic outcome 30%. Here is, so you wouldn't give that patient a third of a chance? I would. You would? There you go. Yeah. Okay.
And also, there's going to be substratification. So, for example, for meningococcal sepsis, I think the outcomes are in the single digits, no matter what you're doing. Whereas for cardiac primary eCPR, so you have to think about which patients. We're not saying offer to everybody. This is a study that looked at strongest predictors of mortality, sort of both pre and post. This is a survival to hospital discharge was 44%, sort of in line with the ELSA data. Before things we mentioned after pulmonary hemorrhage that occurs after neurologic complications, including stroke, seizures, and then renal failure, are all predictors of post-eCPR mortality. So should we offer eCPR? So one of the questions we ask is, what are the complications, whether cervical approach with stroke risk or femoral approach with limb complications or other bleeding complications? And how can one weigh the complications of eCPR against CCPR? Remembering we're activating eCPR really early in the run, and you may be asked to put patients on who might survive with conventional CPR, and those questions are really unanswered yet in the pediatric literature. And decisional needs, I commend to everybody this paper out of Colorado by Pepe Diaz-Moron, who did some really in-depth interviews with people talking about distress sounds kind of soft, but it's really important to think about what goes through teams when they're asked to put somebody on eCPR, how it affects families, how it affects providers in the ICUs, how it affects us. We'll go back to our clinical scenarios. This is actually a patient we had recently in our hospital, a gal. She did have aplastic anemia. She was heavy set. She had basically 4 years gangrene and needed ECMO. Request wasn't for VA, but a poll question with this patient here with extensive perineal debridement and a terrible disease, a terrible complication of disease. Let's say you decide to go on ECLS. How would you approach this? Bifemoral, finding some ways, carotid in a 17-year-old, central for sepsis or other. Call the colorectal team because there's a colorectal problem, right?
Transrectal.
So two-thirds going through the carotid, a small minor, and then smaller part bifemoral or central. Do you want to make any comments on central for sepsis?
Yeah, I think this is a key thing, right? Like, we all know that septic patients require a massive amount of volume to support them through ECMO, right? And most of the times you need central support to be able to drain that much out of the venous system. But in terms of when there's CPR ongoing, you can always put them on the neck and then transition to central once you're flowing and you're oxygenating better. Do you have to jump on central on every septic patient? No. I will put this patient through the neck if it was me. We're going to talk about stroke rate, but then you can always transition to central if needed.
So we learned something about each other's institutions. In Seattle, we've been pushing more femoral because it sort of stays out of the way of CPR. In bigger kids, you have size, but there are definitely considerations for femoral vessel injury and limb loss. I learned that one institution does exclusively or almost exclusively neck, and so we looked into a little bit about what can we answer for stroke rate. So
yeah, so these data has been going back and forth in the last 20 years. Like we used to think like, oh, it's huge, the risk of stroke. Don't do it in adolescents. 15 kilos go to the legs, the femoral vessels. Below that, it's not enough flow. Then they transition to, no, we were wrong. The risk is really low. Current data, 10%, from 2.2 to 10.4% of stroke rate, right? However, in a smaller kid that your femoral outflow is not going to be enough, 10%, I think is a reasonable number, right? It is not insignificant, the risk of stroke in older kids and adolescents when you go in the neck, especially if there's not a complete circle of Willis that you do not know by then, right? But it's something to think about, right? Does anybody do here femoral approach? You tell us. Okay. We used to do that in Phoenix when I was in Phoenix. You do need a distal perfusion cannula or make a chimney preferably. But you need to think about this stroke rate. It's up to 10% on current data, so something to think about.
To somewhat summarize, I think it's important to get on however you can get on, and it's regional practices. Some people go femoral, some with neck. You can take your time getting off. You can involve vascular surgery if you like, or some partners to have a really good controlled, particularly in the groin. This is a debate we won't have time to talk about completely, but as we know, there's the groups that ligate the carotid after removal and those who will reconstruct. There's pros and cons to both. I wanted to make a pitch for long-term surveillance no matter what, even if you have ligate, because we're finding out more and more. We've done a study at Seattle Children's where we found most of the studies that are published are mostly sort of binomial outcomes. There is either a complication of the neck reconstruction with some narrowing or occlusion, or it's open. And I think there's more subtlety to that. We've been finding dilation, narrowing of different percentages, even intimal flaps. And so I think it's really important to...
Pseudoaneurysms.
Yeah, so over half of our group has, in the 7 years median follow-up, has had some perhaps actionable into adulthood. So we just make a pitch for long-term surveillance rather than a one and done. Lastly, to say that ECPR is probably associated with improved incomes in the right patients at Nelson. Volume, experience, and preparation really matter, and patient selection is critical. Some people even argue you should go on ECLS before it becomes ECPR. Again, not enough time to debate that. And to summarize.
Yeah, I mean, the other thing, we used to say, oncology patients, not candidates, and trauma and bleeding, not candidates, right? We're putting more and more patients on ECMO nowadays. Everybody goes on, right? Everybody's a candidate. Oncology always comes back no, we can treat this, right? So put them on, right? Post BMT, yes or no ECMO?
Depends on how long they've been from engraftment, though, right?
Exactly, engraftment is key, right? Patient selection. That's why you need to preventively talk to the PICU, is this a candidate? Talk to oncology, talk to BMT. But we need to think about, are we doing the right thing? And I'm a huge ECMO supporter, but we need to make sure, since we're putting sicker and sicker patients on ECMO, and sicker patients are surviving nowadays, are we doing the correct thing? So
hey,
I think
real quick, I know you guys are out of time, but because this is the update course, and there's that 2025 article on minimizing pauses during ECPR. What's the secret there? Because I agree with you. It's right to do this, but it's painful to do this. So talk to me about that.
I mean, you've seen in our center, right? the CPR coaches are key, right? Showing your outcome through your cardiac output and tidal coaching, right? Your voice, we always have it I don't know if you've seen it in the PICU. The team is constantly circulating through that patient, changing compressors, showing live versions. I don't know who has these monitors in your institution or not, but you can see the end tidal, you can see the oxygenation, you can see the cardiac index from those compressions. I think that's key, minimizing pauses. The earlier you can get to ROS, the better. If you cannot, the earlier you jump on ECMO has the best outcomes.
So I have a question for you guys. I've asked this before to you guys who do more. I've only done one, and it was a nightmare because I couldn't see the anatomy as well because there was no pulsating vessels. Is there a way to teach this technique so you're not doing it for the first time on a CPR patient? Has someone come up with a way of teaching in a non-pulsatile patient identifying the anatomy in a systematic way?
There's a lot of simulation going on throughout the nation. In our center, we do with Manikis, like literally dissection, cannulation, the entire code runs. Nothing like the live version, of course. I think having people scrubbing with you at the moment is nothing like that, right? Mm-hmm. Knowing your anatomy is key, of course. If you've done it in a semi-elective ECMO situations, is better because you can know your anatomy and your landmarks and the way you should dissect down. The younger the patient, the easier it is to get into these vessels, right? 2 attendings is key for ECPR. We do that in our center. We think is better, at least for our institution, ECPR, 2 attendings run. I think that provides the outcome. And you know, when in these situations, it's chaos, right? And everybody is like running around and people are pushing you from behind. You need to pause compressions to see, you need to pause compressions to cannulate, to make your arterial venotomy. So it's tricky. However, if 50% are gonna make with 30% good neurologic outcome.
Yeah. I'd say we can learn from the adults. Again, different disease processes, but people are putting adults on PERC, bilateral groins, straight to cath lab. We don't need to go to cath lab, but the PERC approach, I think, keeps you away from the chest and can be faster in the right hands. Mira?
No, I was just going to add on to Juan's point about the 2 attending. I think the other part of the 2 attending, sometimes you get a scrub who hasn't, done an ECPR case before, and so that second attending can check the circuit, make sure you have the right cannulas, to help the scrub know what they're supposed to need, all of those things, in order that the person who's actually doing the cannulation doesn't have to be paying attention to that stuff. And I think that helps a lot.
Excellent point.
Well, thank you so much. This was a great session. All right, we're going to play the intro. And you can hand that off to them and you'll do this. So let's bring up the oncologists.
I think you're first. Okay, we are going to do updates in oncology. So we have a couple of talks from Dr. Gonzalez and Dr. Aldrink focused on a couple key aspects to think about in oncology and how we continue to move forward with the care of kids with cancer. So Dr. Gonzalez.
Well, thank you very much. I'm Gloria Gonzalez from Cleveland Clinic. So we're going to talk about fluorescence-guided surgery. And here is our clinical scenario. This is a male, 17 years old, history of a desmoplastic small round cell tumor. So he was treated with chemotherapy, good response in images, and needs surgery. And these are the first images. This is pre-treatment. You see a really big burden of disease, all over the peritoneum, and usually the pelvic masses, and of course, all around the liver and peritoneum. And this is after chemotherapy, so he responded really well. Adjuvant chemotherapy. So right now we only have a really small piece in the pelvis and one close to the liver. In a PET CT, a really good response, just one spot that is avid in PET CT. But what we do with these patients, we know these patients are sometimes really bad. So first question, could you use any localization technique in these patients? And can we do the poll?
Yeah, what do you guys do in the room? Do people use localization techniques for a case like this?
Any, ICG, nothing, needle localization. Do you do a laparoscopic resection, technetium 99? Other that you can tell me? Is there anything? And we're seeing this, and ICG is one of the main things, and many people do nothing. I mean, they said there's nothing that we can do. So what I'm gonna talk to you about, it is two topics, non-targeted fluorescence and targeted. And we know about ICG a lot. You know, there are many publications about oncology and ICG. ICG is a fluorescent element that we can see during the surgery. So if we're looking at like a laparoscopic, normal laparoscopic, we're not gonna see anything, just pinky stuff, yellow stuff, that's it. Normal colors. But if we put the nears, we're gonna see some things in green. Okay, so in oncology, we have been using this a lot, and there are many publications about many of the diseases that respond really well to ICG. But many of those are liver tumors, because ICG is excreted through the liver, so the liver tumor cells doesn't excrete the ICG really well. And what is targeted fluorescence? Do we know anything about this? Well, this is what we're using, targeted fluorescence. And I'm going to talk about papholasicine. This is Cytolux, but there are many elements in targeted fluorescence guidance surgery right now. Most of them comes from adults, of course, and they have been using this targeted ICG. This means is like a monocolor antibody, and you mix or bind this fluorescence element to that antibody, and we use it in the patients. So, for example, Cytolux, we're going to say something different. The tumor cells are really, they're replicating, so they have really high or rapidly dividing cancer cells, so consume folate all the time. They're avid for folate. So if you mix folate with fluorescence, we're going to see it green during the surgery. This is a FDA-approved molecule that is used in cancer cells in adults. But what happened in pediatrics? Right now, we're starting. Do you want to see? Do you want to know anything? Okay, and this is another thing that we are using, and it's iris. Have you used this for anything? Iris? Carlos, tell us about it.
Well, we use it for funduplication, but it's an amazing system. We've used it for funduplication. It's an amazing system. It makes things very, very easy to identify by MIS.
So this is a fluorescence guide that you can place in any tube, kind of. So this is your, can you show the picture? This is a urethral one, but you can use it to use like ERCP, colorectal surgery, yes, esophageal diseases and everything, but we are using it in here for urethral. And this is Cytolux in action, okay? So this is a targeted ICG, is binding a molecule, a specific molecule with ICG. So in here we have a patient that we are doing this, exactly this patient, desmoplastic small round cell tumor with Cytolux guidance and the iris placed in the urethra. So we can see 2 or 3 different images in here. The normal one, and all the tumors are highlighting. And of course, I would love to do it robotically. In this one, I'm doing it laparoscopic, and I struggle, it's true. So, yes. I was really, come on, please. I have to do robotic. Next year, I will do it. But this time we did it laparoscopic, and you can see all the cells that they're highlighting. But this is off-level. This is FDA approved in adults, okay? So this is the normal view, just pink. So if we have only one spot, for example, a 2 centimeters nodule in the pelvis, and you use Silox, for example, or in neuroblastoma we are using this
Dinutuximab.
Thank you very much. That is an antibody, like a monoclonal antibody that we're using in neuroblastoma right now. Mixed with fluorescence dye, we're going to see the neuroblastoma during the surgery. So it's great. This is the future for us.
Gloria?
Yes.
So Tim Louds from Lowry, Chicago, I think, well, he's one of the authors there. I think he won the best poster presentation in SIBE last year for calculating the concentration of these specific receptors for Cytolux, and they were actually higher in the pediatric tumors he chose to test than in the adult population. So I know this is still not FDA approved, but I'm guessing it's coming, isn't it?
Yes, so it is coming. And in here, again, can you show it? There are 2 ongoing studies to see, to try to see the safety in pediatric patients. And we have been using it like off-label in Cleveland Clinic in patients with the dysplastic small round cell tumor specifically. But these are 2 studies. Larry in Lutz is doing this one in Lowry Children's Hospital to know if these Silox helps for metastatic patients. And in the Mayo Clinic, they're trying to see all the solid tumors, because we know pediatric solid tumors are really high in folate receptors. So we are going to have, I think this is a really breakthrough story, and we are using it right now. And we know the limitations about ICG, because many people, and you see that answer ICG of one of the options, well, the sarcomas don't highlight with ICG, and that's a problem. So this is new, and I wanted to show it to you.
How widespread is Cytolux for people to use?
Because it's not FDA approval, will not be easy to go and ask for it. Okay. But it will be, because right now it has been used for ovarian tumors in adults, women of course, and lung tumors too. So it is available. What we need now is the FDA.
Dr. Gelfand. You need a microphone.
It's not that cheap, basically. You need to buy a lot of vials to use it. That's the other problem in using. Although it's off-label, you can get it. The thing is, it's expensive so far, and there's basically more to come in the next 2 years. Target non-ICG fluorescences that are building up the different labs within USA and the world to use near infrared spectrum to focus on that thing. So it's a coming thing that is basically building up the next 2 years.
Yeah. And actually right now in neuroblastoma, they're trying the molecule that we took before, and they're trying to build another thing that is a little more precise than NIRS, is PIRS, is a different one and allows us to see deeper in the tissue. Because right now the problem is we just see superficial. Like a 1 centimeter superficial with the NIRS. The other one will be deepest. So this is new, and thank you very much.
Thank you, Dr. Gonzalez. We're going to turn it over. Dr. Aldrich is going to talk a little bit about the newest COG renal tumor trial. A lot of us have patients who have renal tumors or have Wilms, and really understanding the way in which this trial impacts the care that we provide and how we need to think about things differently than we've done for the last 10 years. So she's going to walk us through some of that.
And what I'm going to talk about, and I'm a member of the COG Renal Tumor Committee, so I am using the branded slides for COG just because this is being broadcast. But what I'm going to talk about is essentially like 10% or less of the entire clinical trial. So for those of you who have this study open at your institution, it is really complicated, favorable histology Wilms tumor of all stages. And so I'm just going to walk through one of the important kind of surgical points and kind of see what people would do. So here's your clinical scenario. You have a 3-year-old male who presents with an abdominal mass that was appreciated by a caregiver. No past medical history of any concern, no concerning family history. So specifically, no predisposition or anything that you would worry about. Okay, so These are your labs and your vital signs. Here is your imaging, right renal mass. They did a Doppler, okay, and then this is your scan. So what would people do next? And I realize this is an international audience, so this is certainly going to be a little biased.
Yes. Recognizing that there's a PSYOP strategy that would be totally different.
So just here are some, this doesn't mean every answer is wrong, but the correct answer, the answer I'm going to say is correct, is in accordance with the clinical trial. So place a central venous line for neoadjuvant chemotherapy, proceed with a right nephrectomy with central line placement, proceed with a right nephrectomy with nodal sampling, or all three.
What would you guys
What would
do?
people do in here?
Was there tumor thrombus?
No tumor thrombus.
Anyone?
Well, 3. That's a great question.
So nephrectomy, nodal sampling, and nephrectomy, nodal sampling, and central line placement. I think in Chile we do umbrella, but I think one of the favorable things of COG is that there's a little window of opportunity of not giving chemo postoperatively, and that happens only if you're under the age of 2 and other conditions. So I think this guy would go with the central line, or am I already wrong?
No, you're already wrong, but I thank you for bringing up that
set
point.
Her up,
Yes.
Thanks, Jose.
Yeah, you've read the prior studies, and that's exactly right. It was an age cutoff of 2 or under age 2. It was a size criteria of under 550 grams. However, currently, what we would recommend is right nephrectomy with nodal sampling only, and then await for pathology. Okay. So just to step back for a second, for those of you who have enrolled on renal tumor studies in the past, so there was this overarching biology study called O3B2 that allowed for banking and central review. That is closed, and that has been replaced by the renal PEC. So this is sort of your enrollment study. Any patient that has a renal mass, regardless of whether you have pathology or not, you can start entering this patient in this study or approaching them for study. And there's rapid central review for risk assessment. Okay, one of the key points for the renal PEC or the biology study is, again, as soon as the mass is identified, you don't have to wait for surgery or pathology, just start entering them. The other key point for 2231 is you absolutely have to get lymph nodes. Does anybody know a magic number? How many lymph nodes would you get, and from where? 10. How many?
7 or 10, depending on the...
Okay, anyone else? And from where?
Mike, get a mic in your hand.
So it's 7 or 10. That's around that. I think it's 10 for COG and 7 for PSYOP. And from where I think it's important, and I don't think it's been established in the previous trials, because it's really easy to get some mesenteric lymph nodes and just get your count up. But I think it's getting more and more relevant where you take them from. And I've seen some diagrams in JPS in which they say, so intercavo aortic nodes are important, above the helium, below the helium, and in some cases even going through the other side. But I'm guessing you're gonna...
That exact diagram, I thought I had it in the next slide, but I think it's a little bit later. So there's not a confirmed, this is the magic number. It's probably somewhere around 5 to 7. We only require 1. Okay, and it's hard enough to get surgeons to get 1 lymph node. So you have to have a lymph node to get on the study. Probably the ideal, from what we've gathered from retrospective studies, is between 5 and 7, as you mentioned, but that's one of the secondary aims of the study. So, and then location is important, and when I put the diagram out, I'll come back to your comment on that. Thanks. So there's a new group, and again, this is just 10% of this entire protocol, called the Modified Very Low Risk, or it's newly expanded and refined based on data we learned from prior COG studies and PSYOP studies. So stage 1 patients less than 4, so the age has been expanded, and I'll show you some data in the next slide to show where that came from. Regardless of any tumor size, which has also been shown to not impact event-free and overall survival, without any negative biomarker or prognostic biomarker, which are listed here. So loss of heterozygosity 1p16q, 1q gain, or LOH 11p15. And then the other component is an epithelial predominant Wilms tumor. So those patients can be classified as a modified very low risk group. And the aim of this study is to demonstrate that this group of patients can be treated effectively with nephrectomy only and can avoid chemotherapy. Again, they have to have a unilateral renal tumor, so no predisposition syndrome or solitary kidney. Upfront total nephrectomy, which I know is not the routine in all PSYOP institutions or umbrella institutions, but upfront total nephrectomy without spill, partial nephrectomies are not eligible. And so if there's a question and it may be an older kid, is this a Wilms tumor, a renal cell, it might be worth a discussion of what procedure you choose. And then lymph node sampling with appropriate drainage. Here is that graphic that I mentioned. This is in the COG protocol, but as he mentioned nicely, you want to basically get for right-sided tumors, hilar, paracaval, and aortocaval region. That doesn't include periportal, that doesn't include iliac nodes, and it certainly doesn't include mesenteric lymph nodes. So we see a lot of those just to count. And you should, and then the left side, kind of the opposite. You want to document where you harvest. Yeah.
Have you found ICG helpful? We've been trying to see just for, okay, go ahead.
No, go ahead. Make your comment.
Just wondering if it seems to point you in the right direction. I don't know if it's really shown increased yield, just maybe makes it more efficient and faster.
There have been a couple small studies going off of Gloria's excellent talk. So ICG for renal tumors has been used for two purposes. Number one, to help identify lymph nodes or sentinel lymph node mapping or nodal harvest. And then number two, to help, if you're planning a partial nephrectomy, maybe a pre-treated tumor, you can inject ICG, and it actually is inverse. And so the kidney will light up and the tumor will not light up, and so that can help show you margins. Is it really helpful for nodal harvesting? Has anyone found it to be helpful for nodal harvesting in here, using ICG?
Yeah, I have used ICG for lymph node sampling. It's not easy. You have to puncture the kidney hilum, and usually it's not that easy. So what happened to me, exactly, yeah, of course, because you change and everything. So it happens to me that the ICG I place, it kind of defunded around the kidney and not in the kidney. So I saw everything green. Yeah. And there are many people that it happens the same to many people. So yeah, there should be another way.
Yeah.
But it's in the right direction,
right.
I think.
I agree. The times so you have to inject in the kind of perihilar region, and then it just oozes out, and so all you see is green. So I haven't found it to be super helpful, and I worry that somebody might inject the tumor, and then you've got a spill. So.
But with an open nephrectomy, I don't find it difficult to get 5 nodes. Why would you need ICG? I think the role for ICG is more for laparoscopic cases, which are probably, you're talking about laparoscopic, which is usually have a low lymph node sampling, but I don't think this is the setting for laparoscopy, is it? Right. Okay.
Yeah, I mean, would anyone do laparoscopic? Why not? I mean,
if incidentally found really early, why not?
There's no reason you can't. If you can do the same operation without spill and you harvest lymph nodes, then sure, or robotically. The other
did one this week robotically. So
the other point to make with regards to this one little section of the trial is central venous access, and so we've all been trained. You have a renal tumor, they're going to need chemotherapy. Well, there's a bigger subset of patients, probably about 15 to 20% more patients who may be able to avoid chemotherapy. And so you have to really be thoughtful about the target or the timing of central venous access. And so for a patient who's under age 4, that you don't see any obvious rupture, that you haven't spilled the tumor, that there's no stage 4 disease, you would probably consider delaying placement of central line. You can use, if you have a suspicious lymph node, you can use intraoperative frozen section to confirm that, and then guide your decision to place a line at the time of surgery and avoid a subsequent anesthetic. Or you could combine central line placement if the patient was a candidate for oncofertility with that procedure. So again, biomarkers will be routinely tested for these patients. They cannot have any negative biomarkers because those have been shown to increase the risk of recurrence. I thought I had a data slide, but maybe not. This is our current renal tumor roster, just to give credit where credit's due. So thank you.
Thanks so
If you
much.
have any questions, let us know.
Thanks, everybody.
All right. This was awesome. I think, James, you said you need 2 minutes, right? We're going to take 2 minutes. We're just trying some things here. I'm always pushing the envelope. I'm pushing James to get better tech here to try things. James, it's okay. We could just leave it. Okay. All right. Tell me when you're ready. When you're ready? Okay. What?
Heather, let's do it.
We have. Is that different? Your schedule is different.
That's online.
Yeah, we have the AI tools one now.
So there's a discrepancy in the schedule. Is there? Sorry, there's a discrepancy here.
They can do it if they want it.
You
want to do that one? You want to do whatever body?
Yeah. No, we'll do AI. It's already in the deck. So, all right. Sorry about that. We're gonna swap if that's okay with you guys. Is that all right? The deck was already. Sorry. All right. Where's James? Is he there? All right. So there is a talk I give about how I think clinicians should look at diversification of career and have side things they do to keep them engaged. This is one of my side excitements, and we have incredible people here. So this is what Em and I do every day with a lot of other people in the room, trying to figure out how we can push the limits with this. James, who is leading the video and audio here, is also a physician. He's still practicing, and he has a side hustle. So it's a fun thing to do. It keeps you alive. So with that, these are 2 other people that do side things. So Em and Carlos. And actually, before I asked Em, they do this every year. This one is more focused on everyday AI stuff that is not necessarily related to patient care. Things that we think everyone needs to know about if you're somewhat close to being current.
Okay, so Carlos starting. We have a bunch of videos in the presentations, but with Todd's request, we'll do some workshops over the next year. So some of them are just going to be like glimpses of what you might see in the future.
Yeah, and to explain that, so we will start giving workshops in depth on each of these things. We've done one. We're going to do one at Steve's Vail course. We're going to do them throughout the year because there's been enough requests. So we're going to give just high level here. If you want more info, contact us and we can show you more.
Perfect. So let's start with the tools that will make your life easier. So we already know open evidence, but
I have a question. How many people here use open evidence?
How many know about it?
Okay, so we had like 4 or 5 hands recent. How many people here have used open evidence with their advanced capabilities that only people in the US have access to? Miguel? Hoka? Okay, so let's talk about it. So we know that open evidence has had lots of partnerships with NEGM, JM, with JAMA, etc. So it's been becoming a tool that has partnerships that validate using it as a medical provider, as a medical practitioner. Next, please. So now it can give you CME. Now you can use it for studying. Now you can use it to further validate what you're working on in a more yeah.
All right, I'm going to cut you off. Hold on. Who here, only like 2 people knew what open evidence was. So let's back up a little bit and explain to people. This is one of the most important sites that has come out in the last year. You 100% have to know this. This is not a maybe. This is probably the most important site as physicians we need to have. The guy who came out with this became a multi-billionaire in about 2 months. It is absolutely critical. Can you explain
Yes,
what
of course.
it is?
So open evidence is a large language model, which we already know, and we've been hearing so much about them. Cloud ChatGPT, Llama, etc. But the thing that we have to know about large language models is that they're really big, fancy, very well-funded text completers. So they depend on what text you train them on. Open Evidence has been making sure that they've been training these models with medical text. These partnerships that they've been creating ensures to us that the text that they're checking out is medical text. So that's why in recent papers that they've been publishing, they give better answers against other open LLMs. Any questions about Open Evidence up until now?
Ask Mike.
They give you also where they're coming the information from.
Yes.
At the
Yeah,
same time.
it doesn't hallucinate like any other large language models out there. It gives you more than resources. If you bring up a case scenario, which is the part of the HIPAA compliant, if you get registered by your business administrator from your hospital, you can even put your actual patient information and ask for a case solution and diagnosis and management options.
7 minutes.
Perfect. So what's new? Now, since it's HIPAA compliant, it's been enabled only in the US to receive attachments from your guidelines. So now you can upload the guidelines from your hospital and it'll use actual up-to-date information comparing your guidelines to what's happening up-to-dately. So it's really, really useful. It cites how it's comparing your information against actual information, but always with a little asterisk, because it still sometimes hallucinates. But we'll always have to check what it's producing. So here's a little example of the attachments. Here's a little example also of what's called a deep consult. Normally, you ask a question, it gives you a quick answer, but here it's just using something called reasoning, where we could say think about the question. It analyzes the papers that better respond to your inquiry. And you can see here in this video that it not only citing the papers, but it's citing important graphics, important tables, etc. And at the end, it gives you the actual papers that you can check out.
What kind of a question did you ask to get that result?
The question was, what kind of question was asked to get that result?
You can see it actually.
The question was, in children with uncomplicated appendicitis, how does primary non-operative, oh my God, this again. Non-operative management with antibiotics compare the appendectomy to add 1 year of treatment success?
30%.
So one of the news that was very exciting, this is the first AI in the large language model history that actually scored a perfect 100% on USMLE. And now you can use it even for USMLE study sessions for step 1, step 2, and step 3. You pick the topics and subtopics, and it creates a scenario for you. And then you have your quiz questions, and if you answer correctly, it changes the level. Next time, it's a little more difficult. And if you do wrong, it gives you the explanations, references for you to learn more, and you can connect to third-party apps to make flashcards. And now they have templates to make patient notes that you can either create your own templates that you can use in your hospital, or you can use their existing templates that would aim to decrease the amount of time you spent on doing charts. And the next Todd's most excited part about ChatGPT, we hear a lot about the operator projects, GPT-5, the Codex, agent, research mode, deep thinking. They have a lot of capabilities that you can use in ChatGPT. They keep adding more stuff. And we'll talk about the operator projects, GPT-5, and custom GPTs today. The operator is a human and ChatGPT co-pilot something together. And AI does most of the job, but as a human, you can interacting, jump in anytime to steer and change the direction of the topic going on. And Todd will show us how to do it.
I just said, make me reservations for 2 people between 6 and 7 p.m. near this area at a steak restaurant. And go ahead, see what you can find. So here's what it did. All right, so I typed in my request. I put in my name and email and phone number so it could fill it in. You don't have to do that. And then it searched on Open Table. It found a steak restaurant near me, and then it found the right time. It removed the ads there, and then it started filling in my information. So when it was done, it basically said, here you go, it's done. Do you want me to go ahead and do it or not? And you say yes or no. It's amazing. Go ahead.
So the next one is the projects. Do you want to explain this a little bit more, Todd? The projects part?
Yeah, you can do it. Oh, this is just, projects is the idea that you can put, who uses projects? All right, so it's classifying, you create a smart person in your team, so you have a whole team of people that help you. So I have a bunch of different people on my team, and all the stuff related to that I've uploaded all the stuff I need them to know, I go to that person for a specific request. So I have my team, this kind of shows it, right? Or is this not a video?
Did you know that you could literally build an entire staff that works for you in ChatGPT? So all you do is go into ChatGPT and go to projects on the left tab and just make a bunch of projects that are, here are mine: social media Sam, executive coach Eddie, financial Frank, I have travel agent, I have my stoic philosopher, I have everything you could, video editor Vicky, I have all the ones, and I just keep adding them to it. And then under each one, you have all the different projects. So if I'm doing social media, I said, you are an absolute ultimate expert in social media. I don't know anything. Here's what I'm doing, blah, 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 and it remembers everything. You can upload documents, and then every time you want to do something different, make a new project underneath that expert, so that staff handles it for you. It's sick, it's insane. Now, I just got ChatGPT Pro to try it for a month. I'll let you know if it's that much different, but go ahead, give it a try, and tell me what you're using it for so I can copy from you. Like, tell me.
So this one, one of Todd's custom GPTs, one of his passion projects.
All right, I believe the best way that we learn in residency is by screwing up. And I want to figure out how we learn better in the future. Now, part of me is wondering, do we still need to learn? Because you're going to get answers when you need them, as we just saw from open evidence. I still think we need to learn certain things and figure out how to do it. I think making mistakes is how we learn best. So we designed this GPT. It's not perfect yet. I'm happy to send it to anyone to test it. It is designed to take you through case scenarios, but not tell you if you make a mistake. If you make a mistake, the consequence occurs. Now your patient is coding, but it doesn't tell you why your patient's coding. Because you forgot to resuscitate a pyloric stenosis and you went straight to the operating room. They're not going to tell you that. It's just going to say, now your patient's in the... So I have it almost for every specialty. We're trying to make it 100 times better with images and video, but it's basically a board review. But it's the best way.
Now in the role of a senior clinician being tested on a scenario involving an advanced stab wound to the abdomen. Remember, this is all for educational purposes, not real medical advice. Now, would you please confirm that you're ready to begin the scenario?
I'm ready.
All right, let's get started. You have a young adult patient brought in with a single stab wound to the abdomen just below the umbilicus. The patient is hemodynamically stable for now, but there are signs of peritoneal irritation. As the examiner, I'm going to ask you, what do you think is happening internally, and what is your initial management plan? What is your next step?
Well, if he's got peritoneal signs, I'm worried about a visceral or bleeding injury, but the first thing I want to do is assess his airway, his breathing, and make sure his vitals are okay, and see if he's still hemodynamically stable, and I'd get 2 large bore IVs in place.
So you decide to focus on the ABCs first, check his vitals, and establish large bore IV access. After doing that, you find that the patient remains stable, but he is starting to have more abdominal tenderness than guarding. What do you think is happening and why, and what do you want to do next?
So it keeps going on like that.
And I keep making mistakes on purpose to try to get it. I keep trying to, oh, I want to do a craniotomy. I mean, you can say whatever you want to try to see, oh, really? You have to say that it's a board, you have to say it's an exam, or ChatGPT will not let you share it. You have to say, unless you do it in a private tenant.
And every time it's a different case.
Oh yeah.
You're not uploading anything. You're just saying, like, I need to study about this, and it has all the knowledge and just creates this once. And I believe it took a lot of time for you to ask it not to hallucinate. And just get over
and then it gives
spot.
you a summary at the end of what you did right and wrong, and it can send it to whoever you want if you use an agent.
It says time's up.
2 more minutes. Go ahead.
Okay, got time. Okay, go ahead.
Okay, so here's an example of something on the same pathway, which is a version of ChatGPT that's called study mode. So it's a little like what Todd has mentioned, where the endpoint is not the answer, which normally you want the answer that you're asking for, but you change the endpoint so that ChatGPT knows that you want it to help you learn. So the endpoint is it explaining to you what you've asked in a digestible manner, step by step, and it adapts to how you answer. So it makes it easier, it explains more, it goes to the next topic that you're learning on. Yeah, vibe coding.
Okay, I just want to mention one more thing with AI coding agents. We are able to make our own apps in our own terms with every capability that we have. It's like when the computers and internet first started, everyone would get a Gmail address and Hotmail address, and they would drop on online messaging to each other. So the idea of vibe coding, there are different websites and different difficulty levels going on, and there's like fully automated ones. You just say like, oh, I want to make an app that plays tic-tac-toe with me all the time, and it's just gonna make it itself. But we're working on some apps or websites. One of them was, Todd said, I wanna make a website that will help me hire interns. And we were able to make this website in 3 minutes with AI. We just said we need an app we need a website that we need to upload some CVs and have some information about interns, and then you can find like a domain name, put it online, and it's there. You don't need any help to build those things anymore.
All right, so this is what I think is probably transformational, maybe a little early, but everyone needs to know about this. This is like the new internet. There's going to be precise customization of apps and solutions for each individual, and everyone can make their own. You don't need massive developers. So we are trying to do this at our organization. We've convinced our leadership that there is a top-down and a bottom-up approach to AI. Yes, we can buy technologies. I want the entire workforce to be enabled to, empowered to, vibe coding means you just type it out. I want an app that does blah, 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 and there's your app. So we think about in a year, or it's still pretty hard, but we think within a year, it'll be democratized. Everyone will be making their own hyper solutions each day.
Adding to what Todd's saying, this thing's so effective that it's making the question, is software as a service dead as a business, being asked. We don't know the answer yet, but the fact that it's so effective that it's making us ask that question should enlighten to how effective this vibe coding is.
And workflow automation, we're going division by division, asking what they do. We believe we can improve the efficiency of the entire hospital and save hundreds of millions of dollars over the next 3 to 4 years by allowing full automation of everyone's workflow. Because if you go division by division, we started with my wife's practice to see we can completely cut down half of the time that they're spending, money they're spending, and we can do it for every single division individually. So that's workflow automation. I'm telling you, these are just touch points. We'll do a whole workshop. You guys must know about it, or someone in your organization must know about it. You have to have people on your team that meet 3 times a week to make sure you're up to date. Is that it?
No.
Okay. And Carlos are going to do a workshop, so we can do more questions, but that was awesome. Thank you. Yeah.
Thank you.
Too bad. All right, thanks. All right, you want to?
It's a break time.
Okay, 5 minutes, or are we over? 5 minutes, okay.
Oh, no.
If you're worrying, know there's someone working relentlessly. If you're struggling, know there's a team on your side, pioneering breakthroughs. If you're questioning, know we are finding better answers. Because in the pursuit of healthiness, we're changing the outcome together. Cincinnati Children's.
Some said Tiago had 1 week to live, but this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds. It's about changing them for all kidkind. Hope, care, cure. Seattle Children's.
Welcome to John R. Oshai Children's Hospital, a place of hope, healing, and miracles. Oshai Children's Hospital is one of only 43 standalone children's hospitals in the nation, and the only one of its kind in New York State. The only one. Why is that so important? Because our whole staff is specifically trained in and devoted to the care and treatment of children from conception to 21 years of age. Because the entire building has been designed with patient and family comfort as a top priority. And most importantly, because the best of the best practice here at Oshai Children's Hospital. As a teaching hospital for the Jacobs School of Medicine and Biomedical Sciences and the University at Buffalo, our physicians are practice and thought leaders, training the next generation of physicians to provide the highest quality of care to our community's children. There are many things that make Children's different from other hospitals, even beginning before arrival. By downloading the My Kaleida app, families can use its GPS navigation to get to the hospital. And upon arriving, it automatically changes to walking directions so that families and visitors have no problem reaching their destination within the building. Parking is plentiful, safe, and close. Whether you choose to self-park in the parking ramp located on the corner of Ellicott and Goodrich, or use our convenient valet service. Walking into the hospital is like Dorothy opening the door to Oz. Bright colors, artwork, playful interiors, and comfortable seating are just a few of the distinctive sights you experience upon entering. The lobby features a gift shop that's any child's dream. A Tim Hortons, which is many a parent's dream, and an entertainment space to host holiday parties, performances, and special meet and greets with local and national celebrities. Each inpatient floor has a playroom where children can put aside their illness or injury and simply experience the joy of just being a kid. There's an outside terrace that allows visitors to get a breath of fresh air, soak in the sun during our beautiful western New York summers, and enjoy a view of the cityscape that's simply spectacular. But at the core of Oshai Children's Hospital is our team of expert clinicians. Their goal is complex, yet singular, to treat and cure sick and injured children. They've devoted their whole lives to that goal, and every single day they give their all to provide healing and make miracles happen. And at the end of the day, that's what John R. Oshai Children's Hospital is all about.
You asked. We delivered. The all-new Stay Current MD app was built with your feedback and your workflow in mind. We've shifted from browsing to search first, so you get the answers you need faster. Search understands typos, synonyms, even clinical shorthand, because at the bedside, there's no time to waste. Whether it's protocols, podcasts, quick videos, or more, everything is at your fingertips. A fully redesigned experience with smarter search, customizable spaces, advanced discussions, direct messaging, cross-institution collaboration, and more control over your profile, notifications, and content sharing, all built to keep you one step ahead. The new Stay Current MD, smarter, faster, built for how you work.
There's nothing more important than our commitment to children. Our roots run deep, and we're always finding new ways to care. For more than a century, across the Mountain West, we've been dedicated to keeping the child first and always. Our team of passionate caregivers are combining forces in new ways to help children live their healthiest lives. It's the power of we. We're better together. Together, we're building something truly special. Together, we get to ensure the best outcomes for all patients. And together, with your involvement and generosity, we are building the nation's model health system for children. So, what does it mean to build a model health system for children? Intermountain Children's Health is the best outcomes for our tiniest patients, the nonprofit health system serving the most expansive pediatric geography in the United States, world-class hospitals, quality pediatric follow-up close to home, more than 1 million patient interactions annually, thousands of nurses specially trained to treat and support kids and the families who love them.
I'm really excited about this session because I think this is what the update course is all about. I don't think I even knew what this was a year ago. And this primarily lives in the orthopedic world, but if you haven't heard of this, you may hear this soon because I think it's becoming more common and pediatric surgeons are being asked to help. Presenting most of it is Lorena Flicari. She's one of the orthopedic surgeons at Akron Children's. They have an exceptional spine program, and it's actually been pretty fun to participate in these, so I'll let her take it over.
All right, well, thank you so much for having me. So we're just gonna briefly review indications, some techniques, and early to midterm outcomes. So here's a clinical scenario. So 9-year-old female with juvenile idiopathic scoliosis, otherwise healthy, active gymnast, initially presented with a moderate-sized scoliosis curve. So at this point, we indicated bracing for her, not to fix the curve, but to hopefully prevent progression. She was non-compliant, so returned 2 years later with a 50+ degree curve, pretty flexible. She's skeletally immature. So what would be the best treatment option for her? So as you can guess from the title of this talk, I am wondering what is an advantage of VBT, vertebral body tethering, over a standard spinal fusion? So,
should we even back it up a little? And who in the audience has even heard of this? Like, are we doing tethering at all of the hospitals? Maybe 50-50?
Yeah, looks like it. Yeah, so at Akron Children's, we have not been a super early adopter, so some of you might have even more experience than we do, so we are eager to discuss this. But I think that it is a technique that is here to stay because of some of these potential theoretic advantages. So should I move on? What's that? Oh, sorry about that. Yeah, so this procedure has a lot of inherent theoretic advantages over fusion. So it is definitely less invasive, it's more physiologic. We are hopeful that disc mobility will improve long-term outcomes in these kids, but it is early, and so I think it's great to be discussing it on the early end here.
Can you tell us where it is?
Yes, so as shown here, it is this tether that you put on the convex side of the spine. And so the intention is to partially correct the curve and then modulate growth. So this goes on the front of the spine. Typically for our spinal fusions, that's posterior approach, but we don't want the spine to fuse. So going anteriorly, you can place these tether devices without actually fusing the spine. So this is like a polyethylene, really flexible band that we're putting on the convex side, and that's why it needs to be a skeletally immature patient so that as they're growing straighter. So the timing, the right patient at the right time is really critical for these cases. If you do it in a mature patient, it's probably not going to work. So these are our current indications. They've been evolving as more data has been coming out. So immature, moderately severe curves, and flexible. We are also doing some hybrid techniques where if the thoracic curve doesn't meet criteria, the lumbar spine is where you need motion, so you can do a hybrid. So positioning. So the tricky thing with a double tether is you have to do lateral decubitus with the convex side up and then flip the patient over to do the lumbar. So Justin, I don't know if you want to comment on anything.
Yeah, so it's actually really helpful and kind of feels unfair that you guys can see everything just under fluoro. I would love that for the structures we operate on, but they kind of mark out the levels ahead of time, and we mostly put the ports on the anterior axillary line and kind of space out 3 5-millimeter ports. And then where they actually put their instrument through is a 15-millimeter port, so it's pretty big, and they have to be pretty much right on top of it. But you can usually get 2 to 3 levels, I would say, through each skin incision and just move the port up the next intercostal space to get them a straight angle. And then you can obviously use the 15-millimeter port as an extra hand too. And I think you have some pictures of, yeah, and we meant to get better pictures the last case we did, but basically like our job is to expose the vertebral bodies, and you use kind of the rib heads as your marker, and you, the hook works really nice. I think do you have a picture of that? Yeah, so the hook works really nice. Some of the larger segmentals you can use the ligature. You're basically just exposing the vertebral bodies for them. And then you can usually get down to T12L1 through the thoracoscopic approach and kind of just bluntly dissect the plane along the diaphragm to get to that level. And then L1 to L4 through an open incision.
Yeah, just one comment. We do typically ligate the segmentals here. I know in the spine world, it's you certainly don't want to do that on both sides of the spine due to risk of a spinal infarct, but we do neuromonitor all of these patients, but I think if you're taking it on one side, it's pretty safe. So some centers are using 3D navigation to place screws. We have some great x-ray techs, and so we're able to do this under just fluoroscopy, which works better in our hands. So we do an opening all, we tap it, we probe it to confirm that we're not in the spinal canal. We place a staple, place a hydroxyapatite screw. And we're doing this under fluoroscopic guidance at each level, and we're trying to go straight across the vertebrae. So it's dependent, the trajectory is really dependent on the curve, body habitus, and such. The lumbar exposure can be really challenging, so we've appreciated our pediatric surgery colleagues with getting us great exposure here and just trying to be really careful around the lumbosacral plexus. We use EMG neuromonitoring. There's a couple of ways to do this. You can kind of bluntly retract the psoas off the vertebral body. You can dilate it up through tubes. Getting down to L4 can be challenging just because the iliac crest can prevent the right trajectory. So some places have a table that will actually split to pull that downwards. We have used a second incision when needed. I don't know if you have any other pearls for the lumbar exposure at your center, or if anybody else has found anything successful, but it can be challenging to get really far distal. And then we place this tether in. We place it, we thread it through each screw, and then we use a tensioning gun to place tension mostly centered around the apex, and that's what we're using to get our correction. Closure, some places are using chest tubes, others are just using drains. Our preference is a chest tube, but certainly I'm going to show a study where there were similar outcomes. but that is one of the number one reasons for a return to surgery would be for some sort of like hemothorax, pneumothorax, et cetera. And then postoperatively, we mobilize them immediately. We return them to sports within 6 weeks, which typical return to sports for a fusion would be 3 to 6 months. So this is a big game changer for the athletes that are really eager to get back right away. And then we just monitor them over time, especially since they're going to be growing and we're hoping to see curve correction moving forward.
Anybody else in the audience, has anyone done some of these? No one? Yeah, Todd.
I was just with Steve Rothenberg last weekend, and he's so excited about this, and he says he's doing a ton now. So my question is, since we're not going to be doing appendectomies anymore, is this the new operation? Do you typically need a pediatric surgeon? That's question one. So really, this is going to be pretty common for all of us. It sounds like this is pretty hot. In the last couple of months, I never heard of it. Now everyone's talking about it. And it only works in kids, right? Because you have to grow. Otherwise, it doesn't. You can't use this in adults. You have to grow. Is that not right?
Yeah, so those are some great points. And there are people out there doing this in adults, and their outcomes are not very good. So I would say that everybody is moving towards only doing this in skeletally immature patients, so kids, right around the time of peak growth velocity. We don't want to do it too soon and then they overcorrect. If we do it too late, nothing's going to happen, and eventually the tether will break and they'll revert back to the shape that they were in previously. So the sweet spot is when we can actually modulate growth and change the shape of the disc space and the shape of the vertebrae as they grow. And so absolutely this is gaining in popularity. It started to be done like mid-2000s at certain centers, and I think a lot of places were very skeptical. And I think it has kind of exploded in recent years. I think that the data is showing that outcomes are improving over time. So I'm of the opinion that this is here to stay, but you just have to be really careful about doing it in the right patient at the right time. So this was one of the first prospective studies. It was just published this year. Prior to this, we were really limited to retrospective reviews that were really pretty flawed. So I think that we're starting to do a better job now that we have this FDA investigational device exemption, that we can study this better prospectively. So this study was actually from Mayo. I trained there, so I was involved in some of these early cases. And they have found that there's been a big learning curve. And so their success rate is really only considered to be 75% at 2 years based on curve size and lack of revisions, down to 63% at 3.8 years with a 20% revision rate. But they have commented that most of the issues occurred early on when they didn't know how to select the right patient. And so I think the more you do of these, the better you get. So I think that's why it is starting to become more popular, because I think centers are really feeling like the data is encouraging that this will provide benefit in the right patient. So to answer your other question about collaboration, there are definitely some orthopedic surgeons doing this by themselves who may feel comfortable with a thoracoscopic approach. We're of the opinion that you guys are the experts in this, you've been trained in this, and so we love the collaboration. We love learning from each other, learning how to take care of patients, using each other's expertise in different areas to work together. And a lot of the publications that are coming out are done jointly now by orthopedics and ped surgery. So I think this is a really ripe area for some great collaboration. So these are just a little sampling. So there was the one study looking at drain options with no difference in complications between chest tubes and bulb suction drains. Another study looking at postoperative tranexamic acid to reduce drainage and retention time, which is what we typically use intra-op. And then another study just really suggesting that this multidisciplinary collaborative approach can improve outcomes. So we definitely believe that and are excited by this collaboration.
So I work with my orthopedic colleague. I think he's actually watching in, but I call this, in a very loving way, defense against ortho. because the lung is there, and then the aorta is also like right through there if we go too far with the screws. So, you know, I would agree with you. It's been a super fun collaboration. I got a question. It seems like the chest tube outputs, whatever, drain, chest tube, doesn't matter, but the outputs are super high. Have you guys noticed that? Like, I feel like my chest tubes are putting out like, you know, 300 cc's, and you know, when is the decision to pull them? I just pull them high.
Have you thought about controlling bleeding? No, I'm just kidding.
Defense against Russell.
It tends to be high for the first like 6 to 8 hours.
Yeah.
And it seems like it.
I feel like it's just a
lower.
lot of serous, like from opening that pleura.
Yeah, it's a big surface area that you're exposing. But
So I've struggled with that it feels like it's high chest tube output. And then I have had one of these segmentals bleed, and the patient came back, like went home and came back a week later with a pseudoaneurysm.
Oh.
And I do the hook also.
Yeah, the hook works really nice for the
Yeah.
pleura, and then just the larger vessels, I think, like a ligature works well. I think the other thing, you know, if you've done anterior exposure for the lumbar part before, a lot of times there's a really severe scoliosis, and you can, you know, almost feel the spine. These are quite a bit deeper, and they're younger kids, so there's not a lot of space between the lower ribs and the iliac crest. So sometimes removing one of those floating ribs we found is helpful
On
too.
the lumbars, yeah.
Yeah, to give you a little bit more space.
Katie, what are the RVUs for pediatric surgeons?
I don't actually know. Do you know?
Yeah, you can do it as like a co-surgeon case. We've done that to Bill.
And that's another question. So Mike Nance taught me how to do it. He comes in, does the exposure, and leaves. I stay for the whole case.
Yeah, we stay for the whole time. I think it's helpful, especially when they're doing the instrumentation to retract the lung, and especially when they use their instrument, you lose all the insufflation because it just that 15 port just opens up unless you're using like a higher flow system or something.
Do you use double lumen tubes?
Yeah, we use double lumen tubes. Yeah, but just providing that retraction, and for the lumbar part, reflecting the psoas, giving them space, like it's kind of a team effort to get that exposure. All right, thank you.
Another question. What about anterior exposures? Do you anterior lumbar cases? Like with a cage?
Yes, you should. All right. Intro. We don't have Jill on here. All right. So this is one of the long-standing sessions we do where we, for those of you who follow some of the content, I don't really know exactly how the magic happens, but the best articles are chosen, quote unquote. We can debate how that happens, but the editorial boards usually send us what they think are the most important papers. We also have Jose helping us from non-pediatric surgery journals, but this is just JPS. So Alex Halpern and Jill Napreth. Do I say your name right?
No.
No, say it right.
It's Knaprath.
You do pronounce the K. Yeah. Okay. So both of them are doing their research. They're general surgery residents, so please take note. These are some badass pediatric surgeons to be, and they're going to go over the top JPS articles from the last year.
All right, awesome, thank you. We'll start with the first one. So we have a 4-year-old girl who undergoes laparoscopic gastrostomy tube placement. The case is completed at noon. Postoperatively, the patient is tolerating tube feeds, and the family has received tube feed education either pre-op or immediately post-op. So what is your preferred discharge plan? So overnight observation, same-day discharge, or a planned 48-hour stay?
Call it out in the audience. What would you guys do? Same day, same day.
Who says same day?
Raise your hand, same days. Any overnights?
Is she receiving steroids?
No steroids. So we got a split here. Any 48 hours? Liars. Okay. All right.
So we're going to go to a video, and then we'll talk a little bit more after that. They identified 5,947 pediatric patients who underwent elective laparoscopic gastrostomy tube placement. 4.7% of these patients were discharged the same day, and same-day discharge rates nearly tripled during the study period. There were not significant differences in any complications between the patients discharged the same day and those discharged 1 to 2 days postoperatively. So it seems like same-day discharge for pediatric patients after elective laparoscopic gastrostomy tube placement is safe and gaining popularity. So this was a NSQIP study from 2017 to NSQIP pediatric study from 2017 to 2021, and they found 6.2% of patients were discharged the same day at the highest year. And so it was a very low rate, much lower than what's reported here. Does this change your answer at all about whether these kids can go home the same day?
Would anyone who said overnight, right now, Steve, I saw you raise your hand, would you change right now to same day? I switched.
Unfortunately, it's not my decision. It's a pathway we follow. We'd have to restructure our pathway. It's our pathway, Steve. Yeah, so.
Okay, so we're having debate about can you change the pathway, but yeah. Mehul, here comes a mic. Wait, oh, here. We have a second.
One of the biggest challenges we ran into when we were trying to do same-day discharge for these is working with our home device delivery companies to make sure that these folks had a pump. And that actually was a bigger bottleneck that we still struggle with. So really, the scenario works best when these folks have an NG tube coming in and they already have their feeding pump set up. And really, the only thing that needs to happen is the G-tube education and care, which our nurses do. So once we coordinated that, then we were able to actually increase the proportion that we could send home the same day.
Another bottleneck that we ran into was the same-day surgery nurses didn't want to increase the tube feeds. You know, that was something they hadn't done before, and it was a big barrier to try to teach them all how to do it. So we started putting them on the floor, you know, but just for an observation status, and then they go home the same day.
Do they charge for that hospital semi-day? Do they charge your patient for half a day in the hospital?
They probably do.
I need to improve my understanding of all billing and financial related things.
Now, I would have thought that a big bottleneck, like at least from my perspective, is they're so heterogeneous when they come to us about what they're doing for a feeding regimen that it's not clear what they're going to do post-op, and then just like, what's it going to be? And I really don't want to be in the business of deciding feeding regimens. I need that crystal clear up front.
All right, so I just want to make sure, those who raise their hand, do it again, don't be embarrassed. Raise your hand if you do not do same-day discharge. Raise your hand. Of this group, keep your hand up if it's a fear of medical safety of the patient. 0. All right, so medically, we're all fine with it. So we basically just decided we are keeping all these patients in the hospital for logistics. That is something we could solve, right? Get the pump ahead of time. Figure it out ahead of time, plan ahead of time. This is a simple thing, one day. The number we put in across the world, this is actually a big deal. So I think that's a provocative paper.
All right, we got another clinical scenario here. This time it's a 12-year-old female. She has a stab wound to her right lower quadrant. Okay. 12-year-old female, stab wound to the right lower quadrant. She is hemodynamically stable. On secondary survey, there's no other injuries, but the right lower quadrant injury does clearly violate the fascia. So the decision is made to take her to the OR. Our question is, what is your operative plan? Do you start laparoscopically? Do you go straight to laparotomy? Or are you going to stick with a local wound exploration?
All right.
Hemodynamically stable.
Let's show the pulse. Yeah. What's that? Wait, Mike. Here.
All right, hemodynamically normal patient that, single stab wound, Why not a CT scan?
What do you want to see?
Any injury?
No, what would you
free
see?
air, violation, signs of violation of the fascia that will require me to put a scope.
Okay, so hold on. So fascia size. What was the other thing you said?
Free air.
What if there's no free air? Free air, that's a gimme. I'm not going to give you that.
Sure.
That's too, yeah. Okay, no free air. What do you do?
No free air observation.
Okay, fair enough. So, and there's been plenty of studies to show that morbidity does not change if you...
It does not change if you admit them for 24 hours.
Okay. What if it's a stab wound and you see it going into the liver? Then you would maybe not operate, right? Right? Because it's a solid organ.
A solid organ, stab
Right.
wound. You
Okay.
don't have
That's
to.
what I was wondering, what you're looking for, because free air is not a good answer, because not seeing free air doesn't tell you, unless you're going to OBS. Okay. Fair enough.
All right. We got a video here of
This
this
retrospective article. cohort study was done by the American College of Surgeons Trauma Quality Improvement Program on about 1,900 patients. Results showed that laparoscopy was done in 12% of cases, mainly for stab wounds and at pediatric trauma centers, with no increase in complications compared to open surgery. Patients who had laparoscopies had shorter hospital stays and fewer follow-up procedures. Many surgeons hesitate to use laparoscopy for penetrating trauma due to fear of missing injuries, but this study found a low occurrence in missed injuries after laparoscopic exploration.
Yep. What? Mike?
No, this being retrospective, there could be a bias towards the patients that had a lesser probability of a serious injury getting laparoscopy. So I wouldn't be sure about that. I'm still worried about missing injuries. So I would be worried if I do a laparoscopy, I didn't find anything. Is it I didn't find anything because of my lack of laparoscopic skills or because of the lack of injury?
Yeah, the injury severity score was lower for the patients who underwent laparoscopic surgery.
Okay. Keep going. This is phenomenal.
All right, we got another clinical scenario. So now we have a healthy 2-month-old baby boy presents with a perianal abscess, first time without obvious fistula. He is afebrile, he's feeding well, and he has no systemic signs of illness. So what is your preferred treatment for this patient? Are you going to observe antibiotics and local wound care? Are you going to do antibiotics, local wound care, and then also an aspiration of the abscess? Or do you want to take him to the OR for an incision and drainage?
Thoughts? Antibiotics. We hear antibiotics.
Decreases the risk of forming a fistula in anus.
He's opposed to using a mic, so I will say it causes decreased...
Decreases the risk of forming a fistula in ano, and I think it was a 2008 article by Masiakos et al.
Okay. All right, play the video.
And the poll was
Oh
pretty
yeah,
much,
the poll. What did they say?
It was pretty much split between all four.
It's a rainbow.
Yeah.
Yeah, we love seeing rainbows.
Yeah, very sweet.
Yeah.
This retrospective cohort study looked at children less than 12 months old who underwent their first episode of perianal abscess at 2 pediatric surgery centers in the UK from 2012 to 2022. 43 patients were managed surgically with general anesthesia, incision, and drainage, with some needing fistula treatment as well. 73 patients were managed non-surgically with antibiotics, bedside aspiration, and bedside drainage. They found that the non-operatively managed group of patients had a higher risk of abscess recurrence and needing subsequent surgery, but they did avoid general anesthesia. This study showed the superiority of surgical management for perianal abscess in infants, but physicians should weigh the risks of surgery and anesthesia against the risk of recurrence.
Yeah, I'm going to say, no, it didn't show that, okay? Because recurrent abscess in this situation is just like a matter of degrees. You know, how many times have you gone to the operating room for a pimple? People get pimples, right? But they don't get operative management of their pimple. So when this kid has a little recurrent, tiny little red bump in there, and I say, first of all, look at your baby, and your baby's like goo goo gaga, like not freaking out, and just like, don't poke it, leave that baby alone. That baby's fine, and that's the point. These things will go away.
All right, we got a lot of comments on fistula in
Okay, we wrote a very large paper on draining abscesses, and we didn't make a big cut. We made 2 very small holes, flushed the abscess out, put a vessel loop in, and sent the kids home. Our recurrence rate was like 1 or 2%, and the referring doctors can cut the vessel loop out and slide it out after a week. And it worked great, and we didn't get fistulas in doing that. There's no packing. All that went away, and it works great. I don't know if other people are doing that or have done it. It's a large paper in JPS.
The AAP definitely recommends against incision and drainage, to Nelson's point, but I also think they recommend against antibiotics if possible. So we should be probably not even doing antibiotics. Warm soaks, let it come to a head and drain.
Slow down. I didn't understand what you just said. Say it again.
We probably should be avoiding antibiotics as well. Maybe just warm soaks, let it come to a head and drain, or it'll go away on its own.
Okay. Would anyone treat with just like, see you, go home, no antibiotics, nothing, just warm soaks? 4, okay. We'll see next year if we...
That's what the study that I referenced was all about. And the point was, if you could cool it off with antibiotics, they showed that fewer of them formed the recurrent problem, and then you nip it in the bud and don't have potentially 9 months or 14 months of parental anxiety and freaking out, calling the pediatrician, running in for reassurance. Because before that study, we put out that if you don't operate on the fistulas, eventually they go away. And about, in the high 90% of them do, but maybe that's avoidable. That was the whole point of the 2008 study.
All right, we're going to move on. I just want to make one call out here. These are not my fellows. So Jill is at University Hospitals of Cleveland. Alex is at George Washington at Children's National. Carlos has done these. Lizzie's in St. Louis. So it's a plea to the world to help us. We need help making these videos. They're 1-minute TikToks that get thousands and thousands of views. So they're good for your residents to get some exposure here. So,
All right, we have one last one. Newborn male is diagnosed with an imperforate anus. He is otherwise stable and is passing meconium via perineal fistula. What screening studies should this patient undergo? So we have Vactral plus a pelvic ultrasound, and plus a pelvic ultrasound and a spinal ultrasound.
Thoughts? What's that?
So it seems like most people are doing answer C, so both a pelvic and spinal ultrasound.
Is anyone here not doing pelvic and spinal ultrasound? Everyone's doing them? Steve, were you going to say something? Okay. All right.
The video essentially just says to do a pelvic and spinal ultrasound, so it sounds like everyone's doing it right. So no need to watch me talk about
this database.
I don't know if everyone does spinal and pelvic ultrasounds routinely.
Well, what's the V in Vactral? Tell me that.
Dude.
Here. Yeah. So, what's the V in Vactral? It's vertebral, right? So what's the common thing? They get tethered cord, they get, all sorts of things in the spinal dysraphism spectrum. So before it ossifies, while it's cartilaginous, really nice to put an ultrasound probe over it.
Okay. And that was the argument of this paper.
That's everything?
And that is time.
Dude, you finished literally perfect time. So let's hear it up for Alex and Jill. All right, what do we got next? This is our last session. We are gonna, Jose, you're coming up, right? Last session. So the way that works, by the way, if anyone identifies a critical article we should be reviewing, let us know. And would love for you guys to do these videos. Just send them to us or let us know, and you could join our lab. We have a lab meeting every week where anyone's invited, and we need help spreading the word, so. All right.
Okay, so this was all done by Dr. Rodrigo Casals, part of the Chilean Society and part of Journal Hive. He couldn't be here because of visa issues. So go ahead, Rodrigo. Do we have him online or not?
Yes, I think so. I don't know if you can hear me.
We can hear you well and clear. Go ahead.
Okay. Hi, everyone. I'm the last guy to present here, so I'll try to maintain your attention and keep it fast. For starters, I'm Rodrigo Casals, as I was presented from Chile, representing the whole bunch from Journal Hype. And I want to thank the organization for letting me give this keynote remotely. And fortunately, I have the best partner over there. So in case of emergency or whatever, you can just ask Jose and he'll be glad to help. So today we're gonna talk about pediatric cholecystectomy. Despite being a routine procedure, is always full of controversies and opportunities. I don't know if the keynote just appeared over there.
We can
so
see
we're
the
gonna
slides,
talk about
and
this.
I have the thing to move them. So
To
just
pass
let
it
me
on.
know. Okay.
Okay, thank you very much. So as I was telling you, we're gonna dive into the updates in pediatric cholecystectomy. And the first, can you pass it please? The first round is the acute cholecystitis dilemma. This is a very common scenario in our emergency departments. So we're gonna just jump into the first case scenario. It's a 14-year-old girl, otherwise healthy, presenting with the classic symptoms, I'm not gonna detail that, of acute cholecystitis confirmed by ultrasound and labs. And based on your actual practice, I'm emphasizing on that, not the ideal practice, your actual practice. What is the management strategy you typically employ? Admit for a IV antibiotic treatment for, 5-7 days and schedule a delayed cholecystectomy. Perform a laparoscopic cholecystectomy during this index admission. Discharge with oral antibiotics or observing in the hospital for 24-48 hours with IV antibiotics. And if it resolves, just go home and complete oral antibiotics. So put the poll up. I don't know.
Do we have poll results? So the audience is voting B, but we don't have poll results. Oh, there's the poll results. So 51% is doing, half of them are doing B, laparoscopic cholecystectomy during index admission.
Yeah, I'm pretty grateful that you read it for me because I can't see it from here. I'm seeing the TV, so I don't have Superman eyesight.
Okay, so I'll read the polls.
Okay, 50% index admission, right?
Yeah, 50% index admission, and the following one is admit for IV antibiotics and schedule for elective cholecystectomy in 6 weeks. So basically, B early and A late. So no.
Okay, that's the controversy, the usual controversy here. So let's move on and let's see the results about this one. And the data here is quite compelling. There's a paper published in Surgical Endoscopy on 2024. And we look to the outcomes of this. The index cholecystectomy performed during the initial admission dramatically reduces the 30-day readmission rate from 22 to 2 or 3%, and also significantly shortens the length of stay around over 7 days from 22 to 6. So this strongly supports the early surgical intervention for acute cholecystitis in pediatric patients. So the question here is, why are we still delaying it? Are there some specific cases in which we want to delay the surgery or index admission surgery? Please, anyone over there in the audience wants to comment about this?
Reasons to do it late? Anyone? Symptoms over a week or 10 days, maybe too difficult to operate on the elective admission?
Yeah, I suspect it has a lot to do with how a person's practice is structured.
Okay.
Like if you have, it works very well in my institution because we have an acute care surgery program. You know, we're like shark's teeth. Every day there's a new person in ready to do whatever cases need to be done, and you don't count on that case to make your salary. So if you survive by doing that case and you have a full day of office and the next day a full day of elective, when are you gonna do it? So I completely get that. Lots of practice things come into this decision.
You get an OR time.
OR time, okay. So unable to fit it into your normal calendar?
Other times, the OR. You can't get an OR.
You can't get an OR.
Yeah.
Okay. So this is the infographic we did.
Yeah.
Round 2.
Quick comment before that. I think one of the reasons to delay is in the case of gallstone pancreatitis. Now, data supports index operation before discharge, even with gallstone pancreatitis. Do not send these people home and then plan for later. They're going to come back with pancreatitis again.
Great point.
So moving on to round 2, the prophylaxis products. This is a question I believe that many of us have had in the past. And please pass the next one. So the clinical scenario here, you have a 10-year-old boy on the OR table ready for anesthesia and for an elective laparoscopic cholecystectomy for an uncomplicated cholelithiasis. And your intern, fresh from adult surgery rotations, asks you, are you going to give an antibiotic for this case? And you give the look back and say, go to study. So the alternatives here are, please read them for me because I can.
Oh, sorry. A, no prophylaxis as adult guidelines recommends against it. Prophylaxis with an extended spectrum antibiotic to cover all potential pathogens. C, prophylaxis with a narrow spectrum antibiotic like cefazolin. Only only administer antibiotics if signs of infection appear on pre or post-op. Do we have poll results? So, Rodrigo, everyone's saying prophylaxis with a narrow spectrum antibiotic like cefazolin, which is what you and I normally do at the hospital. So we were both surprised to see this study that guidelines actually recommend against it. Anyway.
Yeah. So please put the next slide. And the evidence here from this JAMA article published in 2025, the adult guidelines, like the Infectious Disease Society, recommend against it. They are citing concerns about antimicrobial resistance, but in the real world of our pediatric practice, there's a different story. A multi-center study here, over 2,000 children, found that more than 90% received prophylaxis. So there's clearly two different paths from adult surgery and pediatric surgery in terms of antibiotic prophylaxis. And this study also showed that prophylactic antibiotics were associated with a dramatic 72% reduction of the odds of surgical site infection, and the number needed to treat with prophylaxis to prevent a single SSI was calculated around 35. So this isn't just a marginal benefit, it's a powerful data that justifies the widespread use of prophylaxis in pediatric cholecystectomy. And the other finding, really important finding of this paper was that besides that prophylaxis is clearly beneficial, there's no additional benefit from using extended spectrum compared with the narrow spectrum as cefazolin. So as the poll results were clear, use prophylaxis and narrow spectrum one.
Comments from the audience? What are you guys doing normally?
So we were giving antibiotics. I was giving ANSEF before we got our NISQIP standardized antibiotic prophylaxis results back, and those said we were not compliant with the guidelines. So then we started to switch, and then we saw this paper, and now we've started giving ANSEF again.
Does that represent what happened here in the US mainly or not? Okay, round 3.
Okay, round 3. The ERAS revolution. This is specifically for the pediatric laparoscopic cholecystectomy. We already heard about the ERAS before, so maybe it would be kind of obvious. So let's move on to the clinical scenario. You just already jumped to it. A 7-year-old girl with symptomatic cholelithiasis is a candidate for laparoscopic cholecystectomy. You have programming for an overnight stay, but again, the surgery resident asks why. Why we should do that? So usually you discharge your patients. Put up the audience poll, please.
Yeah, we have the audience poll.
You usually discharge your patients between 4 to 6 hours overnight, 12-hour observation, or this is the perfect out case scenario, just 2 hours, eat, drink, pee, and go home.
Oh, sorry. Do we have poll results? They're already there. Sorry, I was looking at the wrong screen. So, Rodrigo, it's a rainbow, like Todd liked to say.
Yeah.
So, most common
I can see
answer,
that.
I think it's green, is it? Can you scroll over? 30% overnight stay. So, 1/3
Overnight
overnight stay, and the rest is 2/3 different timings. And which one is the D? D is 28%, which is outpatient setting. Let's hear about the article.
Yeah, I thought that after the ERAS presentation, it would be like the whole audience would go for the 4 to 6 hours. But this is a French paper from a French hospital, and they assessed the ERAS protocol for the pediatric laparoscopic cholecystectomy over a 5-year course. And they successfully implemented the protocol in an impressive 90% of the patients. And what they find was that there were no postoperative complications or readmissions during the 30-day observation. And a median long-term follow-up up to 55 months, there were no health issues associated with it. So this is just one of many papers talking about the ERAS protocol, but this proves that the same-day discharge is not only feasible, but also safe for the uncomplicated pediatric patients.
So I have the feeling that we're doing ERAS and same-day discharge for much more complex conditions, but then you look at the data and it's not very common, at least in the world, to do a same-day discharge for lab colis. What are people doing here?
Go back and look at the slide. You read it wrong.
I read it wrong? Simple
What did you read?
Also, apparently our case scenario says cholecystitis, and we're doing an article. So we always meant to do simple cholecystitis?
Yeah, no, it was an uncomplicated cholecystectomy.
So apologies for that, but is people doing here same-day discharge for lab colis? Yes. Yes, everyone. So opposed to as the rest of the world. Cool. Should we keep going?
So,
any comments? This is not working anymore.
You have to aim it here. No.
Sorry.
Dead. I can do it. Hold on.
So we have time to do.
I'll start talking.
Yeah, go ahead.
Finally we come to our round 4, the operator's dilemma. And this is a question of who is best suited to perform uncomplicated cholecystectomy in adolescents. Maybe this is a sensitive subject, considering that there are different realities, especially in the audience, between are we trained as a general surgeon and afterwards as a pediatric surgeon, or directly as a pediatric surgeon? Do we work at a pediatric center or a hospital with both adults and peds specialties? So the question here is, we have a 16-year-old adolescent presenting with uncomplicated symptomatic cholelithiasis to the ER, and there are both adult general and pediatric surgeon available at your center. So usually, who really performs this cholecystectomy at your place?
So A, of course, is going to be me. This is easy peasy. B, me, but I asked the adult surgeon to be my assistant in case it gets difficult. C, usually they end up with the adult surgeon. D, neither. The bosses take the prize. So we have some poll results, and 2/3 it's me, which is, I think, pediatric surgeons. Of course, in the US we have a different situation, as you mentioned, because they all have done general surgery beforehand, so I think it's going to be a bit different. So
let's move on to the next slide. And the evidence from a systematic review cohort from the Pediatric Surgery International from 2024 reviewed over 19,000 pediatric laparoscopic cholecystectomy, and they concluded that for simple cholelithiasis, A higher operative volume is the key determinant for favorable outcomes. And the high operative volume, they round it up in adult surgeons. So there's a statistically significant reduction in postoperative complications and a 30-day readmission rates when they are handled under these high volume surgeons. But they also doesn't take away the critical role of pediatric surgeons. The systematic review explicitly recommends that for more complex children with special needs, such as, for example, they name hemolytic disorders, they say that the participation from the pediatric surgeon is the most important one. So here, the most important conclusion is that it doesn't matter if it is an adult surgeon, pediatric surgeon, is whether is which surgeon is the best suited for the specific patient. That's in long term the conclusion of this paper.
Cool. So should we go through the take-home messages?
Yeah, the take-home messages, if you don't remember anything from what we speak today. So index admission cholecystectomy is up to 2025, should be the standard for acute cholecystitis. In terms of antibiotic prophylaxis, consider the antibiotics. They reduce the SSI risk, but keep it narrow. Cefazolin is your best choice. The ERAS principles, they apply for pediatric cholecystectomy and complicated cholecystectomy. And early discharge is safe, is feasible, so trust about it. And surgeon selection, peds, adults, it depends on your personal capacities, your personal expertise, your institutional scenario, of course, and collaboration and patient-based decisions always wins.
Thank you, Rodrigo.
So thank you very much for your attention. I'll give the mic. You already have it on your hands. So any other comments or questions?
I think we're good. So thank you so much for, sorry you couldn't make it here, but thanks for doing this. All right, we are done. It's been a great day, night, morning, whatever time it is. We got a lot accomplished, a lot of new facts in one day. So I want to thank everybody. Good morning, good afternoon, good evening, and we'll see you next year. Thank you.